Anyway, so Dilip and me and Ankit and all those people whom you're going to be is seeing on the stage, lighting the lamps, are people who have worked together. So the thicks and thins with agreements and disagreements, but working all the same. It's very difficult to run a home. It's very difficult to run a team. And we know how we do. And it's spectacular, whatever it is. Yeah. So let's start with the lamp lighting. Ankit, can you lead everybody there? How will I forget those people who have traveled all here absolutely on their own, have been on their own since yesterday? Ramesh sir, may I invite you? And you are going to be floored looking at him.
In the morning when I gone to MCA, I just, when I saw him and I was like, I was welcoming Tamil Nadu CM. So,
yes. Dinesh, can you take the photographs? So now you know the CME is absolutely informal. Amrita, Kriti, Jayal. I'm calling on everybody who has been our alumni. Karthik, please be on stage. May I call upon a person? There are few people who just selflessly help and they are around and they always will be there to support you. May I humbly invite Gayatri on the stage? Gayatri is a consultant and the chief in Ramakrishna Mission Hospital, and I also work there. The entire team works there, in fact. So actually, she has been here as a silent supporter, and 1 week is left for her, incidentally. So Gayatri, thank you so much. Well, then I won't punish you all standing like that. Well, then just a bit of what we are going to do for the whole day. We are going to come to complications. Before that, we are going to go to communications. So how do we communicate? And if there are complications, how do we communicate even them? And then, of course, by the way, we are going to address the nitty-gritties of managing each and everything that comes our way in the most practical and pragmatic way that we could. So that's how we are going to spend our whole day today till 4:30. And I assure you, your participation is extremely welcomed and we would love to hear your comments and your thoughts. So our journey would take you through certain critical soft skills through skits, thoughtful simulations. Our simulators are on the way and they would be here very shortly. And we are going to deep think into intraoperative management challenges by certain quintessential cases. And we are going to be holding you in a promise. We shall promise you to that we keep you all engaged all throughout the day and not a dull moment here. So this starts with the first lecture, and my co-speaker is Dr. Sohini.
So the first topic is empowering preoperative education. So we'll be talking about preoperative evaluation, as well as investigations, NBM status, everything. So first an overview, then the history taking, pre-op examination, NVM, investigations, and pre-medication. These will be the topics. So just why is this so important for us?
Why is it so important? That's because we as anesthesiologists, we have a chance to speak and patients have a chance to get something else. So let's look into that. We'll look at the aspects. In-depth patient insight and first interaction. That's pre-op for us. So, okay. You can hear me out, right? Well, so crucial for understanding the patient and planning anesthesia. And that's the time where you can give a gist of what sympathy and sensitivity is. Well, from the patient's aspect, we set expectations. We receive from the family the questions they want, and we give a comprehensive overview of what anesthesia and surgical process is. Communication and building trust. So we alleviate apprehensions and we ensure safety of anesthesia. Not ensure, but at least reassure, because ensuring safety is something that we do as a team. That includes everybody, the surgeon, the intensivists, as per the case. And we do address at such times the concerns, the questions, and the patients receive assurances from us. Well, education and information and gathering information. So these are the pillars of a pre-op history taking. Yes. Well, Kriti, I think there's something happening here which doesn't enable me to go ahead with the slides. So is something there that we can stop doing right now? Wonderful. I could have gone ahead speaking with you all, but there is a video that I need to play and I'm waiting for it. Yeah, sure. That's the reason why we are two. Yes, I'm all you required with the cap of yours. How many of you all are hardcore pediatric anesthesiologists? How many of you all are occasional pediatric anesthesiologists? What are the rest of you all? I'm using all my tactics to keep them engaged. You better have this running. You stand here and we watch. Okay, now, no, take it. No, don't give the thunder away. I want them to see.
Video.
Yeah. Okay, now, yeah. Don't count my timing of the lecture now. This has to be reduced. That kind of increases the suspense, right? What's coming out. I was never so happy to see my own self. I haven't yet. Okay.
Hello.
That's not holding him. So this is one example of history taking, and I'm dying to show it to y'all. All right. So you can see that this is a counseling room, and I had borrowed Neil's isolation room in the PICU to shoot this. And here we go, and pray that this video works. Okay, now, yeah, no, take it. So you know who the father is, the mother is, the child is Niharika. You're soon going to spot her.
Okay. Hi, Dr. Where are parents? Yeah, okay. We're actually really nervous about the anesthesia part of the surgery. And I think she's a bit scared around doctors. Why is she so scared? I mean, it's our first time going through a surgery with her, so I think we're a little nervous. Okay, what is the surgery? What is the surgery? So she's going for a dental procedure. So we're actually concerned giving her general anesthesia at this stage. Okay. No, just leave it to us. That's okay. That's okay. I mean, is it safe for children to have anesthesia? Of course it is safe. I mean, what is the problem? I mean, I've Googled certain. I am there. Don't worry at all. I am practicing for the last 25 years. I am there. Don't worry. Come on. Okay, I'll get a pre-medication for her. What?
When you give her the anesthesia, what will be the information?
You know, I have a long history. And I do not have all the time to answer questions. All I can tell you is, I'm really a senior person, you know, I'm practicing for the last 25 years. You don't really have to worry. Come on, have some positive attitude. Okay? Yeah, pre-medication. I'm going to give her a pre-medication right now. What is pre-medication? What is
But ma'am,
we're really concerned. Yeah, I understand. Oh, come on. I mean, you know, you cross the road when you're concerned. It's fair. This is something major. I'm trying to understand. But, you know, I just told you. It's like crossing the road. Okay? Fine. I'll get the pre-medication. And I'll talk. Yeah. Okay, now.
This was terrible, wasn't it? I mean, nobody behaves like this. Nobody must behave like this, whether you're a senior or a junior. Would you all agree on here that this was terrible? Yeah? Now let us set it right, because this is one history taking absolutely horrible things. All right. So something that one should never do. Now history takings, which is probably set right, there is no limit to being right. But it's just my job to probably put up as much as right as I can.
Hey, how
Please just come.
Fine. Nice to know you're fine. True. Do you know who I am? No. I'm your doctor, Auntie. My name is Dr. Vishali. Okay, I'm your Dr. Auntie. Fine? You're scared of Dr. Auntie, aren't you? I understand. Okay, just a quick brief for myself. Although I've been told, what is she really posted for? What is her operation? So it's a dental procedure. Okay. Okay, how old is she? She's 5 years old. Okay. So that it has to be under general anesthesia. Yes, my dear. Your old is not on cooperative sales. It's understandable. Well, weight. She's 15 kilos. Okay. So we're actually just a little concerned because, you know, giving general anesthesia for a dental procedure, we get dental procedures all the time under local. So, I mean, isn't really that necessary. And what are the side effects of anesthesia? Okay, sorry, what is your name? Oh, my name is Sophie. Okay, I understand, Shenoy. I understand where this is coming from. Yes, your first aspect of getting it done under locally is quite all right, provided the little one cooperates, and the little one is not going to cooperate, it's going to open her mouth for injections and stuff like that. So maybe that is why the dentists have felt so. Coming to the safety of general anesthesia, actually, I must say that it is safe. It is reasonably safe. However, what I can promise you is 100% from my end. And I can say that, yeah, it should be good. Let's keep a very nice attitude and conversation. Yeah. Anything about her you want me to know? Normal birth? Let me just make it easy for you.
Yeah.
Birth was normal?
Yes, this is a normal.
Cried immediately after?
Yes.
Anything about her from birth until now that you want me to know? Any hospitalization or any kind of surgical procedure? Anything with her health?
She was hospitalized about a year back just for a fever.
Okay.
But other than that, nothing major. No other surgeries or anything.
At birth, I think she was there for the therapy.
Oh,
Okay. Okay.
right
Okay.
after she was born.
Oh, I quite like him remembering the birth phototherapy, huh? Yes, yes, wonderful. Okay, so nothing after that. Overall, a very happy child, huh? He's just listening to me all throughout. I'm sure she's happy. All right. Okay then. Now that I know anything from your end, you want this.
What will be her recovery post the anesthesia?
Maybe children recover in a different manner. Some get up cranky, some get up asleep, some get up in between. She definitely is not going to look as the way she is looking now. She is going to be a bit different, but recovery overall is going to be good, and we are going to feed water in a matter of 2 hours. I know she's listening to me. I know. It's okay. They understand far more than what we think they do.
So she's really afraid of needles. So I don't know how do you give the medicines without training, without pricking?
Dr. Ali doesn't like needle herself. Why is it give it to you? Okay, we'll do one thing. No, I'm serious. I'm not going to give you any needle. We'll take it this way. Let us give her a pre-medication, as in it is a medicine which will put her to mild sleep. And once she goes to sleep, does she like vanilla? Huh? Okay. Vanilla, chocolate, strawberry, chocolate. Okay. So, or we can mix vanilla and chocolate. So, not the medicine she'll drink. I'm afraid that's going to be a little karela. But we'll give you a lot of sugar. 1 spoon sugar. Half before and half after the karela. Remaining Dr. Anshabit. Okay. So after which she's going to really go into a nice, pleasant sleep. And you'll see that change of it. She'll be a little more happy or sleepy, something like that. And then she comes into the operation theatre, which is going to look fab. It's going to look like a pilot's cabin, lot of lights. Okay? You know that. Face blue. Okay, so she'll take some puffs of medicine mixed with oxygen and air, and she'll go to sleep. And then I will take an injection. You will not realize you'll be sleeping.
Yeah, sounds
Okay.
good.
Sounds good? Okay. So she coming to me from your inside also should not be very, I shouldn't use the word traumatic, but inconvenient for us. Neither you. She shouldn't be anxious, and I don't want her also to be anxious. That's
So, well, this is what we actually try to do in a pre-op. We've tried to tell you what all questions we routinely ask, how do we routinely explain things. The words can be different, the expressions can differ, the tone can differ, but I'm sure we all here do the same. I mean, I love to see Ankit even nodding to what I say. So yes, that's what we are here for. So quickly, can one of you summarize the learning points that we just learned from? Kiran. Patience. Fantastic. Comfort. Traumatic separation. Avoid. Fantastic. So she really has given you the nutshell. I needed a skit. She just told you in 5 seconds. Okay. So this is what it is. This is exactly what we wanted to say. This was not rigged. It was spontaneous. All right. So there are some differences between adults and peds. They're proxy. The parents sometimes give, but as they grow older, we better be speaking to them and involving them. Even a 3-year-old or a 2-year-old is going to listen to what you say. So mind your words, mind your expressions. Don't attack them. Don't physically, don't no physical contact in a form of attack here. Be patient with them. Fine. I'm not going to go into the details because I've already we both have given you the gist of what is required from history taking. So coming now to straight away, what do you do with the examination? So, Sohini, what would you like to do in an examination?
Yeah, so as we do it normally, so general examination and then a systemic examination. And then there's a lot of things which maybe we just need to see the patient and examine. So that is something which we would have to see when the patient comes to us. In general examination, the general condition of the patient, is he an overall healthy child, playful, temperature, pulse rate, that is the normal examination which we do. And obviously fecal pylorictoris clubbing, cyanosis, lymphadenopathy, and edema. Then systemic, we'll do as per the child. So depending on the age of the child also, cardiovascular, respiratory, abdominal, and CNS. And then apart from that, we would do an airway examination. So in airway, we would have to see the thyromental distance, the mouth opening, dentition, especially in children, we have to see that. Other things that we want to see, ma'am, would come.
Yes. She has told you the science behind it. Yes, that's what we want to see in any child, even the spine for that matter, because most of the time we landed giving caudals. But really, how many times do we really, take the clothes off and palpate caudal? That's not possible. We're going to drive them nuts if you do that. So there is something called an eyeballing in pediatric anesthesia. What we look at, it won't be written in the books, but we can tell you off guard. Eyeballing is while you're talking, you're going to see if the child cries. If the child cries, how he opens his mouth. If he opens his mouth, why do you know that malampati is good enough? How is the child breathing? Is he listless? Is he clinging to the mother too much? Or is he letting you even auscultate? If he doesn't let you auscultate, pretend that you're auscultating the mom, or show how you auscultate the mom and then auscultate the child. So these are eyeballings in one, and all this can happen in just
Recording
one
in progress.
and towards the kid, of course. And if possible, playfully hold the hands and see if you can locate an IV. Now coming to NBM status, it's very easy to remember. So 2 hours clear fluids, 4 hours for breast milk, 6 hours of food and cow's milk, and 8 hours of fatty meal. Having said that, we are going to look into something called as guidelines are not guidelines, and how this can still put us in trouble. So the sequence is absolutely challenging this, and let's see how in the sequences. Pre-op investigations, actually we are very frugal here, aren't we? We take the minimum required. We don't, based at the premium, we don't prick them much. It's CBC for very simple and routine surface surgeries, unless the history tells us. We don't really put them through an X-ray unless the history tells us. And investigations, the depth of investigation and the number of investigations are absolutely dictated by the history and the surgical procedure. Let's come to pre-medication. This is again something that we would like to show you.
What she's doing, what she's giving. Okay, what are you going to talk?
What is
I see how troubled she is. No. What do you mean no? You need to know what is there? Yeah, give and I'll tell you everything. Okay. What happened? Are you okay? Are you okay?
ma'am, but she's allergic to pig
We didn't mention. She didn't ask.
Fine. Okay, I'll come back again. I have a place to do. I'll come after.
She just told me now. I look the medicine.
I look. Absolute no.
So this is not what we want to do. We want the pre-medication to be palatable and taken very well. Because pre-medication is about the agent, but it's also about how you do, about the person who's giving it. So let's set it right. And now Niharika and Sohini are going to act very well. They're kind of, going to be in agreement with the anesthesiologist. Let's see how. go.
Recording
So the
in
learning
progress.
is definitely don't attack the child. Definitely don't try and give it in a way that the child is not going to be happy with. You can quant children. You can make them feel happy and give it. That's all we wanted to say. So Hini, what all pre-medications would you use?
Usually we use something which relieves the anxiety or causes the patient to go off to like a little bit of sleep so that they're calm, so that they take the mask well. So we would use like an oral midazolam or maybe a ketamine or something like that.
Yeah. So orally we have midazolam in a dose of 0.5 milligram per kilogram to 1 milligram per kilogram. That's the dose range. It depends on what you're using exactly for and on whom are you using exactly for. A CP child, 0.5 would be enough, but a very sensitive or very anxious child, maybe 1 milligram per kilogram would be good enough. It gives you a time span of around 15 to 20 minutes to act. Dexmedetomidine in a dose of 1 to 2 microgram per kilogram, intranasal, oral, both are good. Advantage, dexmedetomidine doesn't have that key taste which midazolam has. Then there are these are the most common things that we would use. We would use chloral hydrate, but we don't these days. We've left it long back. Ketamine in a dose of 5 milligram per kilogram combined with 0.5 milligram per kilogram of midazolam is a good thing. It might aid even a venous cannulation because it doesn't hurt. However, the child might cry due to the act of venous cannulation, if not the pain. So your conversationalism does work even here. If history tells you, nebulize the child. So the take-home message are very clear. Whatever way you want to, what your jobs are, is transform anxiety into comfort, uncertainty into clarity, both ways, yours as well as the patient, ensure safety, build trust, and prepare young patients and their families for the outcome. It may not be a very good outcome, but we'll have to prepare for that outcome, depending upon the surgical scenario and the medical scenario. Then you just have to evangelize a bit here and get all the information that you want. So this is what we had to tell you about pre-op evaluation and communication as such. I hope we've made our points clear. Thank you. So, now that we have seen the NBM status and the guidelines evoked, right in this lecture, and then there's a huge amount of literature written. However, we are going to look into something that we all are horrified with, the horror of post-operative on-table aspiration. You follow the guidelines, or you may not. I mean, there could be some reasons due to that you're pushed to do it, something like torsion testis. That's something that we might just overlook everything and we may have to rush the kid again. So having said this, I am going to invite one person who's going to hold the entire reins, and it is none other than Dr. Ramesh. Ramesh, sir, here has been a constant with CAS. Sir, you're here. You're going to take my place. Please. Yes, I'm going to call the panelist. Dr. Kiran.
Plan of anesthesia was decided to be under sedation. The IV line is established, premedication with glycopyrrolate MSET is given, sedation is started with midazolam, ketamine, IV propofol is given. Now we are...
The previous slide?
Yeah, just
skipping off so that I'll skip questions here, That's okay. I just want all the people to think at this time that it's, I think, Pradeep, a 14-year-old male, female, which is 65 kilo. I think it's, okay. I don't know. It's Veshi. No, I cannot put anything. What to do? There are some inherent problems with dhotis. So this one. See, I just want to know there are things which is okay. See, it's a perianal abscess. Your plan of anesthesia is sedation. What does it mean? I don't understand that. What is your plan of anesthesia is sedation? I think I feel that perineal abscess is one of the very painful procedure. I don't think we can do under sedation. What is your plan when you go like that? What is your plan in this?
So, as an anesthetist, when we go for any case, let it be a major case or minor case, it is extremely important to discuss with your surgeon as well. Though the perineal abscess, yes, it's a definitely a extremely painful situation. It is important to know from your surgical colleague if it is superficial, if it is deep, if it is going to be extremely painful, if the child is going to need some pack to be kept in, which is going to hurt the patient in post-operative period. So sedation could be a main plan of action, but along with that, taking care of pain is one thing which is extremely important. So plan regarding perioperative pain as well as post-operative pain management has to be decided by discussing your surgical colleague at the same point. So yes, we can, if it's a superficial abscess, maybe we can manage with IV analgesics. And if it is a deep-seated, obviously we will have to go for some definitive plan for analgesia, maybe single shot epidural, or if the child is cooperative, spinal anesthesia.
Let us go to the technical later. I just want to know I think with sedation, Pradeep will agree. Is it possible to do the
So I think he's already animated the point as to what kind of procedure I want to do. So I am very communicative with my anesthetist. Ankit scares me. So we are very particular as to discuss as to what I should be expecting, what he should be expecting. So we discuss in detail as to what procedure we would be doing. She's already mentioned whether it's a deep abscess or a superficial abscess. Basically, my thing is when I'm doing the procedure, I want the anesthetist to be comfortable. As we see, we are dealing with a 14-year-old, slightly obese kid, 65 kg. So I want him to be absolutely comfortable. At the same time, given anesthesia, wherein I get a comfortable patient during surgery as well as after the surgery. The choice of anesthesia, I leave it entirely up to the anesthetist here. I would not try to say whether it's sedation, you want to give an LMA or anything. Secondly, with regards to the position also, for this patient, perineal abscess, I would give a lithotomy position so that the airway, he's got complete control over the airway. Sometimes, if it is a gluteal abscess, I wouldn't mind giving a lateral position. But again, entirely depends on the anesthetist if he or she is comfortable.
Well, Pradeep, I'm very happy to tell that everyone will agree that no one is so cooperative like a pediatric surgeon like anybody else. So I think that's very important. No one discuss about this with anybody else. That is one of the reasons I become a pediatric anesthetist, because we don't feel that we are apart different roles. See, in their conferences, we are all there. Yesterday, I think Dilip was there in the PETAL meeting, and we have been there. So I think the surgeons and the I can tell in a public that none of the branch other than the pediatric surgeons are so respective of the anesthesiologists. That is very clear with me from the beginning of the last public.
The reason being, when we were general surgeons, okay, we were not so accommodative. Okay? But when we do pediatric surgery, we realize that you're not the most important person there. I feel personally the anesthetist is more important than me.
Yeah, I think everybody should feel like that. But let's see. But that's all right. I think that's a very important message. what is present as far as I understood, it is the ketamine, which is 50 milligram is the analgesic as far as this is concerned. And I'm not sure whether Pradeep, why do you want prone position for this? See, we are having so much. Why you never mentioned either lithotomy or lateral, but why you only put on prone, right?
First, let me clarify. I was not the surgeon.
Oh, sorry for
Disclaimer.
that. Sorry for that. I thought.
But I would put them in prone position only if I hate myself, hate the anesthetist and the
Sorry,
entire.
I didn't know that you.
So I think, no, jokes apart, I think it's a very dangerous thing to put in a prone position because I don't think you are in control of the airway. And especially a perineal abscess, if it is a perineal abscess, it is not a superficial abscess, it's a deep abscess. And sometimes it goes up to the intersphincteric plane. Sometimes there may be associated fistula in ano. So I consider fistula, perineal abscess to be a slightly bigger procedure than a routine abscess. So, I mean, prone position will be quite dangerous for the airway.
I was not very sure. I thought you were the surgeon. I thought I will, so it's okay. But so I don't know. Why do you put on prone position? I'm not actually questioning her technique and all this thing, but I want to, very curious to know why they put prone position, obese child, you are thinking of someone, then why do you want to prone? I hate putting obese prone position. God, even for scoliosis surgery.
Okay. So, when the way sir said, it's a close team and surgeon and anesthetist, we are working together. Let's forget the aspect that patient has come for perineal abscess drainage. None of the procedure is minor or major. A obese child who is coming for some surgery where we need to put the patient in prone position. Accepted, agreed, maybe it's a surgical requirement. But at this particular point of time, as an anesthetist, we may think that, okay, now we are putting our patient in prone position for whatever reasons. And yes, now maybe this is the time where we should take care of airway. The way we had decided, now let's just hold the mask, let's just give sedation and go ahead with the procedure. Maybe this is the time where you should really think, do we have to put LMA? Do we have to put tube? Do we have to secure airway from a point of view that there should not be any emergency thing which we may have to deal with? So maybe at this particular time, point of time, as an anesthetist, we may have to change our plan a little bit. So moving ahead, now the procedure is done and a patient was turned supine. We are getting our patient back to normal. And suddenly she started coughing and she vomited. Her saturation is dropping from 80% to 60%. Then she was turned to lateral position, suctioning is done, her spontaneous breathing is started. Slowly, her saturation, which was dropping, it is improved and now it's somewhere around 90 to 94%. Nasogastric tube was inserted, suctioning is done. Now patient is spontaneously breathing, conscious, but she's coughing consistently. And without oxygen, her saturation is falling somewhere to 85%. So we are continuously giving her oxygen supplementation by mask. Nebulization is carried out. Still complaining of chest discomfort. There are bilateral crepes, those we can see now. So the patient was shifted to ICU.
I just want to know at this level, previous slide. No, I think that you had, it's a very prone, this is a obese patient, put on prone, then you're put in a supine, and then it's the oxygen requirement, and it's not really minor procedure, but it's okay. But there's dropping. And you were, did you call what do you think at that time, what is happening? And shifting ICU, I understand that it's okay. What do you think is happening? Did you get anything done at that time, or what is your thinking at happening?
Okay, so a child who is in lighter plane of anesthesia, the airway is not 100% secure. Child has and somewhere analgesia is not completely taken care of. This is the time when the little bit of gagging is obviously going to cause vomiting, and since the protective reflexes are not completely back, there are chances that child might have aspirated some amount of it. Now, since the child is coughing actively, I may not think that it's a copious amount of fluid or whatever aspirate content that is gone into the lungs. But what happens is every patient, every lung is going to react to the matter, which is the foreign particles which are going into the lungs. Every is going to react it differently. We really don't know what the content is, what the acidity is, what the volume is. So thinking from the point of view that this patient may need little more ingestion, little more support, respiratory support, we plan to shift the patient to ICU.
Did you call the intensivist at that time? What's happening? Did he come to the operating room? Or what is
So-
because he's keeping quiet. I can't ask him to keep quiet.
No.
The surgeon is going to be blamed.
No.
That's it.
So,
Don't have a surgeon anyway. Don't worry about it. Okay. So, I want to know, Neil, what is we have been communicated that the child is going to shift. What is in your mind? What is going to do? Did you come into sometimes? They're going to ventilate now.
So when the intensivist is called into the OR, it's usually not a happy situation, right? And when it is something unplanned, as in you expect that post-operative somebody is going to be coming to the PICU, that's fine. But if it is an unplanned thing, you get this sudden rapid call, please come fast, please come fast. You usually know that there's something which has gone a little haywire. Now, just one point in this, the volume or the content of what is aspirated doesn't matter at all. What happens is is how you react to whatever may be aspirated. So you could aspirate a few drops, you aspirate saliva, it could be acid, it could be actual food particles. It doesn't really matter. What the intensity of your reaction is going to differ. So sometimes we have this feeling large vomiters will cause more aspiration, less vomiters will cause less aspiration, less severity, will settle down faster. There is no proof of any of this happening. Yes, you get called to the OT. Situation. It is usually a situation which you need to just go and get everybody to take a calm breath, take control of the situation, figure out, prepare the ICU team. There's an unexpected PICU admission. Be prepared that you would have to speak to the relatives about them being in this kind of state, and just go and going into the OT in that situation. The only thing we're going to look at is how secure are we as far as the airway is concerned? What are the details of what surgery has happened? And what is a reasonable expectation about the timelines we would need to look for, and what are our immediate priorities as far as oxygenation, etc. are concerned. And try to get people, be a mediator between two people blaming each other for what has gone wrong. Usually that is practically what the anesthetist and the surgeon are doing at that point of time. Once people start thinking, it is the end of your career and all of these. Some of these are takes precautions to avoid something like this happening, but there's plenty of instances of patients like this reaching the ICU. So that is something we're usually used to. It's not that big a deal.
Oh, is this I just want to, is this the X-ray of the child? When was it taken? This is the X-ray of the child in short.
So this,
when was it taken? After the incident, when was taken? How do you think? What do you interpret as far as the X-ray is concerned?
So it just looks like a messy X-ray. From what I don't exactly recall, we had a pre-operative X-ray in this kid, but this actual X-ray findings are, we look at how much the child is struggling to breathe, and the first Dr. Kiran mentioned that with only oxygen, this child is not maintaining saturation. We need something in addition to oxygen. It's not only a pure oxygenation failure. It is something in which there is a ventilation perfusion mismatch going on, and something in addition to oxygen is going to be needed as far as support is concerned for this child. So just this, an acute right-sided significant haziness diffuse across all of the lobes, along with not maintaining saturations even on a good oxygen delivery device, is something which we look at this point of time. Very suggestive acute event. Doesn't look like there's something going on for a long time. Those are the parameters we work with at this point of time.
We'll just finish with the last question to Dr. Neil. Do you think that comes to you on saturation is going up? Do you think that because you've got some tube, suck out whatever is possible, or you want to continue with a non-invasive ventilation or something like that particular time?
So two reasons why. One, this putting a tube, very often it is a liquid which is chemically aspirated deep down. No amount of a tube is going to get something washed out. So there is no advantage of a tube over something else in this situation. As in putting in a tube so that you can suck out something doesn't happen because it's already gone deep down. and that is going to be causing oxygenation issues. It is not only a main airway tracheal problem. So you're not going to be able to suction out even with the tube. The second situation is, I think, a little practical. In everybody's eyes, intubation is regarded as a big event. So in this situation where neither the relatives prepared for post-operative ventilation nor the surgeon nor the anesthetist, it needs to get everybody to understand you want to hope that it is not, it's bad to give a trial of non-invasive while obese. Those are things which as you're not giving anesthesia would settle down. So we would need to look at deepening sedation analgesia for this patient with an invasive ventilation. A trial of NIV, I think, is fairly warranted in this situation.
I think that's fine. I think we're just sort of finished right now. I think what I have learned, I don't know how many people, what I have learned as far as this particular 20 minutes of time is that, number one, I think it's important to communicate with the surgeons and then what exactly do. Second, if there's a prone position, if the things are saying, I think our anesthetist should say, no, this is not the right child to be put on a prone position. It's our thing that it should never do that. I think that's a very important. Third is that whatever the volume or thing it can aspirate, probably the history, whatever it tells, may not be correct. So you must be very happy. And fourth is that your involvement of the ICU, PICU should be little early. Don't cap at the end of it, and then when they are in arrest, then call the pediatric ICU. Then they cannot do anything. I think it's important to communicate them with early, so that sometimes I also, because that's very, very few centers probably where I have a PICU will be next to our theater with not. So we call, if there's availability, you call them, and then we always call into the operating room, tell the situation, whatever it is. They assess exactly what is. Many of my children, I think that. Lochana and Gokul at the back, many of them we have called them ICU. They've resuscitated successfully than what we could do by the intensivist. I think that makes a lot of difference. We have a lot of children getting them into the operating room. They know the situations and then they proceed with that. Than to hand over that what really has happened. If they have seen them inside, they'll be able to manage better if I'm wrong. Okay, thank you very much.
Thanks, Ramesh, sir. Thank you, Neil. Thank you, Pradeep. And Kiran has deliberately planted certain words in the way this case was presented so that it does evoke questions and it does evoke controversies. So I do all of you have gotten at least a wee bit of a clarity on this. Actually, this case is something that discussions can go on for a very long time. But we just wanted to kind of spark a kind of a thought process into you. Oh, they all disappeared while I spoke because I wanted to give you all the mementos. So please be on the stage again. Yeah, I know. How they listen to me, don't they? We'll start from Ramesh sir because he's the most traditionally dressed man today. Pradeep Shenoy. Neil. Kiran, for you. Yeah. Now don't keep this for yourself till you speak. Okay. Dilip, do I have the liberty to announce that Professor Jim Fehr is here? Can we have him on board? Well, Professor Jim Fehr
is the anesthesiologist in chief at Lucille Packard Children's Hospital, Stanford University School of Medicine, and his interests lie in pediatric anesthesia.
That's the simplest introduction that we can give about Professor Jim Fehr. He is the current president of the International Society of Pediatric Anesthesia, very fondly called as SPA, that is SPA. The last occasion that I met him was in ASPA, which was conducted in Seoul. And with this very brief introduction of ours, I wrote to him once if he could be here virtually, although, and he really did not take much time to agree. And he said that the topic guidelines are not godlines is something that he is really excited to speak on. So over to you, Jim. I hope you can see and hear us. Lovely. All yours.
Yes, I can hear you fine. Can you hear me?
Wonderfully well. Clear as crystal.
Excellent. Namaste, everybody. And Zippy, I see you somewhere in the background there. Nice to see your name.
Thank you. I'm here.
Greetings. I'm Jim Fehr, and I'm going to speak about guidelines are not next to godliness. I want to begin to say I have nothing to disclose, nothing in my pocket, nothing hidden away. And I want to thank Dr. Rushali Pandey, who is president of the Asian Society of Pediatric Anesthesiologists, and the ASPA meeting organizers for this kind invitation to speak. First, who am I? I appreciate that very kind introduction. My background when I was a kid, I went to medical school at the University of Michigan. And then I went and did an internal medicine and pediatrics combined residency at Baylor College of Medicine. That's in Houston, Texas, famous for Dr. Cooley, Dr. DeBakey, and a lot of early congenital heart surgery work. I decided not to work in outpatient clinic, but to become an anesthesiologist. So I went and did anesthesiology, pediatric anesthesiology, and pediatric critical care at Johns Hopkins in Baltimore, Maryland. Worked with some big names in pediatric anesthesia there. I needed then to get a job, so I went to Washington University in the middle of the country on the Mississippi River, St. Louis, and I worked in pediatrics and anesthesiology. Worked as a pediatric cardiac anesthesiologist in anesthesiology and a pediatric cardiac intensivist in the Department of Pediatrics. Over the time, I also developed and ran the Pediatric Simulation Center at our Children's Hospital and became the assistant ombuds, which was kind of like the complaint department of the School of Medicine. Currently, as of August 2019, I became the chief at Stanford, the anesthesiologist in chief at Lucile Packard Children's Hospital, and the division chief of pediatric anesthesia. And then finally, since 2014, I've been a member of the board of directors of the Society for Pediatric Anesthesiology and became the president of that organization last October 22. I actually met Dr. Gathuya there. And I'm delighted when anybody can come to the meeting. Dr. Gathuya was our international scholar back in Texas, as I recall. This lecture is going to be about guidelines. I'm going to describe what are guidelines. I get confused myself. And there's a process the guidelines are developed. I want to touch on that. Discuss a few, about 4 or 5 different types of guidelines we find in pediatric anesthesiology, some of which I worked on, and that others, and then a controversy in pediatric anesthesia about NPO guidelines. Thomas Aquinas said that cleanliness is next to godliness, which is a bit of a riff off this title of this talk is a riff off of that, or vice versa. Aquinas was a 13th century theologian, a philosopher who believed that godliness was the highest moral value. And the second was the cleanliness of the body and the soul. It's a picture of him there, and ablutions, the washing of one's self and in spirit, whether in the Ganges River or a baptismal font, is a component of many religions. Judaism, Islam, Hinduism, Christianity, and many others have a component of washing and being clean. There's a professor at Tufts. I found her comment about this. She's more of a sociologist, it seemed, or was studying world health and had this interesting brief article in Africa Health Sciences back in 2005 when she was the Lucy professor at Tufts. She noted that kind of said that cleanliness is next to godliness, but many physicians do not bother to wash their hands after touching contaminated objects. She also noted that hygiene is derived from the Greek word for health, and that many people in the world have limited access to clean water and good hygiene. And I agreed with her. The reason I include this is I agree with her statement that that is neither good nor godly, that we don't wash our hands when we touch patients and between patients, and that people in this world don't have access to clean water and good hygiene. I personally think that's a basic right that people should have, and we as humans need to do a better job of that. We have a traditional practice adage that is attributed to Dr. William Halsted, who was the first surgeon at a very esteemed surgeon at Johns Hopkins back in the day. They would say, see one, do one, teach one. And there's a picture from 1904 in Johns Hopkins where he is operating, surrounded by Harvey Cushing, the father of neurosurgery, and a number of others. I have a little problem with that. He's far more brilliant than I am, but if you're seeing somebody do something wrong and then you do it, you're going to do the same thing incorrectly, and you'll teach the next person incorrectly, which is why the cross-pollination, and here we represent 3 different continents.
Hello, Jim.
Yes?
Hello, I hate to interrupt you. Could you please share your slides with us? Could you please share the slides?
Oh my goodness, I'm not sharing slides. Ay. Thank you, thank you.
Never mind, we're getting what you want to say very clearly. However, we would love to see your slides.
Hold on one second, I so apologize. I'm a boomer. That's embarrassing. Okay, I'm going to start over. Here we go. This will be very quick. There we go. I was wondering why I could see it so quickly. So this is the introduction. Thank you, Dr. Ponde. This is who I am. This is more who I am, what I'm going to talk about. That's Aquinas. That's the Ganges. That's somebody in a baptismal font. This was Dr. Professor Almedam. And this is Dr. Halstead. And Dhanyawad to Dr. Ponde for pulling me out of my own incompetence. But we're anesthesiologists. We do that. We miss the airway. We turn around. We get the airway. It's all good. So in the adage of see one, do one, teach one, if somebody's doing something incorrectly, like me doing share screen wrong, then we will then copy them incorrectly. We will copy them correctly doing the wrong thing and teach our next person that. So we have an obligation in this. I love this cross-pollination across multiple continents where we learn from each other. I think this is profoundly important. Dr. Ignaz Semmelweis was a Hungarian physician and scientist who pioneered aseptic procedures. Again, prior to his time, people were doing things incorrectly, that is, not washing hands. This was 2 different clinics. He noticed the ones that were using the chlorine wash for their hands had lower rates of puerperal fever. And he instituted the chlorine hand wash throughout. And at that point, which is about 1847, the rates went down from 30% of the patients or so down to just a few percent. This was not widely accepted by English physicians in the UK and others initially because they didn't completely buy into it. Again, seeing the way they were doing it, what they were demonstrating in their actions and teaching was problematic. Joseph Lister of the Fellow Royal College wrote on the antiseptic principle of the practice of surgery about 20 years after Semmelweis, The ideas of Semmelweis had spread throughout the world, and the benefit of hand antisepsis was described by Lister about reducing nosocomial infections. That said, about 150 years later, with the germ theory well understood, many physicians still don't practice proper hand hygiene. And in general, doctors have poorer hand hygiene than nurses. That's a problem. So I guess what I'm saying is we should wash our hands. And I'm also saying that I'm asking a question, is washing your hands a standard? Is that a standard of care? Or is it a policy? Is there a policy that we're supposed to wash our hands? Or is it a procedure? I mean, I wash my hands, that is a form of a procedure. Or is that a guideline? Where are we in this spectrum of ideas? Or is it just a good idea? I think it is a good idea. I think it is something that should do, a procedure we should all do. There should be policies and standards about this, and guidelines should reinforce that. So what are standards? The Institute of Medicine in the US talks of standards of quality. Standards are statements of the minimal acceptable level of performance or results, what constitutes excellent performance of what results, and the range in between. So the minimal standard, the most excellent that we can do, and everything in between are the standards that we work out of. Whereas medical or clinical practice guidelines are systematically developed statements to assist practitioners, that could be physicians, nurses, in their decision-making in specific clinical situations. It's kind of a roadmap. It helps us understand what we're doing and why we're doing it. A few more definitions. Policies are written standards by which an institution manages its affairs and meets its missions. At Lucile Packard Children's Hospital, sitting behind me, we have many policies. Some of those are about medical illness. Some of them are about behaviors and how we're supposed to treat each other. There certainly are ones about hand washing. Procedures are the documented operational processes which support implementation of the institution's policies. Indeed, if you go to the neonatal ICU, you have to roll your sleeves up and wear no watches below the elbow or any jewelry below the elbow to protect the neonates. And it'll say exactly how long the procedure for washing your hands before you go into the NICU. These are important components of the care of our children that we come in contact with. Guidelines give recommendations, interpretations, instructions, best practice guidance, or frameworks in which to operate. Guidelines are informational, they're not necessarily mandatory, and they change with the organizational needs. Consider it a map. When the roads change over time, you have to have a new map, you have a new guideline. So again, what are guidelines? They're statements that include recommendations intended to optimize patient care based on a systematic review of evidence and an assessment of the benefits and costs of alternative care options. This is from Mark Nunley and Jeff Applebaum that looked at, this was from an editorial on a paper I'll cite, and Anesthesiology 2021. And these editors noted that these commentators implied that most guideline recommendations are not supported by the highest level of evidence. Now, again, they're referring to this article, Guidelines in Anesthesiology, Levels of Evidence Supporting North American Preoperative Care Guidelines, the systematic review of 2,280 recommendations and 60 guidelines published by a major North American and European society. Half of the recommendations were supported by low-level evidence. That doesn't mean they were not valid, but there wasn't a strong evidence base to them. And that's critically important. That's where some of the godliness is lost from the guidelines, because there's kind of a devil baked into some of them, because we go by that they are absolute truth, and they may or may not be. Guidelines in anesthesiology, I anticipate this is probably a little hard to see, but I can get my slides to Dr. Ponde later. guidelines, when you're creating evidence-based medicine, a guideline has to be built out of the evidence. And as you know, randomized controlled trial would be the gold standard. And that would be in this schemata, a level of evidence of A. And then it drops down to B and C, C being only expert opinion or case studies or standard of care. And the strength of the evidence could either be very strong or very weak. And there has to be a sorting of data when you're looking at it if you're coming up with guidelines. Otherwise, it's like in the newspaper, an editorial piece. You're just writing down your opinion, which may be better or may not be better than somebody else's. The one thing that's probably true is you think it's better. But again, if you're doing something incorrectly, all you're doing is teaching the next generation a bad pathway to behave, and that helps our patients not at all. So learning to grade, this speaks of the grade recommendations, which I'll refer to. They basically tear apart studies in order to look for the truth in them and then reproduce it in a grade, give them a grade, A, B, or C, and then plus or minus if it's strong or weak evidence. And that allows us to sort through the wheat, if you would, and the chaff, the detritus of what we're looking at and for. The American Heart Association produces many guidelines for the last 100 years. And these guidelines help doctors understand the best ways to diagnose, treat, and even prevent diseases and conditions. These guideline recommendations are based on the strongest available evidence. And I included this to show you the pathway that it takes. Guidelines that are well done do not come out quickly. It takes several months to half a year to get things going. A writing committee comes together for several months. And then over the next year to year and a half, the committee members review the evidence based on the grade methodology or another methodology, and then takes another 3 to 4 months to codify that and then spit it out as a guideline that is published. This is for the AHA, but this is very similar to others. And they're looking at essentially 2 years from the point that you start looking back in time at the literature to finishing a guideline, including incorporating any information that comes out in that 2-year period to keep it as absolutely useful and current as possible. Now, guidelines can be dirty. Going away from godliness. If godliness is next to cleanliness, then dirtiness is probably not very good. And guidelines can also not be very good. And why? Because there can be conflicts of interest that exist for members of those panels that create guidelines. In fact, it's been looked at, and the range has gone from high 50s to 87%, where there is a conflict, a financial conflict of interest by those who are creating the guidelines. Guidelines can be compromised by industry funding. It's like product placement in a Bollywood movie. It's no longer necessarily about what's best for the patient, but what's best for the enterprise. That is a very slippery slope, and I think we need to be very careful to guard against that, because the industry does not necessarily have either your as a practitioner interest at its best stake, or especially the patient. And it's the patient that we fundamentally serve at the end, not General Motors or Tesla or some other big company. And then guidelines can be compromised by the biases of members of society creating them. And that could be gender biases, that could be racial, that could be religious, it could be any number of things. And again, if we are stuck in our biases, then we're unable to see what is probably closer to real truth. Guidelines also inform medical malpractice. In the US, there's 4 components of malpractice. A professional duty must exist between you, the physician, and the patient. There must be a breach of that duty. Injury must be caused by that breach, and damages must occur from that injury. You can fail to put the endotracheal tube in the airway. That in and of itself is not malpractice. If you recognize it, take it out, replace it correctly. If you don't recognize it, and you leave it in place, you now have a breach of duty and injury can occur. Injury leading to brain damage is a perfect example of where the endotracheal tube's put in the wrong place and injures the patient, causing brain damage. That is medical malpractice that the person will have to defend themselves against. Guidelines can help establish the standard of care, and in medical malpractice suits, and this can be in the US, in Europe, in India, guidelines can be used as a reliable authority by lawyers to defend the physicians in lawsuits or to demonstrate a breach of the standard of care has occurred. They also have limitations, and this is important. They may not always be applicable to individual patients. You are not taking care of an entire village when you're in the OR with one patient. You're taking care of not an entire population, but a single patient at a time. Even in the ICU, each patient has a different phenotype, genotype, and a clinical experience that led them there. And guidelines guide us, but just like a map, they can lead you off the wrong pathway for a given patient. Well, what guidelines do we have for pediatric anesthesia? Where do they come from? The ASA, American Society of Anesthesiologists, is a big producer of guidelines, as well as the American Academy of Pediatrics, and I've mentioned the AHA. SOAP, the Society for Obstetric Anesthesia and Perinatology, the American Society for Regional Anesthesia, and the Society for Pediatric Anesthesia, my favorite, because I happen to be a loving member of that. I'm going to touch on this SPA very quickly and talk about the critical events checklists. These are important because they are built out of, if you would, others' guidelines to provide a product that any one of you could download. If you go to this website, pedsanesthesia.org, and look up critical events checklists, you'll see they come in multiple languages. And what they are 26 checklists that are updated with the most recently available evidence and guidelines. They focus on what a pediatric anesthesiologist would need to know to manage an emergency in the perioperative period. This is an example of what they look like. Again, they are corrected and done in various languages, and these are updated periodically, twice a year, and then a more significant update occurs. This is one example, one page. Again, there's 26 of them. So the one that says cardiac arrest, this is one of the pages for that. And it allows you to go through all the data coming into this is built out of guidelines of which is basically pediatric advanced life support, or adult ACLS, or the literature to make sure that we are including correct information and updated information. There's also an app that goes with this. It's either on Droid or the iPhone, and you can search PD Crisis app with that little red symbol, those two little kids, and you can download that. Like the events checklist, it is updated periodically by a group, and it's available in both English and Spanish. Once downloaded, you can use it on your phone. I have it on my phone, and it is something that is useful in an emergency when you're away from other technology. What are some guidelines germane to pediatric anesthesia? There are guidelines about pediatric sedation, traumatic brain injury, ICU sedation, pediatric inpatient intravenous fluids, and clear fasting, clear liquid fasting, MPO. Guidelines for pediatric sedation. This is an important one. It's built out of guidelines from the AAP and the American Academy of Pediatric Dentistry. Dr. Charlie Cote, well-renowned pediatric anesthesiologist, and a pediatric dentist, Dr. Stephen Wilson, took those guidelines from those two organizations and brought them together with the purpose being to update and unify the sedation guidelines used by medical and dental practitioners. I find them very useful, but I also find them a bit like opinion pieces. These guidelines are a thorough review of the literature and are provided in readable form. There's almost 450 or 500 references, and they're a sensible, descriptive, expert opinion and a distillation of the literature. I want to point out there's no grading of the evidence. So it's basically Charlie and Stephen coming from the mountain saying that this is truth as they perceive it at that time, which is okay. It is described as a guideline. It is a guideline of sorts, but it is not thoroughly vetted in the sense of a grade methodology where they went through all the specific components of what they wrote about. This doesn't make it bad. It just means you need to be careful when you use the information. Traumatic brain injury guidelines, however, there's a most recent third iteration of these, have level 1 through 3 recommendations, similar to the grade of high quality to low quality body of evidence. I pulled one table. Again, this is found in neurosurgery. It was produced in PCCM, Pediatric Critical Care Medicine, and Critical Care Medicine Neurology, in a number, because there were so many people who contributed to creating this guidelines. They're chronically updated. Dr. Kohanek, the world famous pediatric intensivist at Pittsburgh, was the lead on this version with Robert Tasker from Greater Ormond Street. And I just pulled up one of the tables looking at thresholds. The level is level 3 for treatment of intracranial hypertension and thresholds for cerebral perfusion pressure. So they list the level they think that targeting less than 20 millimeters of mercury is very reasonable to improve overall outcomes. But they also note that this is based on relatively low level evidence. This is a fabulous way of looking at that type of information and getting a big sense of it. There was a grade review of the literature guiding sedation and management of patients in the pediatric ICU. This was done by critical care organization. In my role, the SPA, I got to be involved with it. Ultimately, there were 44 recommendations, 14 considered strong, 30 not so much. And they ultimately pointed to unanswered questions that required further evaluation and identified topics requiring further investigation. So basically, guidelines can give you a working product for your own patient, but also for our colleagues who are clinician scientists and investigators, give them a roadmap of what we need to be studying and investigating further. In these sedation guidelines for the PICU, it essentially was able to produce and this was graded, but they put it in tabular form and a table such as this that allows you to see whether pain, sedation, or delirium, how to assess it, what risk factors, what complications, what management are for neuromuscular blockade, iatrogenic withdrawal syndrome, and PICU environment and early mobility. This took many years to run. I think it went back to 2014 or so when it started and was finally published in 22. I was also involved in this AP-sponsored maintenance of intravenous fluids guidelines. This was created by a multidisciplinary team, including intensivists, nephrologists, emergency medicine anesthesiologists, nursing, and again, grading methodology was used, ABCD down to expert opinion with strong or weak evidence. And all the literature was investigated. What came out of that was essentially one guideline, one recommendation that patients 28 days to 18 years who frequently were receiving hypotonic IV fluids, they should receive isotonic fluids with appropriate potassium, chloride, and dextrose, because that significantly decreases the risk of developing hyponatremia and some untoward impacts from that. So this was quality, evidence quality A, recommendation strength strong, and this is the optimal that you would get from a grade methodology or a review and creation of a guideline. This was in pediatrics in December of 2018. And then the American Society of Anesthesiologists, as I said, if you go on their website here at Standards and Practice Parameters, you'll see standards such as basic anesthesia monitoring, post-op and pre-op anesthesia care. You'll see guidelines, you'll see practice advisory and alerts, statements such as came out during the COVID pandemic, and expert consensus documents. Not all of these are guidelines. The guidelines are guidelines. And they are often not all that useful for pediatric anesthesiologists. One of the recent ones was about pediatric pain, which was very well appreciated. And one of the other most recent ones was this very controversial one for pediatric anesthesiologists. It came out last year from Joshi et al. This was the ASA's NPO guidelines, where they were looking at, and I only can pull out one piece salient to pediatric anesthesia here, addressing the question of clear liquid fasting duration for children. They used grade methodology, and very low evidence to support was found for 1 hour versus 2 hour clear liquid fasting. And for that reason, they came up with a statement, which was a bit controversial for pediatric anesthesiologists, that to avoid prolonged fasting in children, efforts should be made to allow clear liquids in children at low risk of aspiration as close to 2 hours before procedures as possible. In children with shorter clear liquid fasting duration, exercise clinical judgment. This was actually a lot of work to get them to say this. They wanted to just say no 2 hours or longer for clear liquids. But there were many institutions in the US, in Canada, in the UK, and Europe that were moving for 1 hour or had moved to 1 hour. And as president of the SPA, I pushed, and Sol Soriano was on this, this committee and this publication to gently move them to allow some wiggle room, as close to 2 hours as possible. Could be 2 hours and 15 minutes, but we were really alluding to 1 hour and 45 minutes or 1 hour and 15 minutes. And at Stanford, indeed, we have gone to 1 hour. And it doesn't mean that the kid has gone 1 hour. It's usually an hour and a half or 2 hours. But we are finding that there are fewer 6 or 8 or 10 hour periods. The nurses are more attuned to it to make sure that they get clear liquids. In that Joshi paper, this includes the number of studies, and there just was not a lot of studies. And I point this out mainly to show the strength of evidence for 1 versus 2 hours was very low to low. Only 1 was low, everything else was very low. So this does create a controversy because the European and Canadian societies have crafted guidelines themselves in favor of 1 hour clear liquid fasting. As well, several large children, much larger than Stanford's Children's Hospital, such as Boston Children's, Texas Children's Hospital, CHOP, have shifted to 1 hour clear liquid fasting. And bottom line, there's a spectrum of differing viewpoints that exists amongst pediatric anesthesiologists regarding 1 hour versus 2 hours of clear liquid fasting. And a guideline will not change that. If the SPA was coming up with a guideline that said 1 hour, some individuals would shift over for the guideline and other individuals would not. So some concluding thoughts I have on guidelines are really two. One, like caveat emptor at the marketplace, let the buyer beware. If you're reading a guideline and using it, you have to do that with caution. It was created by humans and humans make errors. And you can use this as a map that can get you where you need to go to take care of your patient, but use clinical judgment at all times. And second, primum non nocere, first do no harm. So at the end, I've described the guidelines, how they're developed, touched on a few from pediatric anesthesia, and touched on the NPO guideline controversy in pediatric anesthesia, which I don't see going away anytime soon, and is basically impossible to study because it's a natural experiment that has moved on. I want to thank you for this opportunity to speak, Dr. Pandey, and the meeting organizers, and appreciate you very much.
Thanks, Jim. Am I heard? Am I heard to you? I'm sure I'm heard in the auditorium.
I do hear you.
Thank you. Wonderful. So we got your reflections, we got your own thoughts, we realized the caveats that you want us to be aware. And what I am particularly intrigued is you actually searched into the Ganges and you've taken pictures that would allure us. So thank you so much for being here and here to further friendships. And I want you to know that here is a team called Children's Anesthesia Services who has taken up the whole thought process and initiative of having the CME on. This is for your information because I just thought I haven't told you enough about it. So thank you for being with us. You may be online. That would be lovely, but I know it's late there. So good night to you. Any questions to Professor Jim? All right. Yes. Here is a very astute senior anesthesiologist in the auditorium called Dr. Satish Kulkarni, a very dear friend of mine. He wants to know what are your takes on protocols. What are protocols?
Protocols, my take on a protocol is a description of what one must do in a specific, generally order to accomplish some goal. And that goal could be to achieve adherence to policy, but the protocol will define how we do that. In other contexts, it could be in a research format where there is a strict protocol, or based on research that has been done, considered cancer chemotherapies for children. They are entered into protocols, and there's a very strict mechanism, not a guideline, but we need to follow that in order to protect the care that the child is getting. So protocols are, and I appreciate the distinction that you're touching on, Dr. Kulkarni. They are something that you need to adhere to much more strictly or thoughtfully. Guidelines are very important, but not necessarily need to be followed so strictly. Thank you for that question.
Okay, so we move ahead, and the next topic is dangerous parts, neonatal intubation failures. First of all, intubations are difficult in neonates, and then the failures. By say, may I have Zipporha on the line? Zippy, could you show yourself?
I'm
Hi, Zippy.
right there. Hi.
Hello.
You can see me?
Yes, very well.
Thank you.
Hi, Zippy.
Hi, Jim. Nice to see you. And nice talk.
May I call upon the stage Dr. Dilip and Dr. Ankit.
Dr. Zipporha Gathuya is a pediatric anesthesiologist at the Nairobi Hospital in Kenya. Her interests lie in pediatric anesthesia. Dr. Dilip Chavan is the course co-director and director at Children's Anesthesia Services. His interests lie in pediatric anesthesia. Dr. Ankit Desai, founder-director of CAS, is affiliated with Surya Hospital, Wockhardt Hospital, BHC, Holy Spirit, Holy Family, and several other hospitals, is interested in the pediatric airway, regional anesthesia, and focus.
Dr. Zippy, can you hear us?
Yes, I can hear you.
So,
I can start.
yeah,
Do you want to share the slide?
Yeah, I'm doing that.
As he shares the slides, I want to say thank you very much to Frushali and the whole team for inviting me. It is a very great honor to be here and to be part of this. So we're talking about communication, and our topic is on neonatal difficult airway. And we'll start by defining what is a difficult neonatal airway or intubation. So it can be defined as inability to effectively bag mask ventilate or inability to intubate. And this can be caused by two main things physically. The first one is inability to visualize, as may happen with some congenital conditions such as Pierre-Robin syndrome, or the inability to pass the tube. So you can see the cords, but the tube cannot go in, as may happen with subglottic stenosis. However, next slide. There are other things that contribute to failure to secure the airway, and these are things that we can do something about. And they include the team, who's the people on the team, and what is their skill sets, how well do they work together, what equipment do you have, and how adept are you at using this equipment, and the communication between the team members. How well do they communicate? If we are many people trying to intubate and I have the laryngoscope, am I able to say, oh, I can't see, I can't see the... Sorry, somebody is asking for the slides to be shared, but they are being shared. Sapil, can you see the slides?
Yeah, it's good. Yeah, we can see the slides, madam. You can go on.
Okay, so you can go back a bit.
This one, madam?
The one before, sorry.
Yeah, we can see the slide, madam. You can, yeah.
Okay, next slide. Next slide. Oh, they're running so fast.
This is the slide, madam. Your first attempt is...
Yes. So, what contributes to success of in securing the airway? Your first attempt is your best attempt. So you need to be very well prepared with your skills, including communication and leadership, with escalation. Who will you escalate to? How will you escalate? And before you start, you can check what roles have been given to whoever is in the team, the equipment that you have, you check that they are working properly, and also check the patient factors. Are you expecting a difficult airway, or are you not expecting a difficult airway? What positioning are you going to put? And those kind of things that will be important for you to succeed. So next slide.
Yeah.
So you need to be very careful about your areas of interest, and I'll hand over to the next presenter.
Yeah. So I'll be discussing the topic in these, these are the points of our discussion. These are slightly we are trying to understand what all things can go wrong in a pediatric airway and trying to formulate certain principles on which we'll be managing a pediatric airway. So the areas of interest are preoperative assessment and preparation of the child. Second is what medications would you use to put them to sleep so that you prevent a difficult airway or a CICO kind of a scenario. That prevention is, remember, prevention is always better than cure. So we want to prevent cannot intubate, cannot ventilate kind of a scenario. Techniques and algorithms also we'll discuss. We'll discuss identification and treatment of difficult airways. Then next is how do we confirm a successful tracheal intubation. Tracheal extubation is as important as an intubation. So we'll discuss that. And there are certain human factors which lead to errors, which we will be discussing. So in preoperative assessment, what is most important is in this age group, history is very difficult to obtain. So you have to rely on certain signs like micrognathia, retrognathia. They would prelude to a difficult airway. Limited mouth opening is another sign. Facial asymmetry can be a patient may have facial asymmetry, which can lead to a difficult airway. Fixed cervical spine, oral or neck masses. Certain syndromes like Pierre-Robin, Treacher-Collins, they are prone to difficult airways. Here, one thing that is of importance is a volumetric CT scan can be very helpful, like in predicting a difficult airway. This has saved us in a number of scenarios. MRI is very difficult to do in these age group because they need a lot of sedation or something. So CT scan is very useful for these kind of scenarios. So coming to pharmacological management, there is a level 1B evidence that sedation and general anesthesia is required for this. We all know that in pediatrics, you cannot do awake intubations. Awake intubations are a thing of past now. So with the advent of newer drugs, sedation and general anesthesia is more important. And neuromuscular blockade do aid in our intubation. So here I would like to ask Dilip sir and Zippy madam, what induction agents would you prefer in a difficult airway kind of scenario? You are aware that it's maybe a difficult scenario. So would you prefer sevoflurane, propofol, ketamine, etomidate, or opioid? So what agents would you prefer?
Zippy, would you like to answer this question or should I answer?
Okay, I can go fast and then you add. So for the neonate who does not have an IV line, I'll probably use sevoflurane controlled and keep them breathing spontaneously for some time. We don't have etomidate where I am, and I tend not to use opioids. If I have a line, then I'll probably go for ketamine.
So usually, clear-cut message or experience what we have. Yeah. So I feel that whether in the neonate, whether you have an IV line or you don't have an IV line. So crystal clear in the difficult airway or even in the normal neonate, what we can do is that inhalational induction is one of the best choice, and that too is a sevoflurane. So it helps you any IV drug if you give, and then if you're not able to ventilate or if you're not able to go ahead with the intubations, then you are in a great problem. So I feel that the clinical experience and the whatever the evidences which has is experiences that the sevoflurane is one of the most important inhalational drug, what we say for a neonatal intubation. So you can intubate without the muscle relaxant. Also, we can make patient be enough under the sevoflurane, and then you go ahead with the intubation.
Yeah, so the principle over here is to give the shortest acting agents. So that is what will save you. Like in a case where you face a difficult intubation or a difficult ventilation kind of a scenario, the principle is to give an agent which is like the shortest acting, so that you can awaken the patient in case any difficulty is encountered. So for that reasoning, sevoflurane would be the drug of choice. Another thing I would like to mention is we have remifentanil available now. So, and there are models available even in neonates, even premature neonates. You have models like Eleveld, which is available with remifentanil. So remifentanil is another drug which you can use for sedation in these kinds of scenarios. And it's like a short-acting agent. So besides sevoflurane, I think remifentanil would be another agent which would be like an agent of choice. Also, like remifentanil, if you see the enzyme systems, remifentanil enzymes, the esterases are very well developed even in neonates. So remifentanil metabolism is very quick even in neonates. Whereas if you see propofol metabolism generally comes up after 6 months of age. So propofol in this age group doesn't act like a very short-acting agent. So that is why sevoflurane and remifentanil probably would be our choices for these kinds of scenarios. Now coming to relaxants, what relaxants would you like to use? Scoline, atracurium, rocuronium. What is the preferred relaxant? Dilip sir?
Yeah, usually if we required if you require the give the muscle relaxant, normally what we prefer is an atracurium. But in case of difficult situation, what we can use is the rocuronium, where we have a sucamadex available, so that if you face any problem, so we can just reverse the patient and then make the patient on a spontaneous. Yeah. So what,
Dr. Zippy, would you like to comment?
In my practice, we rarely use muscle relaxant for intubations in the neonate. But if we need to, again, we don't have Sugamadex free or rocuronium freely available. So we do succinylcholine and add glycopyrrolate or atropine, whatever you have available. We try not to use atracurium because then it means it's a longer acting, and you have to, if you're not able to ventilate back, it becomes a challenge for us.
Yeah, so scoline we are all afraid of using in the pediatric age group because we are worried about unknown malignant hyperthermias, etc. So atracurium was always our go-to drug. But with the advent of Sugama-Dex, now rocuronium-Sugama-Dex combination can be a good choice for relaxants. In many cases, we have started using rocuronium now. Although one word of caution over here is Sugama-Dex FDA approval is from 2 years of age. Although a number of case reports off-label use of Sugama-Dex are there, but FDA approval, US FDA approval is from 2 years of age. So tracheal intubation, VL scopy versus direct laryngoscopy. What is your view? Which one is better?
Actually, the video laryngoscopy gives a good idea of the intubation. So even with the assistant, he can explain you that where you can do the intubation. So nowadays it is better to have a video laryngoscopy because a lot of in the clinical practice we have a good number of the sizes blades are available, so that you can it helps you to go ahead with the easier intubation. So that is what.
So that is the evidence also. Most of the evidence shows that VL scope is better than direct laryngoscope. There is level 1B evidence that VL scope is better in the supine position, and 1C evidence that VL scope is better over direct laryngoscopy in the lateral position. So VL scope is taking over now, and VL scope should be used for all your intubations is my take home message over here. There are Miller blades also available for this particular age group with VL scopes. So that is what is coming up. Apneic oxygenation is something that is very important. We always think of airway in the anatomical terms, but physiological management of the airway is as important as anatomical management of the airway. So there is level 1B evidence now that apneic oxygenation is very important. So you have devices like Thrive, etc., with the high flow nasal oxygen, which can be used. Even your bubble CPAP, etc., which are available in the NICU, can be brought to the operation theater and they can be used. They help in reducing your safe apnea time. Also, you have now those video laryngoscopes like AirTrack, TrueView, Oxyport, etc., which have a oxygen port attached to it. So you can attach oxygen through that. And if you give apneic oxygenation, the apnea time, the hypoxia time is reduced very much, although it can cause some hypercarbia, but apnea time is definitely reduced. So now this concept of physiologically difficult airway is what is coming up now. So we have to understand that what is different in pediatrics. Ideally, in a difficult airway scenario, ideal management would be to keep the patient awake, do the case under airway blocks, and do it without putting the patient to sleep. But this is possible only in an adult patient. This is not possible in the pediatric age group, and that is where our problem starts. So we put the patient to sleep, and that is the reason we face these issues. So asleep patient, use of relaxants, coexisting hypoxia, hypotension, and metabolic diseases, all these prelude a patient to hypoxia. So understanding this physiologically difficult airway is as important as understanding the anatomy of the airway. Now coming to uncuffed versus cuffed tubes, sir, what is your choice for this age group?
Yeah, definitely the cuffed tubes are the choice because in the market the better tubes are available, micro cuff tube. But situation, if it is there, both the tubes are uncuff or cuff tube are fine with the for the intubations in the neonatal.
Dr. Zefi, which ones do you prefer, cuffed or uncuffed?
We're just starting to use cuffed tubes, and they're actually quite good. But both are okay. In most of our NICUs and ICU, we still have only the uncuffed tubes available. But we are encouraging to move to cuffed tubes.
So with respect to cuff tubes, one word of caution is that cuff pressure monitoring, especially if you're using nitrous oxide, is very, very important. So you have to do cuff pressure monitoring in all cases, and cuff tubes are not available for premature babies. So in those babies, you have to use uncuffed tubes. And as far as literature is concerned, the evidence regarding the use of cuff versus uncuffed tubes is the same. So you can ideally use both. So what is the unanticipated difficult intubation in neonates and infants? By definition, it is 2 failed tracheal intubation attempts. We cannot overemphasize the use of supraglottic devices in this particular scenario. So LMA should be your go-to device in case you are facing any hypoxia or any difficulty in ventilation. So there is level 1B evidence now regarding the use of LMA as a rescue device. So there is no such gold standard for a difficult intubation scenario. There is no one solution which fits all. So we have now direct laryngoscopes, we have VL scopes, we have flexible bronchoscopes, and we have rigid or semi-rigid bronchoscopes where we can use hybrid techniques for your intubation. So the idea is to limit the number of attempts, and the best possible attempt should be done by the most experienced person, as Dr. ZP has already mentioned. So with VL scopes, we have the use of
something there.
Yeah, madam.
I wanted to you must think about what are you going to do differently before you make the next attempt. Whether that is changing the person doing it, changing the position, but you must actively think about what are you going to change at the next attempt at intubation. That will increase your rate of success.
Yeah, absolutely, madam. So with VL scopes, we have even VL scopes with Miller blades available. There are some hyperangulated blades as well, which are available. Coming to bronchoscopes, a flexible bronchoscope will remain your gold standard, especially when there are scenarios with less mouth opening. But flexible bronchoscopes in this age group have certain limitations. They have a limited field of view. There is interference if there is bleeding and secretions, and only the tip can be manipulated. So many times in patients with a good mouth opening but an anterior larynx, this kind of hybrid techniques can be used. So this is a rigid bronchoscope over which you can pass an endotracheal tube. These are available even in smaller sizes. 2 number can take a 3 number or a 3.5 number tube. With that, the angle that you get for your insertion is slightly different. So this can come to your rescue in many scenarios. There are scenarios where I have used a cystoscope over which a tube has been loaded. So if you don't have a rigid bronchoscope available, if ENT surgeon is not available, but the pediatric surgeon has a cystoscope available, over that you can load your tube, and the angle that you get is slightly different. So that can be a go-to device in case you face this kind of scenario. Now coming to front of neck access, sir, what is your thinking? What is best tracheostomy? So we have 3 options basically: tracheostomy, surgical cricothyrotomy, and a needle cricothyrotomy. So
definitely, see, there are modified techniques which are available till if the expert person is not available for the tracheostomy. But what you can do is that what clinically, what we have a 20 gauge cannula, and then you can attach the needle, the circuit, the tubes connector over there, and then you can join the circuit. So that is what in an emergency situations. In neonate, there are no cricothyrotomes or the sets are available. So you can have a modified thing till you have the definitive treatment like a tracheostomy with the expert person which is there. And then
it's actually the same.
So basically,
to a needle and then connect it until you have a tracheostomy done, which will be your more definitive airway, front of neck airway.
So surgical and needle cricothyrotomy, if you see in older children up to 8 years, surgical cricothyrotomy is what is recommended over a needle cricothyrotomy, because needle cricothyrotomy comes with its own sets of problems. Like you can go beyond, you can perforate the posterior part of the trachea. There can be bleeding with needle cricothyrotomy. it can be used as a temporary resort, but tracheostomy and surgical cricothyrotomy are the two best resorts. In neonates, tracheostomy is the best resort, and it is to be done at a slightly lower level. Also, you have to remember over here that identification of the landmarks manually is a challenge in this particular age group. So use of focus and ultrasound is very important to locate your cricothyroid membrane. So that is also something you should remember. Now, this is a case which Dr. Dilip has done. He will describe the case.
Let me brief about this case. Is that this was just a newborn baby. You can see on the left of the screen, and so this was a 2.5 kg child, and then I got a call from the intensivists that they are not able to intubate this child. So till then, I told them that like I was on the second floor, and then till I reached the theater. So the important point was that there are a few take-home messages in this case which I would like to share for each and every one of us. That I told them that not to get panic. I said, okay, you ventilate. Okay, saturation, which is like almost 80 or in between 80, 90. So within a minute, I reached in the one thing before, as in a few minutes back when we said that the supraglottic devices, which are most useful thing one has to have in your clinical practice, has to be available from the smallest size till the bigger size one. So what I did was like I just inserted an LMA, which you can just this was the LMA insertion, and then the saturation came. So we have ample of time to think that what need to be done. So what I did, the saturation came up, and then I did a good DL scopy, video laryngoscopy, which was done. And then I realized, if you see this one, is that there was a complete glottic closure of, you just see. So one thing was kept in the mind that now need to see ahead with the further. So again, LMA was inserted, and then the further course of action which was decided. So if you see the sequence of event in a panicky situation, would have happened, the patient would have decided, somebody was like try to intubate multiple attempts. So he said twice or thrice he did an attempt. I said, okay, fine. Then we did an LMA insertion, and then we go ahead with so we did a tracheostomy of in this child. And then if you see, then we did then a bronchoscopy. So we saw. So if you see, this is the feeding tube which is there, and then from the front, like at the end, so where you can see. So this was the tracheostomy tube until it went just above the carina. So this was a laryngotracheal cleft case. But the point or take-home message here is that do not get panic, even this sort of situation which comes. Think what you have to do. So one thing, rescue device, always keep in mind that if you're not able to intubate, just keep the handy the supraglottic device, and then you go ahead with the definitive treatment. So if you think in a peaceful manner or in a better thought, so sequence by sequence, if you go, then definitely you have a good success in these sort of cases.
This is the second case which I had done. This was in a day 3, day 4 child with anorectal malformation. He was posted for a colostomy because he was obstructing. So everything was normal. There were no signs that it was a difficult airway. Ventilation was good. We had already given atracurium. And what happened was we was not able to pass the normal. I opened a 3.5 tube, then 3, 2, 2.5, 2, even 2 number tube, which was the smallest size available, was not like passing through. So the ENT surgeon, we called the ENT surgeon. ENT surgeon was not available immediately. So what we had to do was, since I had already given atracurium, we put in an LMA, we awakened the patient, finally like ventilated for half an hour. And finally the patient was like awakened. As then a CT scan was done. It was found that he had a subglottic stenosis on the CT scan. Then ENT surgeon was available. He tried to do a bronchoscopy, and there was a very tight subglottic stenosis. He was not able to pass even the smallest tube. And then subsequently a tracheostomy was done with an LMA in place. So this kind of scenarios you do face in private practice, and you have to remember that subglottic stenosis, etc., can be there even with a normal ventilation kind of patients. And the role of supraglottic devices cannot be overemphasized. Now coming to the last point, which is confirmation of tracheal intubation. ETCO2 may not be, ETCO2 is our gold standard. It may not be reliable in certain scenarios. Like if you have, say, an arrest scenario where ETCO2 will not be available. So in that we have now focus available with us, which comes to our rescue. So what you can do is keep your probe over here and you can see the tube passing in. Another sign is a lung sliding sign. So it has been described as a 2-point and a 3-point technique. So first point is over the trachea. You put the probe over the trachea and you see the tube passing in. Second is over the lungs. You see the lung sliding. It means your tube is inside the trachea. Extubation can be awake or deep, especially if it is a difficult intubation. Then the role of nebulized epinephrine has a level C, 1C evidence. There are human factors available, which can be errors in judgment, skill, inexperience, etc., which can lead to these kinds of scenarios. We have to remember that. This is a difficult airway algorithm, which we do not talk about normally. This is given in BJA 2024, where they have recommended the use of video laryngoscope as a first resort and not a DL scope, even for a clinically stable patient. So video laryngoscopy should be your first resort with the current practice. And you have to remember that you have to limit the attempts to 4. So that is the time when you will decide to awaken the patient. So 4 attempts is maximum what you can do. So this is the article. This is a 2024 article. It's freely available. This is what we should go through this. And focus, which we already mentioned, I think focus has a very important role in airway management now. So it can help you in assessing the airway pre-op. It can help you in locating your cricothyroid membrane. It can help you in ruling out causes of hypotension. Hypotension, we said, it preludes to a physiologically difficult airway. So all your causes of hypotension with your IVC measurements or Vexus scoring, or there are a number of measurements of hypotension which are available with focus. We can use that. And volume status also can be done pre-operatively, because a hypovolemic patient also preludes to hypoxia, like a quicker hypoxia in the perioperative period. So that is, Dr. Zifi, can you just conclude?
So in conclusion, we say that it is not rare to encounter difficult intubation in neonates, but a lot of the things you can do something about. So we encourage you to be well prepared and anticipate trouble and have a plan what you're going to do in case you get trouble. Thank you.
Oh, thanks. That was wonderful. And the to and fro. Yes. Anila wants to put a comment. Mic to Dr. Anila. Professor Anila.
3 to 4 comments to make.
Please.
I think it's a high time that we think whenever we have a difficult airway, there's no question of not putting an IV line. If we are expecting a difficult airway, see, the babies are there in the NICU, PICU, in the wards. How many of us are going and sedating and anesthetizing? They in and out, they are taking IV line. Then why so much hue and cry about taking an IV line in the awake state? I think it's a high time we should take an IV line if we are expecting a difficult airway. My second comment is about the neuromuscular blockade. I have encountered quite a few of Pierre-Robin syndrome, where there is a difficulty in intubation and all. So now with the supraglottic devices available, either we put a Prosil or a iGel, if we are able to ventilate nicely with the supraglottic device, and then if we give a relaxant, usually in our cases, we do give atracurium. So after giving the relaxant, the job becomes much easier rather than just struggling with the thing. Okay, we can have a further discussion on this. My third comment is, in neonate, the thyroid membrane is hardly 2 millimeter. It's not possible to do a cricothyroidotomy. It's very difficult to see even with the ultrasound, and it's a very, very thin one. So it's definitely not advisable. Obviously, we need to go ahead with the surgical tracheostomy. And my fourth comment about that most of the neonates whom we are getting, at least in our government setups, BMC setups, are less than 3 kilos in the weight, except some of the congenital diaphragmatic hernias who are more than 3 kg. Most of these neonates are less than 3 kg. And the manufacturers have not recommended use of microcuff tube below 3 kg. There are some studies, there are some reports available. But if you see even the case report defining a lot of complication has again gone against that manufacturer's recommendation and have encountered the problems. So I think we have to be aware about it. Okay, we can have a further discussion on this if you wish to.
These were actually the wisdom over a period of years that was coming out from all the ends here. I agree with every point that you have mentioned. I mean, clear as crystal. I agree with the point of focus coming in. There are certain, but probably imagine a theater in which difficulties are going on, and that too with the 2 kilograms. Then there has to be a thought process line, and that's what was the entire idea of putting in these difficult scenarios to you. About the cuff that has been said, different manufacturers are going to manufacture it differently. The external and the internal diameters of each manufacturers are different. For this age group, it is even more difficult. And by the way, the funnel-shaped anatomy of a neonate or a child and the cricoid there itself is a cuff. So if you're using the cuff tube, we need to be extremely aware of that particular point there. And I guess it's a common sense that then works in an operation theater. And the common sense is, as both of them have very properly said, a supraglottic device. Okay. So
can I? Oh, sorry.
Yes.
Can I add something?
Definitely.
About the supraglottic device. Sometimes, especially in neonates, it depends upon what is the reason for the for that you're not able to oxygenate.
Yeah.
Say it's a congenital syndrome like a chaos syndrome or something. Even your LMA will not work.
Sure.
So if you're able to mask ventilate or get some oxygen in, you may not need to put an LMA because the reason for the obstruction or something is a airway obstruction, So LMA will also not work better than the mask in that situation.
Yes, I get your point. But at times, that there has to be a thought process, 1, 2, and 3. So suppose if my mask ventilation is troubling me and I'm not able to put in a tube. So I think I have at least something in my hand till I really think of something else so that it's ready. And if it's ready, at least to pick it up and use. So that's all I'm trying to say. I'm sure each case has its own thought process.
Every case will be different. This was just to stimulate the thinking process and understand what is different in neonates.
Katkede, sir.
Remifentanil, we have very limited experience, but from what we know is Eleveld is the model where there are 2 models available. One is the Minto model and second is the Eleveld model for remifentanil. Minto model is available beyond 12 years of age. Eleveld can be used even from premature babies, 27 weeks onwards. 650 grams, I think, is the cutoff from which you can use remifentanil. 3 to 4 nanograms per ml is what the effective the effect site concentration is what is recommended normally. For these kind of scenarios, 1 to 2 nanograms per ml, I think, can be used. Problem with remifentanil is most of them will become apneic. Even with low doses, they become apneic, although you can just wake them up. So it's a very different kind of drug. So, yeah.
Yes. Now that's something that we would never like in a neonate, more so. All right. So now, yes.
Mask ventilation is a bit difficult with them.
The seal.
That is fast. And then just before insertion of the laryngoscope, we are putting the laser. That's what I wanted to say.
That's a nice comment. All right. So here is, I'm sure you've been here since quite some time, and it's time to tea and shake your legs. So before that, we would like to present a good, nice mementos to both the speakers here. And Zippy, when we meet next, it's due on me to give you this book. See you, and thank you for being here.
Thank you. Thank you very much.
And thank you. Thank you for all the comments. And thank you for being here. We disperse for tea. Anuya to Ankit and Anuya to Dilip. And there are certain announcements. We will need you to download 2 apps, and we shall prime you all about it after the tea break. And the tea break is of 10 minutes. ते पण चेक करूनच जाते मी आता मग.
तो वीडियो ना होता है Pause this code gently. Pause this code gently. Where हाँ बड़ोदर नहीं बड़ोदर हाँ रॉयल पट्टी लाओ प्लस में लगता है सुनिए it is a two anterior का ये ఇప్పుడు నేను దాకా ये two anterior so that's why it is important with your little finger to manipulate five
check, check. Hello, hello. Ramesh, Ramesh, send banana. Check. Hello, 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 check. Hello, 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 check. Hello, hello.
I would encourage all of you to be here seated. If your friends are still outside, I would encourage you all to go and tell them to come in. Please be seated because we start our next session. All right. So next. Okay, I can see the audience trickling in, and thank you, Nandini. I can see you searching for a nice place to sit. I would love to see you here somewhere. Anila, welcome, and welcome everybody back. I hope the tea was good. Okay, here we go. We start. There is a bit of a reshuffle here because our speaker from artificial intelligence is intelligently caught up in some intelligent work, and he shall join us post lunch. So we shall start with a bit of a reshuffle. We start with the cleft lip and palate, that is CLAPS, a quintessential teacher. So may I invite Dr. Parit Ladani, who is a maxillofacial surgeon. Yes. Dr. Anuya, who's our anesthesiologist. And Dr. Sarpil, who is online with us. Before Sarpil really joins in, by the time she joins in, I'm going to introduce you to certain important people who are very pivotal in handling the whole show going on here. They have relentlessly worked for us. So one is, of course, I might have taken his name 1,000 times since morning, Amol. He is the audiovisual in charge here. So Amol is behind the camera. So yes, his... yeah, maybe at the end of the day, things go better, even better. We'll give you a better clap. Okay. Asha is our backhand secretary. She has looked into all the communications and the registrations and stuff like that. I do this so that next time you'll be even better. Yeah. Annie, who's from Holy Family. Well, she is a friend. She's helping today. She today. Dr. Sati, another person who very selflessly helped, and Raju, yeah. And so they have arranged everything which is there outside, and it's my duty and honor to introduce you to them. So, and Ritesh, of course. Welcome all of you, and thank you, so that you can continue with your good job. Having said this, I'm sure we have Sarpil online right now. So can you just put Sarpil online? Meanwhile, yes.
Dr. Zara Serpil Usalar Ozgen is affiliated with the Yakubatum University Medical Faculty Department of Anesthesiology and Reanimation at the Altunizade Hospital in Istanbul, Turkey. Her interests lie in pediatric, regional, and geriatric anesthesia, as well as ambulatory anesthesia. She is also interested in museums, puppetry, and traveling.
Parit, Dr. Parit Ladani, please.
Dr. Parit Ladani, Project Director and Consultant, Cleft. Invest in and ear construction surgeries.
Anuya.
Dr. Anuya Desai is a consultant pediatric anesthesiologist with Children's Anesthesia Service in Mumbai. She is affiliated with Surya Children's, Shushrushah, Criticare Asia, Nanavati, Holy Spirit, Beach Candy, and Virtually Hospitals. She has many publications and has taken several lectures. Her interests lie in pediatric anesthesia.
Okay. Sarpil, can you hear us?
I can hear you, but I cannot see you.
All right. You'll be. Meanwhile, starting, and I'm sure as long as hear me, we are going to hear your answers as well. So the things on the back end worked on. Before that, there is just one scene I really love to watch. So I'm going to share my slides. Yeah, look at this one. And that's what we all do. This is a takeoff. Tells you in one clear sweep everything about pediatric anesthesia is actually a cleft lip and palate. So here is Anuya's case, and this is the objective that she has given me, and by the end we probably would be covering it and then of course talking to each other. He's a 6-month male, 5 kilograms, full term, normal delivery, presented with cleft lip and palate, posted for correction of lip. And we will take him further to palate also for the sake of a completion of discussion. So, Dr. Parit, what would be your actual indications of the surgery?
So cleft lip is cosmetic as well as the functional deformity, because this child has a facial deformity. It's a look problem. Apart from that, they have a feeding problem, frequent nasal regurgitation. They have a speech problem. Later on in the life, they will have a chewing problem. So the indication for surgical correction is obviously cosmetic as well as the functional repair.
Sure. So the cleft lips and palates present all these issues. So, Anuya, would you like to involve other teams as well?
So this would be the multidisciplinary approach. Because the child is going to come for surgery for multiple times, and it involves the pediatrician, it involves the plastic surgeon, it involves the maxillofacial surgeon, it involves dental surgeon as well as the anesthesiologist, and multiple procedures.
To really see them through, right? The dentist at the end to set things right once the anatomy is repaired. Okay.
The child becomes adult, we require dental surgery.
Sure. So what would you really like to look into the history exam? Just tell us your thoughts. Anuya, you're very soft, I know, but you can be a little hard-spoken today.
Yeah. So the cleft lip patients would be very small, like 3 to 6 months old, and the palates would be like 6 to 18 months of age. And so I would like to ask for the birth history, like whether the child is full term or preterm. Then is there any history of airway compromise during the or immediately after birth or in the process of the child is growing, like obstructive sleep apnea or snoring? Or is there any history of repeated respiratory tract infection? Because it's quite common because of regurgitation, and they can have a ear infection as well as the URTIs. So, and this is the elective surgery. So I would like to optimize the patient before we go ahead with the surgery.
Sure.
So like proper physical examination as well as the laboratory test.
Sure. Serpil, anything that you would like to add sitting there in Turkey?
Also, I would like to add that these may have some additional congenital anomalies, so maybe midline anomalies. So cardiac defects should be sought, and if we need the help of the cardiologists, and so that how we will give the fluids and the postoperative care. So we have to know how the cardiac anomaly acts, I think.
Yes. I think you've read just our minds, because we were soon going to come to the associated anomalies along with that. So before that, what would be your airway assessment like?
So for the children, small children, it would be like a clinical examination. When the child is crying, you can MPC grading, but otherwise he would not allow you to examine. Or just for the clinical examination, you can see whether there is a micro or there is a receding mandible, because usually they have a hypoplastic mandible, or the mandible growth is not adequate.
Yes.
And then you can ask the parents whether the child has got a snoring or you can ask whether the child at a particular position, to release the obstruction if he has. So that is one thing. Then lots of toxins. So from the clinical features, you can see whether the child has got a difficult airway. Sometimes like pure Robbins or Tricher cord, you can see the child has got features.
All right. Anything from your end, Dr. Parit?
Yeah, of course. Mainly with income.
Recording in
Would you do that?
progress.
Yeah, because most of the time, there is a possibility when they give the extension that the tube can come out. There can be accidental disconnections also. So when they put the throat back, there could be endobronchial intubation also. So you have to keep a watch. You have to be continuously vigilant, and you have to communicate with the surgical team every time when the positioning is given. One more thing about the mouth gag also. When they put the Dingman's mouth gag, so it could just compress the tube when they open the gag. They have to keep a check on the airway pressure and what the tidal volume is getting delivered. So you have to communicate with the surgeon. If it is too tight, then they can use the needle. They can readjust it to make the ventilation easier. This is a common thing that which can encounter at the
He listens to you say it's the airway pressure is going high. You better lose the Dingman. Does he listen to you?
Yes.
We have to listen well.
All right. Sarpil, anything on your end about fixation of the tube and positioning of the child?
Yes, the importance is emphasized, yes, with our colleagues. The fixation is almost all of the surgery. But regarding the previous talks, the surgeon, yes, should learn anesthesia, but the first thing first is for him, for our surgeons, they have to first learn how to not to extubate the child, not intubate the child. But and also we have to always monitor the end-tidal. And the video laryngoscope is the first choice, I think, for if you have it, because several attempts will harm the airway. So at the first attempt, it could be done with video laryngoscope. If you have, your first choice will be better if you choose video laryngoscopes. And about the throat packs, whoever puts the throat packs, I think they should announce that the throat pack is put in, and when we took it out, we should announce also in the operating room that we took the throat pack. That's all.
I get it. I mean, we all from Turkey and from Mumbai, we all are almost in the same boat. Okay. In the interest of time now, let's jump in, and Anuya and Parit are quite okay with each other, and the Dingman is in place, and they haven't quarreled yet, and things are fine on the monitor. So, and how about the fluids? What do you give?
So I would like to give a crystalloid for maintenance, and it should contain a dextrose-containing fluid, I feel, along with
they're fasted enough.
Yeah.
Even if they're fasted enough, would you like to give dextrose?
It is like you can combine with ringer lactate as well as DNS. You can give alternately, because in the post-operative period, they may be fasting longer, not because you are keeping them fasting, because they may not take adequate fluid in the post-operative period, surgical repair or something like that. That is why you have, there are smaller kids and they are more likely to go into the hypoglycemia.
Okay. Get your point. Fine. Any analgesics that you would like to use?
Okay, so the analgesics would be like IV analgesics, and there would be regional blocks. For IV analgesics, we can give a paracetamol 10 to 15 milligram per kg. You can give for the older children, like more than 1 year of age, we can give a diclofenac, that is 1 to 2 milligram per kg. You can add a opioid also if you want to, 1 to 2 milligram per kg, microgram per kg of fentanyl, and the regional blocks. So for
yes. Parit, anything that you would want to add, because you need a good field to operate?
Local, I think the local blocks and infiltration is very, very important. The local infiltration includes lidocaine with adrenaline, which is like per the dose advised by the anesthetist.
Okay, so I'm just running through the videos because the time is clicking. So these are all, see, if we go for regional anesthesia for cleft lips and palates, it would be another lecture of 20 minutes. So I'm just going to skip all this. I just want you to know that these are the possibilities. A greater palatine block by the surgeon himself, a good infiltration by the surgeon himself, an infraorbital, both the approaches by us for the lip, and of course the beautiful suprazygomatic block. One thing that we would like to share here is our feeding of our children has been definitely the quantum. Could you please share on that?
So in comparison to greater palatine nerve block and maxillary nerve, suprazygomatic maxillary nerve block, we are doing a study and we found that the patient's oral intake is quite better with the suprazygomatic maxillary nerve block in comparison to greater palatine nerve block. They are able to take a good amount of liquid probably same day and the next day. So their comfort level is quite high.
Wonderful. So much for the regional anesthesia. And of course, you're going to write the post-operative pain regime, right, for them and see to it that it's followed. All right. Now you're fine. You've removed the throat pack and the child is awake because that's how you would want the baby to be in. But the baby is howling a lot and thrashing around. So what would you do?
So ideally, for extubation, the child should be awake and should be not coughing or gagging. So you keep the child in the lateral position, make sure that your neuromuscular blockade is completely reversed, the respiratory efforts are good enough, there is no secretions or no bleeding in the mouth. You keep the child lateral and then you can extubate. And if the child is too much crying, then you can think of giving some opioid depending upon the airway status of the child. If the child is syndromic, I would avoid giving it. But if it is a non-syndromic child and if it's breathing very well and there is no compromise of the air, you can think of giving 0.5 to 1 microgram per kg of fentanyl just to quieten the child. Keep in the lateral position with supplemental oxygen. In the recovery, one should be observing the child.
Sure. And any take on emergence in the cleft palate, Sarpil? Anything that you would want to add over and above on what Anuya has said? Anything you want to add?
I totally agree with Anuya. They're all, yes. It's sometimes I use Precedex, dexmedetomidine, if the child is agitated, since I don't want them to cry or and discharge the stitches. And sometimes what our surgeon is thinking about, we put some tongue stitches if the airway is in compromise. If the mouth is so small and the tongue is very big, we use some tongue stitches.
You're probably talking about a just before extubation or even before, say, it's of the tongue and lip we have for the pure carbon syndrome. I would take from both. I would say that I myself have given fentanyl in a very titrated dose in the postoperative period. And of course, dexmedetomidine is known for emergence, but if it was pain, it would be helped by both. Right? Okay, fine. So can I get the slides, please? Because I just want to show one case here, and then we kind of extubate the child. Before that, we remove the throat pack, and then we go to the next case. I mean, the next session. And Sarpil, thank you for being here. Thank you so much.
Thank you for inviting me, and it's nice to see all the Franks there. Thank you for your invitation.
Well, here was a video till it comes up where the child was really howling and it being quieted. However, what we've not discussed is if we take the child out and he keeps on bleeding, that's, I think, another lecture. But Parit, one line on this. Where will you be concerned and where would you be okay?
if there is a continuous trickle coming out and if it's filling the mouth totally, then it's a concern. I would like to take him back to the OT. But before that, I'll
question or two. Yes, Pandey sir, I can't say no to him. So honestly, I have not tried any adjuvants here because they last and he infiltrates as well as we give the blocks. But as any other, the safest here is clonidine again. And probably it might have two purposes, a little bit of sedation because finally it's going to get absorbed. So I see Saroj madam also saying yes, Nandini, yes. Okay. Sure. She said nasopharyngeal airway for airway obstruction. A soft one, yes. Yes, my dear. The suppositories, we always do that. Because 2 milligrams per kilogram diclofenac, Jonac 12.5. I mean, 2 milligrams per kilogram for sure. Yeah. Okay. Yes. Thank you, Paritan. Thank you, Anuya. We go ahead. Anuya has got a book, Parit. How can you walk out without a present? Ankit, and may I invite Dr. Amrita? Our next case is thoracoscopy challenges and controversies. And Dr. Kiran, you please don't leave the stage because you're going to be here. And Ankit, you hold the mic. Dr. Dilip.
Dr. Amrita Rath is the Associate Professor at Banaras Hindu University, and her interests lie in pediatric anesthesia and regional anesthesia.
So this topic is about the thoracoscopies and its challenges and controversy. So before the mic sets in, just let me know about the public. So how many of you are doing thoracoscopy neonates routinely? Okay. So how many of you have heard that that's an option, but that too from your colleagues, but you have not have direct exposure? Okay. And how many of you have ever not even heard of I think that's most of the crowd. Okay. So we begin the session here. Why we have gathered here for this topic is the famous dictum is the neonates are not the miniature adult. And the children and neonates poses the unique challenges during the thoracoscopy surgery. Why? Because of their varied anatomy, physiology. The most important problem is the non-availability of the age-appropriate equipments that is needed for one-lung ventilation, the high chances of intraoperative hypoxia, and a good pain relief in the post-operative period. And at the end, we'll discuss, is there any role of POCUS over here in thoracoscopy? So let's take you to the first case scenario. It's a 2-day-old baby with a history of tracheoesophageal fistula who is optimally optimized, is posted for thoracoscopic repair of fistula. So my first question is to Dr. Kiran, how does the physiology of one lung ventilation in pediatric patient, to be very specific in neonates, differs from that of adult that you are very anxious to manage?
So nowadays, minimally invasive surgery is taking over open surgery. So as an anesthetist, even we need to be getting ready for managing such cases. When we deal with a neonate who is getting exposed to thoracoscopy, we don't only have to manage from neonatal anesthesia point of view, but we need to be little more well-versed with the thoracic anesthesia. So it's the tricky situation, especially when it comes to a neonate who is getting exposed to thoracoscopy. So when we see a neonate anatomically, we all know that the rib cage, which is the main organ of respiration, is not obliquely placed the way it is placed in adults. The rib cage is horizontally placed. So the lungs, when they expand during inspiration, they do not have mechanical advantage of the thorax getting inflated. They don't get much space by movement of the ribs. So the main organ which is helping for lung movement is the diaphragm. So we all know that neonates are belly breathers because diaphragm is the one organ which is helping the lungs to expand. Thoracoscopically, for thoracoscopy, we usually keep neonates in lateral position with the bolster under the dependent lungs. So a rib cage who is not yet mature enough, the ribs who are very much cartilaginous, they are not going to support the lung tissue per se, and there will be obvious compression of the lungs. At the same time, the intestinal content is getting pushed up in this particular position. So again, lungs are at completely mechanical disadvantage when we consider rib cage and the diaphragm. Secondly, hypoxic pulmonary vasoconstriction. This is the main phenomena which helps us during one lung ventilation, which we usually give for a neonate who is getting exposed for thoracoscopic surgery. So the hydrostatic gradient that is established between an operative lung and a dependent lung is not much in neonates when we compare it to adults. So again, we are at disadvantage of this. The neonates, as we know, they have high metabolic rate. So CO2 production is high, oxygen consumption is high. At the same time, lung capacity is not much. The FRC and residual volume, they are very much close to the tidal volume. So the margin of safety is extremely less. So the gist of all this anatomy and physiology is one thing, that the margin of safety is extremely less in neonate. And so to maintain the ventilation perfusion mismatch, the strategy will be changing, and it is mainly of low tidal volume and high frequency.
Okay. So what we can conclude from her that thoracoscopy and especially one lung ventilation in pediatric patient actually is one challenge. Okay, my second question is to Dr. Akhil.
Dr. Akhil, we forgot to introduce. Dr. Akhil is at AFMC, has done his pediatric anesthesia from KEM, and I think he'll be the organizing chairperson of IAPA next year. So the co-secretary.
So as we learned that OLV is very difficult, so can you throw some light? How do you achieve OLV in this unit?
So, ma'am, in a neonate, we have the most practical is to put an endotracheal tube into the main stem bronchus. So we will put a 3-size uncuffed tube and push it into the left main bronchus. Now, the advantage of this is the simplicity of doing this. And we hardly need anything. Only we may need a proper sized fiber optic scope to confirm the endobronchial placement of the endotracheal tube. Apart from that, but the disadvantage is that if the tube is smaller in size, if it does not form a tight seal. So then there would be, if the tight seal is not there, the air will escape to the operative on the opposite side. And there would be the complete deflation of the lung will not be there. That will interfere with the surgery. The other disadvantage is that the blood mucus secretions from the operative side may trickle onto the healthier lung, the non-dependent lung.
I have a question here. So what type of VT do you prefer, cuffed or uncuffed?
So
it's a neonate.
Yeah. So I prefer to use
Okay.
The literature says that in a neonate who is about 2.5 kgs, even in the left side, when we want to put an endotracheal tube on in the right main bronchus, three size endotracheal tube uncuffed, I am saying, would be optimal. But left side, even in it, when you want to put the tube on the left, in the left main bronchus, a three size uncuffed endotracheal tube might also be tight. So that is why I would like to put a 0.5 size smaller endotracheal tube. That would be a 3 uncuffed tube on the left side. If we have to put it on the right side, then probably we can attempt using a 3 microcuff tube. The advantage would be that because it will give a more margin of safety because there is no Murphy's eye and the distance from the tip to the proximal cuff is lesser, because otherwise we will be blocking the right upper lobe, because there is an early takeoff of the right upper lobe from the right mainstem bronchus. And this distance from the carina to the takeoff of the right upper lobe is about the distance on the left side is almost 3 times. Greater.
Here the messages depend on the side you want to go. You have to select of the tube and size of the tube as well. Second thing, do you have the availability of neonatal bronchoscope to check?
At my center, I have a 2.8 outer diameter fiber optic scope. So I don't have a 2.2 size scope. The second option would be putting a 3 French Fogarty embolectomy catheter.
Okay, so that will come later.
Yeah.
Okay. So this is what already you have discussed. For this baby, you are going to pick up 2.5 or 3.5 depending on the size.
It's the Mararo tubes.
Yeah, the third option is, well, these are Mararo tubes. Mararo pediatric biolumin tubes are there. That is also a possibility, but they are not commercially available now. So Mararo biolumin pediatric tubes are they are 2 PVC tubes, one of a shorter length. And ma'am, can you show the previous slide? There's a photo of the Mararo tube. So these are 2 PVC tubes having 2 radio opaque lines, which are joined together laterally to each other. One is of a shorter length, the other is of a longer length. So the longer length tube goes into the bronchus and the shorter length tube goes into stays in the trachea. So the smallest size available is 2 plus 2 internal diameter of the tracheal tube and 2 internal diameter of the bronchial tube. And the distance, and there is the thickness of this tube also, which is 0.1 millimeter of each wall. So the minimum size would be 4.4.
They are not available commercially.
They are not commercially available.
Okay, the next question is to Dr. Kiran. What are the important intraoperative monitors that you will consider for this neonate?
So a neonate coming for any kind of surgery, non-invasive monitors like a routine ECG, pulse oximeter, non-invasive blood pressure monitor, temperature are the things which will be needed for any neonate. Since it's a thoracoscopic surgery which is going to take for a while, we would like to monitor urine output as well. But the most important parameters are the respiratory parameters. So EtCO2 is one thing which needs to be monitored. Something called as permissible hypercapnia, which we need to follow in these patients where the safety margin as well as surgical comfort level is achieved. If we are using mechanical ventilation, then peak inspiratory pressure is one thing which we need to take care of. So recommended is 10 to 15 centimeters of water. But at the same time, if we are using pressure control ventilation, we need to keep close eye on how much tidal volume is getting delivered, because during intraoperative period, the peak pressures are going to fluctuate quite frequently. To achieve good minute ventilation, higher respiratory rate of around 35 to 55 breaths per minute.
Okay, may I interrupt you? Dr. Dilip sir, can you tell me if, because as the neonate, when we create the pneumo, so obviously EtCO2 keeps on rising. So at what margin, till what safety margin you do allow your surgeons?
So there are 2 ways of the monitoring. One thing is that if there is a good one lung ventilation is there, then usually the surgeon, they don't create a pneumo. But But if you the ventilation is not properly happening, one lung ventilation. So maximum what our clinical experience is that they start with the two pressures, and maximum what to maintain the hemodynamics of is that we maximum we can go up to 5 millimeter of pressure. That is what we do. But almost like 90% of time we have a good lung ventilation. So it's not really required to create a pneumoperitoneum.
So in short, if a good one lung ventilation is given, then you don't need to create a pneumo. And pressures wise, whatever is recommended for your pneumoperitoneum, generally the surgeons would put around 2 to 4 centimeters lesser in the thoracic cavity. So it's generally lesser. So if in the neonate, if for pneumoperitoneum it is 6 centimeters, that they go up to 4 to 6. For pneumothorax, it will be around 2 to 4. So it's generally lesser on the thoracic side, the pressure that they.
So the question next is to Dr. Akhil. What is your preferred analgesia in these babies? So in this case, ma'am, the choices would be either to put a caudally, we can insert a epidural catheter through the caudal epidural space, and we can use ultrasonography to localize the tip of the caudal catheter. So your choice. My choice, well, I would either like to put a thoracic epidural catheter or a caudal catheter. So apart from that, we can put a erector spiny plane block. We can give a erector spiny plane block, or a paravertebral catheter can also be put. Dr. Dilip sir, what is your choice here?
I said, but
if given a choice between thoracic epidural and caudal epidural, which you would like?
No, nowadays I'm very, very site specific even for the epidurals. So for example, the thoracoscopy, we try to put in thoracic epidural. So you can show the video. It is a clear-cut important point here is that unless and until you are really trained in putting an lumbar epidural, and then slowly you can go ahead with doing the procedure in the neonatal. So as we are a hardcore pediatric anesthesiologist, so we are always very site specific when we are doing the thoracic epidural. So the procedure remains the similar what we do. So saline technique what we use, and then little manipulations which are required. So that is what.
Okay, thank you, sir. So we will move to the next scenario. It's not a neonate, but not an adult. So it's an 8-year-old male who is weighing a 30 kg, was admitted with fever, cough, and night sweats with pain in the chest hole, that is specifically on the left side. The diagnosis of empyema on the left side was made, and the child was posted for a VATS procedure. So first of all, I would like to ask Dr. Dilip sir, we have already discussed one technique of SLT. What is your preferred technique in this child, or what you routinely do for such patients?
We had like a same, but commonly the catheters which are available in our clinical practice are the Fogarty's catheter. So they are available right from in the neonatal age. What we use is the Fogarty's catheter, like 3 French, 4 French, 5 and 6 and so on. So these are the assemblies. Like usually for a bigger children also we try to use the Fogarty's catheter, and you can see the induction once the induction is done, and I think so videos are not running, but usually what I do is a extraluminal. First I pass the Fogarty's catheter and whichever the side I need, and then I put the endotracheal tube, and through the endotracheal tube the fiber optic scope is passed, and then you can manage the Fogarty's wherever, like whichever the site if you want to block, and then you can do the auscultation. So that is how the one lung ventilation is achieved. So so you either if you have the good connector which is there, like you can do intraluminal also, where Y-shaped connector which is there. So you can pass the Fogarty's, you can intubate and then pass the Fogarty's from one side, then the other port you can pass the endotracheal tube, fiber optic scope, and then you can maneuver or manipulate. That is how preferred technique. So there are ANT blocker which are there. You can use that one also. But little what we say in Indian jugaad, so something which has to be done. Only the disadvantage with the Fogarty's catheter is we don't have oxygen. Like it's a blind end, so we cannot do the ventilation. So, but advantage is that whenever the surgeon wants, like for example in Watt's procedure, decortication, if like in between they ask to ventilate the lung, so just deflate the cuff and you can do the ventilation. And then again, if you want to do one lung ventilation, just inflate the cuff and then you do the procedure. Yeah, same thing. So you can see on the screen the right side where the Fogarty's catheter is there, and then is fixed. So then you can see I attached the three-way wall at the Fogarty's where you can just inflate and deflate the cuff. What when you see when one lung ventilation, absolutely lung doesn't come inside, and if asked to deflate, then you just deflate, and then you can see a good ventilation.
Ma'am, my preferred choice in this would be putting an ANT blocker intraluminal 5 French. So otherwise we have a lot of choices in this. 8-year-old child, 30 kgs, 130 centimeters. We can even put a 26 French DLT. That is the smallest DLT available. So that is one choice. Apart from that, we can put a Fogarty. As already said, we can put an ANT blocker. The advantage of ANT blocker over a Fogarty is that first of all, the cuffs are high volume, low pressure cuffs. So the damage to the tracheal mucosa is less. So either you can put them extraluminally, intraluminally. This is a 8-year-old, so I like to put it intraluminally. Apart from, so this is a photograph of the ANT blocker with its ANT multi-port adapter. So it has got 4 ports. To one, we can attach the endotracheal tube. The top port, which is in the front, we can introduce the fiber optic scope. And from one, we can attach the anesthesia circuit. And the 4th port is for putting the ANT blocker itself. So it is available in 3 sizes. In this, either I can put a 5 French or a 7 French ANT blocker intraluminally. And apart from that, we can even put a Univent tube. So yeah, this is for intraluminal to properly ventilate. So the cross-sectional area should be at least 50% inside the tube, which should be available. So if I put a 5 French ANT blocker, the outer diameter of the ANT blocker would be about 1.5 is 1.6 1.66 or 1.7 millimeters. And in an 8-year-old, I would like to put 5.5 or a 5.5 size or a 5 size micrograph tube. So it's fairly okay. The airflow resistance won't be too much. So this, the lower photographs are in case if I have to put an ANT blocker extraluminally. This is just for the sake of depiction. So we have the snare, the monofilament loop of the ANT, nylon loop of the ANT blocker. We have just snared it over the endotracheal tube, and we do a direct laryngoscopy and introduce the tube inside. And then once we have done, put the tube inside with the ANT blocker snared to it, we put the fiber optic scope, put in the scope, take it endobronchial, unsnare the ANT blocker, push it inside and direct it towards the desired bronchus, wherever we want to do it. So this is the extraluminal. Apart from that, we can do the intraluminal, extraluminal to intraluminal also can be, intraluminal, extraluminal to intraluminal also can, interluminal to extraluminal, I mean, can also be done. Apart from that, we have Univent tubes also. So, and uni blockers. So the advantage of these are that these can be used, ANT blockers, Univent tubes, uni blockers, all can be used in difficult airways. Whereas they can be used in tracheostomized patients. You don't need to change the tube. Unlike DLTs, if you require post-op ventilation, you can use it through a tracheostomy tube. The only thing with the Univent tube is that it has an internal diameter of 3.5 millimeters and the outer diameter is about 7.5 to 8 millimeters. So it has a very high airflow resistance. So that is a disadvantage. Dr. Dilip, what is your choice? First TLT or first you will go for a bronchial blocker for this kit?
Bigger children, as
Yeah.
I said, I think so. 8-year-old child.
Yeah.
you can go with the double lumen tube.
Double lumen
that is what you can do. Or my preferred choice is always what in our institute what we do is that one Fogarty's catheter.
So, ma'am, one more thing. This is an 8-year-old child.
Yeah,
So this
8
literature is American children 8-year-old. If it is a 10-year-old child, I'll probably 9.5, 10-year-old, I may put a DLT. In a 8-year-old child, I'll like to put ANT blocker only. This is my personal choice.
Okay, Dr. Kiran, as we know with one lung ventilation, so there is always a chance of intraoperative hypoxia. Suppose the saturation drops to 80% with the FiO2 70. So how do you manage?
So first and foremost is check for the mechanical obstruction. If your tube is getting blocked, suctioning of the tube is important. Increase FiO2. Try and adjust your minute ventilation by decreasing tidal volume and increasing respiratory rate. PEEP to the ventilated lung will help in achieving good ventilation perfusion mismatch if it is happening by avoiding atelectasis. If we are using something called as ANT blocker, then maybe we can give a little bit of CPAP to the operative lung. If nothing is improving, then we may have to go back to bilateral lung ventilation for a while. Maybe intermittently using one lung ventilation will be a choice in such scenario. And last thing is the intravascular volume.
Yeah,
it may be a reason for hypoxia.
Yeah. So just one notion, we have a misnomer that thoracoscopic surgeries are less painful in VATS procedure, but it's a completely a misnomer. The separation of the pain from the pleura from the visceral is equivalently very high. So we should even use the most important, that analgesia that we discussed for the previous case here also. So the last question to Dr. Dilip, sir.
I think other analgesia methods we have to mention. In the first case, other analgesia methods were a bit difficult because it was a neonate. But here, besides the epidural, do you have any other modes of analgesia? Dr. Dilip.
Yeah, so we can use basically you can use the combinations of NSAID drugs with the paracetamol combination. So we have a fixed regime of giving the paracetamol with the diclofenac combinations. Also help definitely to maintain the most importantly, what we forget about this analgesic drug is that we don't maintain the proper dosage in the pediatric patient. Secondly, it has to be in a proper, if it has to be given every 6 hours or 8 hours, it has to be maintained that one. So it maintains the peak of analgesia throughout that whole day. So that is what we miss so many times. So I think so that is very important.
So paravertebral ESPs, paravertebral by proxies, these are also this analgesic option in this age group.
But you have to be careful over here. If it's an infected case, sometimes the infection may have spread to the paravertebral space as well. So you have to be a bit careful about thoracic paravertebrals. Although thoracic paravertebrals, some say that the analgesia, the quality of analgesia is far superior to even the epidural blocks. So paravertebral blocks give the best analgesia and it's a unilateral analgesia.
Okay, the final question is, what is the role of POCUS in this case?
Definitely, POCUS plays a very important role, as Ankit earlier also mentioned about the lung movement, whether it is there or not. Then hemodynamics can monitor. So definitely, it plays. If you have an ultrasound, then you can use wherever it is possible. Then you can do it and make possible use of all these. The gadgets and maintain. Definitely.
So towards end also you need to check for the recruitment status if lung is equally expanded or not. That also we can use the ultrasound to check for the same. So thank you all the panelists.
Can take one question.
Practically, we can isolate and do whatever, but practically they don't maintain. So you have to be very, very the only place I would do one lung ventilation in a neonate is probably a CLE, where I just don't want that, lung to be inflating and causing worse problems. So there I would be putting a tube endobronchially. But But otherwise, most of the times we are doing 2-lung ventilation. Even empyema, in fact, our surgeons want 2-lung ventilation. If our child is older, we have the the luxury of the DLT. But otherwise, ARN blocker, all those things. Really speaking, our usage has gone less and less.
CLE, madam, are your surgeons doing it thoracoscopically? Our surgeons are not doing it.
CLE, the surgeon is washed up and ready to take an
No,
incision.
but they don't do it thoracoscopically. Generally, it's an open thoracotomy. So most of the times it is not like if it is a thoracoscopic procedure, then the challenges are a bit different.
So
CLE, most of the times it is not a thoracoscopic procedure, it's an open procedure.
Agreed. CLE is 100% open procedure, but we have to put the tube endobronchial because you don't want to ventilate the lung. In a thoracoscopy also what happens is if you put the tube endobronchial and then turn the neonate, I'm only talking about neonates, they don't maintain most often. So although we have tried and all, we have actually come back and doing 2-lung ventilation. All they have to do is use some insufflation and collapse that lung. And even if you are, say, gone endobronchially, the lung usually remains expanded unless they need to collapse it initially at least.
Yeah,
later on, they may not need
that's a
it.
valid point. So basically it depends on how many cases you do it, because the experience also matters, because unless and until like you are doing a once a year or just only once a month the case, then it becomes very difficult. Yeah, I agree totally with you. But then if the options are available, like nowadays all our surgeons, like most of these cases, they try to do it with a thoracoscopic way. So they definitely want like bronchogenic cyst or the cases CDH, or day before yesterday only we did a 1.2 kg child with the CDH thoracoscopic repair. So definitely she wanted a 1-lung ventilation in that one. So experience matters. Then there are ventilation strategy itself. It's a very different. Neonatal 1-lung ventilation is a different topic itself. We can talk for a whole day because there are various modes of ventilation also is there when you are doing, and you have to be really like concentrating on that case, and then it is possible to do a good 1-lung ventilation.
Can I put one comment?
Yeah.
First of all, for a congenital diaphragmatic hernia, when they are doing thoracoscopically, there is no need of 1-lung ventilation because lung is hypoplastic. It doesn't come in the way. Okay, it doesn't come in the way.
I got the point, but when they are doing a plication, diaphragmatic plication in this little older children.
Older children, if it is an eventration of diaphragm, yes, thoracoscopically, it is needed. But when it is a congenital diaphragmatic hernia, lung is hypoplastic, thoracoscopic, when you are doing, you don't need a 1-lung ventilation because the lung doesn't come in the way at all. Okay. Secondly, even in a congenital lobar emphysema, the surgeon has to be washed up and standing ready. And in our experience, when the senior surgeon is standing over there, in a CLE, when you turn lateral and when you have, they open up immediately, lung pouts out immediately. It is hardly a job of 5 minutes. The lung is completely out of the thorax then. So for that 5 minutes, that exercise is not needed. Where it is needed is really congenital, means CCAM is there. Okay, cystic adenomatoid malformation. And if it is quite infected, they have tried out all antibiotics, everything, still not working out, it's infected. There, you want to avoid the spillage of secretions, and there the 1-lung ventilation will be needed. And coming back to decortications, unless your ICD is showing the bubbling, that is means some connection is there, or if there is a lung abscess inside, or if there is a pneumatocyl inside, something like that, you really don't need a 1-lung ventilation. Because 1-lung ventilation, it's very difficult to maintain and it has a lot of its own disadvantages also. So, I mean, I think we should follow the correct indications.
Oh, well, there are, I'm loving this atmosphere to begin with, because there has to be a rich give and take. For a change, I'm not looking at my clock, you see. There is a rich thing happening here because I know this team. I know they do neonatal 1-lung ventilation at least 4 times a month. And I know another aspect to it, which is coming from a very deep experience as well. So both are saying something different And a wise person is going to keep the mind open and see who's saying what and how much can I put in my practice, you see. So that is how it is. There is a buffet here. I know she has a case and I know what she does. I totally understand from where that wisdom is coming from and this wisdom is coming from. So if the surgeon demands, you have to. However, I've also done it and I have retracted the tube intraoperatively, or I have done a case and gone ahead with the case and at the end retracted the tube and shown that, okay, fine, the ventilation is fine. So I guess soak in this, bask in this, and take your take-home messages very astutely and follow your team. Follow what your surgeon is like and follow what your patient is like here. So that's one take-home messages. Thoracic epidural in neonates may be a done thing for somebody, may not be a done thing in anybody else's hand. So don't. So here is a buffet for you. Pick up what is the... have your own thoughts on it and go home with that kind of a scenario. These are the possibilities. And these are the teams who are different in different locations with different thought processes, and everything has its own role. All right. So may we now present them with the book? You already got it, so you aren't going to get it once again. So Akhil is the person who's going to get the book. Akhil, thanks for being here. You've got a book, Kiran? No, I'm here. All right. Amrita? Now, nothing pleases me more than to call on Dr. Kriti and Dr. Karthik. And they're going to play safe. They're going to recite the literature to you. I hope you've taken very nice journal topics. Over to you. Kriti currently is in New Delhi. She's working. She's a mother of one right now. And she is working as a pediatric anesthesiologist. And she was with us for a year. And so is Karthik. Karthik is working in Chennai. Apollo children. All right, over to you.
Dr. Kriti Puri is an assistant professor at leading...
Stop that, I've already told them.
Hello everyone, I'm Dr. Karthik, consultant in Apollo Children's Chennai. I would like to thank Team CAS for this opportunity. So today we are going to discuss around 8 articles. I'll be doing 3. Dr. Kriti will be doing 3. And Dr. Tripti, okay. So the first article is apneic oxygenation during pediatric tracheal intubation. It was published in British Journal of Anesthesia in November 2023, and it was a meta-analysis. It was done around Europe. Okay, so here the study says that the unanticipated incidence of difficult airway is seen more in neonates compared to the older children, and they tend to desaturate and can cause potential severe adverse events like hypoxic encephalopathy, cardiac arrest, and death. So the safe apnea time concept was explained by Dr. Ankit, and even the apneic oxygenation was told by him. So here in this study, they are using the low flow oxygen with a different delivery techniques. So the primary outcome of this study was to see the incidence of successful first pass tracheal intubation, and the secondary outcomes were the number of intubation attempts and any life-threatening events. So what they found is any children who's undergoing apneic oxygenation was given. The first past tracheal intubation, it is better in the apneic oxygenation group than control group. And the patients, the kids with apneic oxygenation didn't desaturate more compared to the control group. So even the complications like hypoxemia was not seen in the apneic oxygenation group. And the certain things what you have to keep in mind is if it's a very preterm neonates, this 100% oxygen can cause bronchopulmonary dysplasia or prematurity, retinopathy of prematurity. And giving high flow nasal oxygen reduce the chance of pneumothorax because the CPAP we are giving will become less. And giving supplemental oxygen to the children with cyanotic heart disease might cause a perfusion mismatch. So one thing what you have to remember is if the children are having both upper airway and the lower airway obstruction, there's no point giving apneic oxygenation. So the limitation of this study is it was a limited number of included patients and the assumption of independence of different treatment arms. So what they're trying to conclude is they're saying apneic oxygenation during intubation prolongs the safe apnea time and decrease the incidence of hypoxemia and reduce the number of intubation attempts or increase first pass success without physiological instability. Coming to the next article, needle-free pharmacological sedation techniques in pediatric patients for imaging procedures. Mostly they've done only MRI studies. So again, it was published in the British Journal of Anesthesia in October 2022. Again, it was a meta-analysis study. It was done mostly in Netherlands and Belgium. So it is unclear which needle-free, we have so much drugs and we don't know which pharmacological sedation is better. So they have compared all the sedation available to us. So the needle-free sedation can be successful in children 8 years or younger. Okay, and they can either give it in any route they want. And general anesthesia remains safe alternative who fail this selection process. So they have compared the depth of sedation, minimal, deep, and general anesthesia. There's actually moderate also. I don't know why they didn't mention it. And so the MRI is prone for motion artifacts, and it's usually longer time, easily 30 minutes to 40 minutes, and it's very noisy. And these can affect the sedation success rate. So here they have taken kids from 0 to 8 years who's undergoing anesthesia, and they have receiving medications via oral, rectal, intranasal, buccal routes. So the primary outcome was a success rate, whether they could complete the sedation without the child getting up. And secondary outcomes were the onset and duration, recovery, and adverse events. So these were the list of sedatives they have tried with combination or alone. And these were the success rates. So the limitation of the study is the assessment of the quality of MRI. Only few studies focuses on that. And there is a need of higher standard of reporting with more detailed outcome information. So what they found is this pedicloral, which we give, had higher incidence of adverse events. And it also causes prolonged sedation. And it requires extended observation. And a high dose of dexmedetomidine might not be sufficient to conduct the MRI. And sevoflurane has caused more adverse events. And oral midazolam and melatonin combination, sometimes child doesn't even sleep during that. So the combination of dexmed and ketamine has been successful, but they did only one case with that. And the further research is needed in that. So what they're trying to conclude is they're saying that intranasal dexmed 3 mics per kg along with intranasal midazolam 0.3 mg per kg had a higher success rate with a very less adverse events. Okay, and the third study is from our very own Mumbai. conducted by Dr. Nandini Dave. And that is it was published in Indian Journal of Anesthesia 2019. And the study is the effect of preoperative education on anxiety in children undergoing daycare surgery. And we all know the preoperative anxiety in pediatric population can be detrimental as it produces abnormal hemodynamic responses, negative behaviors, and high pain intensity scores. So the anxiety can be increased due to the lack of knowledge. So here, either the patient is anxious because of the procedure or the patient is the anxious type only. Okay. So the children from the age group of 7 to 12 years undergoing daycare surgery were included in this. They were randomized into two groups. One is study group, where both video as well as the verbal information was given. And in control group, only the verbal information was given. So after double blinding, the patients were allocated a study group where the video was shown and they're also explained and verbally. And children in control group received only the verbal information. And children in both the groups were allowed to choose what kind of induction they want, whether they want IV or inhalational. And if the patient wants, they were asked to see the video again. And the VAS scale, video analog scale for anxiety in children were checked both 1 week prior when they come to the anesthetic assessment as well as prior to the surgery. And the secondary objective was to study the hemodynamic parameters in both the groups. So the median preoperative VAS score was significantly lower in the group where both video as well as the verbal information was given, and even the pulse rate and BP were all lower in the study group. And the limitations of this were, it was the focus mainly on anesthetic induction and recovery of anxiety, not on surgery. Assessment of prenatal anxiety was not done, and even the VAS score has not been validated. So what they're trying to conclude is the non-pharmacological behavior education in the form of videos helps the preoperative anxiety in children between 7 to 12 years of age. Thank you.
Yeah. So before I start, I would just quickly like to thank Dr. Roshali ma'am and the entire CAS team for having me here. It's truly a privilege to be with them again. And without much ado, let's quickly start navigating through literature. So the first article that I would be sharing is one from Pediatric Anaesthesia Journal. And or you could on this. I go ahead. Okay. So the first one that I would be talking about is one which is published in Pediatric Anaesthesia Journal in September 2023. And it's a perspective by Dr. Adam Adler and Dr. Paul F. Austin, describing that caudal block for hypospadias repair, unfolding the controversy through statistical analysis and how we can put it all to rest. So this one is a very interesting perspective which aims to address the controversy, suggesting performance of caudal block, which increases post-surgical complications, particularly UC fistula in children undergoing hypospadias surgery. And when was this controversy brimmed? It started brimming in a decade back in 2012 when Dr. Kundra et al. Published a prospective cohort featuring 53 patients who were undergoing hypospadias repair. Now, interestingly, at that point of time, their primary aim was to assess the quality of post-operative analgesia, to compare the quality and duration of analgesia between caudal and penile blocks following hypospadia surgery. And it was a post-hoc power analysis which was done solely for the primary aim. That is, the difference in the opioid consumption was taken. So this was the article. Now, as you can see, surprisingly, when the article got published, the title was all about the surgical outcomes in children undergoing hypospadiac surgery. Okay, and here they reported incidence of 19.2% of post-operative UC fistulas in patients only with caudal block. And there was just a single sentence detailing the methodology used in evaluating these complications. No justification was given for the small sample size that they used. And why this controversy was there was because they reported an abnormally high incidence of complications with caudal as opposed to other studies, which was only less than 10%. And here we're talking about a small cohort that is just 53 patients, 26 and 27 patients on either side. And the likelihood of not experiencing a complication simply by random chance alone is extraordinarily high. And also, interestingly, what they forgot to mention is the relative risk of a complication when the caudal is performed. So when the meta-analysis was done and the relative risk was calculated for Dr. Kundra et al., it was found to be 11.41 and then with a 95% confidence interval. So this was, 0.66. And this was relating a statistically insignificant association between the block type and the complication likely attributable to a very small size. Now, was this perspective really needed? Yes, it was, because there was so much controversy regarding the impact of caudal on the development of surgical complications following hypospadia surgery. So yes, and to sum it all up, even though Dr. Kundra et al. Had justified that the caudal probably resulted in penile vasodilatation, altering the tissue planes, and that was the reason the surgical complications were developing. A recent study has proved otherwise, that neuraxial anesthesia generally does not result in sympathectomy in young children. And the authors then also conducted a meta-analysis where they took under 10 studies which were analyzed along with 3201 patients and 33 surgeons, and they found that there was no association between caudal block and the risk of the complications. So what was our conclusion? That importance of a large sample size is emphasized in addressing questions with numerous confounding variables and variable frequency. And mostly, even though the meta-analysis which was performed by these authors, all studies were retrospective, to address the complications specifically. So that's the same. Now, let me discuss second article. So this one also is published in Pediatric Anaesthesia in September 2023. And it's a perspective by Dr. Gordon, Dr. Chatterjee, and Dr. McCain, which says that it's time to stop using nitrous oxide for pediatric mask induction. Yes, maybe surprising to a few of you here, but yes, it's true. So what was the purpose? So the purpose was to challenge of routinely using nitrous oxide for mask induction in children, guilty as charged, address frequently cited reasons in support of using nitrous. They countered each reason with evidence, and more importantly, they proposed alternatives resulting in safer, equally pleasant, and less environmentally impactful induction experience. So this was all based on a survey which they conducted, and they found that 77% of the respondents used at least 50% nitrous in oxygen for pediatric mask induction. So what they basically took all the reasons which were commonly cited, and one by one they addressed each of them. So the most common reason being because we have always done it this way. So what needs to be remembered is we all know that children have less FRC, they have higher oxygen consumption, they have an elevated risk of laryngospasm, and that too many a times without IV. Sorry, ma'am. But because of these factors, when nitrous oxide comes into play, of course, the risk of apnea, the risk of desaturation becomes more. Second, the reason that was cited was I turn off the nitrous oxide once the patient is unresponsive. So do I have the time to discuss it? No. Okay. So next, the reason that was there was why fix something which is not broken? So it was always said that they are all myths, that fertility problems, abortions, anemias, it was just a mythical thing. But yes, it's been proven day in and day out now that nitrous does impact the health of the it does provide a occupational health hazard, and thus it has to be addressed someday. Next reason was to allow a child to have a non-traumatic induction experience, right? But obviously in the 1 minute, in the 2 minutes that we have, most of the times we're using nitrous and sevoflurane together, and it's not really that we are using it one by one, which was the original literature, how it was published, the first time it was ever. That's how they've cited it. And none of us do that. We always use it together. So it doesn't really have a non-traumatic induction. Instead, we could use distraction techniques, sedatives beforehand, and either basically ease the transition. The last reason was because the second gas effect speeds up mask induction. So did I. That's what I thought. But recent studies prove that that's not true. It doesn't happen that way. So was this perspective really needed? So inhalational induction in children traditionally involves the use of nitrous oxide, poses challenges, including hindering pre-oxygenation. As we discussed, so many factors that are already at risk. And in a summary, nitrous oxide itself is ineffective in calming uncooperative children and does not expedite mask induction, contrary to the general belief. And it does have an occupational hazard and environmental factors. So to sum it up, it is less safe for children. It is potentially harmful to us, more harmful to the atmosphere, without any evidence of benefit for our patients. So answer cannot be because we've already done it this way. So conclusion, utilizing other techniques which facilitate tranquil mask induction will assure the patients have a pleasant induction experience, and avoiding nitrous oxide will reduce the environmental impact as well as improve the safety. Coming on to the third article, this one is original article which is published in Canadian Journal of Anesthesia in 2023 as well. And this says that regional anesthesia and analgesia in patients with spastic CP undergoing orthopedic surgery, a historical cohort study. Coincidentally, the authors are all my CAS teachers. So the purpose of the study was to examine the incidence of severe post-op pain in patients with CP in the first 48 hours after surgery performed under combined regional and GA and its association with patient and surgical factors. So this was a historical cohort study which had a sample size of 452. They included patients with spastic CP who underwent orthopedic surgeries of upper and lower extremities and excluded hypotonic and non-spastic CP patients. The patients were recruited from, which were taken into the study was from April 2016 to February 2020. Study was approved by the local institutional committee, CTRI registered. All the details were analyzed. So in all these cases, the regional anesthesia was performed after the induction of general anesthesia, and the choice of the regional anesthesia was based on the type and invasiveness of the surgery. single shot or continuous. So it totally recruited 440 patients, and most of them were subjected to neuraxial, that is 390 had subjected to neuraxial anesthesia, 31 had limb surgery, so they were given upper limb blocks, and 28 had been given lower limb blocks. So this is essentially what I was telling you about. Now, was this study really needed? Now, most of the CP patients require major and complex surgeries, and these patients may not be able to communicate effectively regarding pain, necessitating observation feedback from the caretakers. And obviously, this pain adversely impacts the perioperative outcomes, as we all know. And also, muscle spasm in spastic CP can worsen postoperative pain, which is not there in the general population, and this can trigger muscle spasm, leading to a vicious cycle. So these were the tests which were used, and what they found was that there was a 15% incidence of postoperative breakthrough pain in such patients. And despite regional anesthesia, they experienced this. And this was predominantly in patients undergoing complex major surgeries with ASA physical status 3 and 12 years or older. So what were the strengths? I'll be done. Strengths of the study was that it highlighted the challenges of pain assessment and management following extremity surgeries. We also found out that evaluation of sleep quality and quantity of feeds may be helpful in analgesia assessment. That's what they use. And despite single shot and continuous regional anesthesia in a multimodal analgesic regimen, there was still 15% of patients who experienced severe pain, obviously, which responded to the treatment adjustments later. What was the weakness of the study? That the established pain scales of pain measurements, such as a non-communicating children's pain checklist, could not be used. There could not be a standard comparison between the central neuraxial and peripheral nerve block techniques, as the number of unilateral cases was significantly smaller. Regional anesthetic experience for upper limb surgeries was limited because of less number of cases, and no long-acting opioid was instituted in the post-operative multimodal analgesic regimen. And maybe the authors hypothesized that if the incidence of severe pain could have been lower if they were included. And of course, it's a retrospective study, so without a proper comparative non-regional anesthetic control group. So again, to sum it all up, despite the use of RA, as I told before, 15% incidence was noted. Thank you.
Actually, I wanted to come and move her out, but finally she was quoting our study. How could I do that? Okay, Kriti. Kriti and Karthik, over to you. The books. Read them. Thank you. All right. I know we must be hungry, but I tell you, this lecture is going to be one worth of it. So may I have Dr. Ramesh here, and he's going to talk of those unsung heroes. No, he's not talking about anesthesiologists. He's talking about the machine that the anesthesiologists use, because I don't think we are any more unsung. You don't have to try, sir, at all.
Thanks for hot topic. Switch on the front light, this light, and then switch on this light, this light. Okay. Is the collar mic is on? Collar mic is on, okay. So switch on the front lights, yeah. Anybody? Yeah. Lights can be on. Come. It's 1 o'clock. I think by this time lunch would have started. We are beginning about 30 minutes. but I've come all the way from Chennai, so I have to finish my talk. So you have to bear with me, okay? The because the first slide is very important.
I'll utilize this time. You have a quiz with Ramesh sir and Kriti. So meanwhile, Kriti can just tell you about somewhere I need to squeeze in time. Come. Tell them about the Kahoot app so that they can be ready for your quiz.
So all of you could please download this app from your Google Play Store or your, if you have iPhones, then from the Apple Store. So that
I just, because we both supposed to do the quiz, but I never communicated properly with her. But the other one. I'll do also. 2 minutes, please. Bear with me. Is it okay? Shall I start with this one? I think that's okay. I think people like want try to say. This dress code is mandated by the organizer. Please, you believe me. Okay, nothing that is okay. Little uncoupled. The second disclosure before my talk is that this is the first time I'm wearing the dhoti after my wedding in 1985. So something awkward situation happens, please don't blame me because it is just the start of that. Okay. Having said that, I'm coming to my topic, unmasking the heroes. Can you switch on or you can that can be on because it's distracting. Unmasking the unsung heroes. And I say, see, you're given about 15 minutes, I'm going to take 30 minutes because it's not because of me. If we're juniors, I can't just rush it because a lot of things, I myself took about a lot of things to really exactly say what is the point. Very difficult to say. You have to bear with me. You bring down the lunch time by 30 minutes, or I can take off the quiz time. No problem. So that's important to me. So this is what it is actually. The second disclosure is I've been explaining the whole of the concept of anesthesia with a GE machine. Not that I'm part of a GE machine, but from the start about 40 years ago, traditionally I started the Boyle's machine by the Omeda, next by the Omeda, then Datex Omeda, then now GE has taken over Datex Omeda. So that's why I am part of this one from my journey. So I'll be talking about this doesn't mean I am part of a GE machine. I'll tell you all this very, very important to me to that. What I'm going to talk in 30 minutes of time is overview of ventilation in the operating room. What is overview? What is important? How does OR ventilator differ from ICU ventilators? This is another one. That's the pulmonary physiology. I think that's, unless you understand that you cannot ventilate, I think that's a very important. It's just a review of that. It's okay. And modes of ventilation OR. I'm not going to really bore you with that. Ventilator needs in the specific population, one on laparoscopy, other on neonate. So I think these are two which are really little different. Novel ventilation, the talk doesn't end without any novel ventilation, which is really going to come. And finally, TP is gone or alive. I think that is very important. I'll come back to and finally some concluding remarks. Coming to the overview of the ventilation, breathe in. What we are doing it, breathe in, breathe out. Okay. So when you tell all about the machine, you all people please take a deep breath. Okay. So that's important. 30 minutes, you must listen to me. What this talk assumes for all of you is that you already understand the basic of ventilation. If I talk about the basics, the whole day I'll be doing the ventilator workshop. You already have a basic understanding, basic modes. I can't tell you all the basic modes in about 30 minutes. You all understood what it is. You are familiar with the compliant, resistant, elastance. I think whenever you talk about anything, especially in pediatrics, only three things is important: compliance, resistance, and elastance. If I can't define in the short period of time. As such, I have skipped some of the basics to fit the new stuff in the time allotted. And I have tried to entice your interest in some of the odd topics in in children because their mind, once stretched by new ideas, never regains its original dimension. Having said that, in times of change, you see the evaluation of ventilation, in the times of change, ventilators change dramatically. What I was doing ventilator workshop 40 years ago has complete change right now. We are talking about auto modes. We are talking about so many things that change. What was the truth yesterday is not the truth today, and will not be the truth tomorrow. So I think it is not that what's happened 20 years, again it will change and things are not the same. Doesn't mean you should forget the whole thing. My career path during for the training is that from Zipporha, I started my non-PG junior resident where I was using only hand ventilation with the bag, which is a Jackson Reese, which is doing that. And second, when I joined Chandigarh as an MDPG, I had a machine, what is called auto vent. I don't know how many people have used that's called auto vent. That auto vent is the one which is attached to the Meggle circuit. So you attach the Meggle circuit, an open circuit, connect to the patient. If the pressure goes up, it will inspiration, patak, 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 patak. That's all. That was the auto vent which was coming like that. We had no monitoring, no ETCO2. We see the chest expansion. And for that, there's a big competition in Chandigarh. Who goes at 7 o'clock will get the auto vent. If you go at 7:05, you will not get the auto vent. So you have to ventilate like that. So everybody gets up early morning and go and get the auto vent. I think that was the situation at that particular time. Then I joined Apollo Hospital, Chennai. I was the first registrar of Apollo in Chennai in 1983. That time they got what is called a manly servo vent. This is a manly servo vent is just a minute volume divider. You give the minute, you put the minute volume, then put the rate, and the tidal volume will just minus by rate, it will give the tidal volume. How much it goes, we don't know. No ETCO2, nothing, only by check sign. This is a minute volume divider, which is okay. Then I went to Pediatric Jeddah. You know, when though Apollo has a lot of money, but at the time I needed more money. So I went to Saudi Arabia. So, you know, the money is very important. I think Bombay people know everything. So money is very important. And actually I went to Jeddah, not lots, but some money to live. And then at that Jeddah, we have got Datex Omeda ventilator. Datex Omeda has got a bellows, which has got an adult bellows and a pediatric bellows. If you get a pediatric bellows, you have to change it and then put it there and then use it. That give you some volume, it will be there, but exactly expected volume you cannot measure. But it will tell you that's how the ventilator starts with that. And finally, I got Child Trust Hospital summer 1989 for 34 years. I'm there, and that my talk will be from that for 34 years. What really is happening from that? So when I joined Child Trust summer 1989, I had an impression that we don't need a very big machine. We need a good monitor. I think that's good. Anyway, we're going to ventilate with the hand. What is the question of buying a machine which is 4 lakhs, 5 lakhs? I think means of this, we might have a good monitor. That was my concept when I want to buy a machine for the Child Trust. So we bought the Miles machine, but we got the very good monitor. But that, I thought that is the one way we want to ventilate. I think that is the situation at that particular time. But things have changed a lot. Then the concept, I'm sure all of them will be aware. There are 4 concepts I want to tell you why you don't want to buy a ventilator. At that time, I was thinking why I don't need it. Because you are educated hand, you know, you have got very good educated hand. We know how much you are ventilating. Why do you need a machine? There are small babies. So why do you ventilate? Oh, don't put our patient on a ventilator. So we are ventilating with the hand. This is a ventilator safe. Need small. Those days, you said an adult observer, you cannot be used in a pediatric. So you need a small observer. Small observer will not be available. Resistance will be high. So we don't use a ventilator. I think that was the concept of that. We need only what you want. You need a control mode, assist mode, and spontaneous. That is the only 3 things you need for one. So there was the basic modes of ventilator anesthesia was like that only. So no need of expensive anesthesia workplaces. That is my concept which I had at that time, but it's wrong. I can tell you that that's what I was thinking like that. So this is an educator hand. We are just telling you know very nicely how much volume you have to give it. Very easy to do it. Those times there is no valve also. That will be open and you must keep the bag like this, and that is the experienced valve, and the experienced fellow will exactly say how much you have to expire. I think that's a beautiful one. I think Satish Kulkarni is following. That's how we have to do like that. And that's called actual Devonport valve. And I got 3 articles on this very beautiful one. The educated hand in 1967 is written, they put in a one and put in like a physiology experiment into one and put a graph into the drum and ask the residents, fellows, consultants to ventilate, see how much they are doing like that. And that is the result. They found that all the juniors all the juniors are ventilating about 70, 80. So once it's given the bag, they keep on doing it. You've seen everywhere, and they think that they have to punch more. So they'll punch more like that. So this is a junior one. Whereas the experienced one will come and take over and I think that Nandini will agree with me with that. Okay, so this is how it is. And this is an example for this particular child. But 20 years ago, I just gave a bag to my, that time I didn't have fellow, I just had a resident. So he said, please bag, I'll have a cup of coffee, the congenital hypertrophic pyloric. So when I came back and all these things are over and shifted, the child was conscious, extubated, and child was fine in the room, shifted to the newborn ward, and child desaturated immediately and found there was a bilateral pneumonia. Then I found that fellow was really pumping. See, that's really happened. This what happened. I said that. Then I realized why pneumothorax happened with that. Then I realized I went to that fellow. That's why this has happened. This one. And believe me, this is the child which put bilateral ICD was put in newborn. That was about 20 years ago. And then this is the one with a close-up of this, which we have a bilateral pneumothorax. And because somebody has put this. So educated hand needs an experience. Not everybody will have an educated. That's what is important. The best part of the joke in this is, this mother had a pyloric stenosis. So she asked me, I also had a pyloric stenosis, but I didn't get this complication. I told you, you're not given to the boy to ventilate, you only the anesthetic to ventilate. No, this all happened. Nothing to joke in that. This happened actually. So there is a second article which came, this is 1991, in anesthesia, not so educated hand of the pediatric anesthesiologist. They say educated hand is very good. Not so educated, the pediatrician said, the feel of the bag is not alone is important, the feel. And whenever you use a surgical, you must see at the surgical side, if they're retracting, suddenly you must see the compliance, you must see the resistance. So it is not it's not only an educated hand, the feel, but you must see the surgical hand. This is a beautiful one. If anybody wants, you could read that. Very nice. This is the latest article coming 2000 pediatric anesthesia. It was educated and uneducated. Now it has come. Educated and pediatric anesthesia, does it exist? Even in 2007, he says that experienced people able to tell occlusion of the endotracheal tube with a Jackson race much better than a closed circuit. That's since 2007, the article has come, and this all. So all the articles I have taken so that it's all in my favor. So this is how it is. A man views the world the same at 50 as he did at 20 years of time. If I done like that and I don't want ventilator, that means you have wasted 30 years of my time. So you need definitely to improve according to what's happening at this particular level. But whatever educated and non-educated, and I feel that mechanical ventilator freed the operator's hand, enabling other intraoperative hours to be taken. You can have coffee, you can read newspaper, and then you can browse so many things, though not for the patient care. I think this is a very important. Because you'll be alone, you want to give blood, you want to do something like that, you put another line. I think ventilator saves all the things, which is really very important to that. Having said that, I'll come that how does OR ventilator differ from ICU ventilator? It's not the same. There's something different with that. How does it differ from the ICU ventilator? Number one, that in ICU, nobody needs to stay with the patient. It will be like that only. You've seen all ICU like that. So nobody will be there, nurses and all. It will be ventilating on her own and all these things. But in anesthesia, it cannot be like that. You cannot go. So you have to be like that. Somebody has to be by the side. You have to be continuously monitoring because the physiology changes very rapidly, not like an ICU. This is okay. Only there is arrest, all will done. See. So this is one. The other important thing is that the other important thing is that the anesthesia ventilator has got an vaporizer where you need an inhalation to be adjusted. It doesn't have an ICU. Now, and then there is an auxiliary gas outlet which is being there. And you got a manual, and then you have got control where you don't have an ICU ventilator which is being there. Then we have got what is the bellows which goes up and down. We can see that. We don't see an ICU ventilator right now. We can see something which is different. So we're ventilating in ICU, we are ventilating from days to weeks. Whereas in anesthesia, ventilate from minutes to hours. Mostly it's okay. So I think this is a very important thing we have to see why the ICU ventilators are not okay. The more important I want to tell you, ICU people, they ventilate the very diseased lung, whereas anesthesia ventilates their normal lung. So I tell the ICU people, please come and work in theater for 3 months. You know how to ventilate a normal lung, then go to ICU to ventilate abnormal lung. You are learning a normal lung ventilation. How will you know how the normal lung works? So here you are ventilating a normal lung. I'll tell you the difference in this. So I think you must put like this, because they put in ICU, people are posted 1 month in from ICU, they come to my theater. I tell them, you did all things, wrong things, you want to you're the right thing now. So please come before and come like that. So I fight with them. No, this is all, nothing I'm joking, this is all happening in the hospital like that. So I tell them like that, okay. So the anesthesia machine is morphed into anesthesia workstation. That is important now. We don't call it into a machine, it's a workstation. I think that's how it has been morphed into that. So what is the older anesthesia machine? Why you didn't do anesthesia machines? These are the bellows minute volume dividers, because actual tidal volume delivers depends on so many factors. With your fresh gas flow or with inspiratory pressure, compliance, inspiratory time, all this will affect the tidal volume. The present anesthesia ventilator, this will not affect it. What tidal volume you give will deliver to the patient. That is the advancement. How is this advancement happening? Is there are 4 types of anesthesia ventilators. One is a bellows type. The bellows type can be an ascending bellows or descending bellows. Descending bellows is it's almost banned, because you can, if there's any leak, it cannot move. Ascending bellows, if there's a leak and you see it is moving. I think when it stops, that means there's a leak. So all the Datex ones are ascending bellows. Descending bellows are somewhat before with the dagger, but that's all been stopped. Now this is actually piston ventilator is Draeger, where it is a single circuit, whereas this is a double circuit. One has to drive the bellows, other is one to give the patient. Whereas in a piston, it's only a single circuit, very much more safer, and piston will go up and down, you can see. This is the other one is Siemens, what is called a volume refractor. Okay, this is a flow eye ventilator, getting one, it's a beautiful one, but not many are using Siemens, and it's not important because mostly ICU ventilator, but the technology entirely different, what is called the volume refractor, the exactly tidal volume what you are giving, it will give it to you. So ventilator for pediatric anesthesia need to be powerful and able to deliver small volumes at high rate without compressing volume loss. I think that's what the pediatric ventilator should be. So it's okay with that. So do new anesthesia ventilator deliver small tidal volumes accurately during volume control ventilation? If you put a volume control, 70 ml, that's the 70 ml goes to the patient. That means that's a good anesthesia machine. So all the anesthesia workstation has completely changed according to this. Whatever you do, the fresh gas flow should not change. That is the present. So the fresh gas flow independent of ventilation, what you are giving. So all the machines, what you are giving is like, this G machine, what called a fresh gas flow compensation occurs. What I don't want to describe everything. And whereas in the Draeger, it is called fresh gas decoupling occurs because there is sudden drop during inspiration. Whereas in Keating and a flow high, there is a fresh gas accommodation happens. And finally, juice and pulses off. There's a high-end Draeger machine, and that works on principle of circuit flow interpretation. Whatever the principle is, they'll deliver the even low tidal volume about 10 ml exactly to the patient, independent of the flow, compliance, resistance of the tubes and everything. And that is the one we have used for pediatric ventilation. So having said that, what is modern anesthesia workstation? See, complete self-checkup and calibration has to be done. That I'll tell you the reason why you have to do that. And then you think that just to check it and you will bypass it, it will go again because you're in a hurry to do the case. So you will not do that. It takes 2 minutes, but it takes a lot of important in that. Exhibit ventilator modes other than PCV and VCV. Initially, you thought only pressure control, volume control, spontaneous you exhibit. But all other modes are very, very useful. I can tell you that. I have monitoring facilities of ventilatory mechanics. If it's available, you can easily titrate what is the tidal volume, how much PEEP you have to give it, what is this. I think that's a very important. I can do all these things. So self-checking is a very, as soon as you go self-checking, correct functioning of machine sensors and internal devices. It will sense exactly what is the device to be checked. And more important to all the people, I know how many is aware that evaluating anesthesia circuit to be used, it will check the compliance of the tube, what is the compression volume in the internal diameter, what is the estimated internal volume, all will be done during the self-check. So it all will tell you exactly what is to do. What is the internal volume, what I'm talking about, is the circuit volume, canister, reservoir in terms of compression volume. All the volumes are checked before the machine says I'm okay. And more important, when during the checking, there's what is called the saturation K time constant for inhalation to saturate the circuit. That's called K time. That is, it will check how long will it take for the circuit to saturate with the inhalation agent. So if you take 1%, immediately it should give you 1%. That takes time. That's what's important when you're doing a checking of this machine. So I just want to tell you this. It gives you all the check. It comes at the end. As this one will tell you what is circuit leak. The circuit leak is 10 less than 100 ml. It will say okay. So everything has to be checked, and it will tell you okay. And then you can start the case. Then everything is fine throughout the procedure. Whether you use a pediatric circuit or you want the people say adult, as soon as go, they'll change to adult circuit. No need. If you change the adult circuit, go to checking machine. It will check on what are the compliance. You can use adult circuit in pediatric, nothing will happen to that. You can use pediatric circuit in adult circuit, nothing will happen because machine will check what exactly to be done for this. This is another small caution to the people. That is, when you are using my hospital, no problem, because in default it will be pressure control. But if you use an adult machine and suddenly you go and use a smaller child, it will default automatically, it will go to volume control with 500 ml. You connect to the patient, that 500 will go more to the patient. I think please be careful that you have to switch over to pressure control or put the weight of the child, then it will go to pressure control mode. Without this, if you switch on the machine, it will automatically volume control and it will be 500 ml thyroid volume for the first breath. Please be careful with this, very important when you're doing that. Having said that, what the literature says, all the information from anesthesia is all from adult data. Nothing is in pediatric data very, very clearly as we are. We are whatever you are extrapolating from the PICU ventilator modes, they are all diseased, the ARDL septic. How can you interpolate into the normal lung in the PICU? All the literature are not all right. The outcome, what you are looking after the study, is it the post-operative pulmonary complications or the lung volume or the outcome, what we are studying it? Nothing has been studied. Lack of good study in children anesthesia. No control study in anesthesia has been done so far in any of the literature, which mode is good and which mode is bad. 90%, but still we are getting out of that because 90 to 95% of the children have a good lung. Whatever you mode ventilate, however you ventilate, child will be all right. So don't bother about it, but you must understand that that's why we are getting away with that. So coming to the pulmonary physiology, can I go ahead? Or I can stop at the end. I'll finish this. If you want, I can go out to the ventilator, modes of ventilation. I'll just rush through that. Okay, I'll just rush through that. See, this is I'll just do the pulmonary physiology. What you have to understand is two things: is FRC, very important. Doesn't mean that you have to ICU. I just thought Vishali will say, please go ahead, but she's not. That's okay. Doesn't matter. It's okay. See, usually I get a good response, but but doesn't matter. The FRC, recurrent maneuvers, PEEP, and lung. See, why I'm telling you, it's really very important for the people because you must. All the four things are very important. FRC, and why FRC is important is the first is that effects of the beautiful article from Perth as well as from Germany, effects of anesthesia and pediatric lung function. Fantastic one. What does it say is during induction, paralysis, inhalation agent, give propofol. As soon as you induce, the FRC goes down. So this is, I'll tell you a video which I'm showing exactly is okay. There's another one in the same paper, decrease of FRC as soon as you give a neuromuscular block. So that people like to do only spontaneous without neuromuscular block so that the FRC doesn't come down. I think that's important to do that. This is a cleft lip child where I just intubated, giving a muscle relaxant. You see pressure control of 12, we see the tidal volume. The tidal volume was 29. As soon as I connected, you can see that the next patient where I am recruiting, I just put it to the manual and take the manual back and just give a pressure about 30 to 40 centimeter, 5 to 10 seconds. And as soon as you give the pressure, you see the same 12. You see, this is all recruitment maneuver. I'm doing that as soon as the FRC comes down. As soon as you can see that with the same 12, I'm getting 70 ml of tidal volume. I reduce the pressure to 10. I think as soon as you paralyze and then induce, please put on manual, give a couple of recruitment maneuvers. Just give 10 seconds and then put it back, then your pressure will go down. This is immediate. This will be all okay. There are some recruitment manuals which I want to tell you. There is this is a child with has been analyzed and MRI has been done. within about half an hour, 45 minutes, there'll be a lot of collapse and all these things. So on this is the say with the CPAP, with the alveolar recruitment strategies, the lungs are becoming better. So you must use recruitment even in children. So whenever you want to do FRC, when it decreases, whenever you do suctioning, if you disconnect, whenever you are doing anything on this one, you must do this manual. Okay, I don't know what to do. I'll just rush to the PEEP. I think the PEEP is very important. See, PEEP alone, if you give over this open alveoli, minimal alveoli, PEEP doesn't do alveolar recruitment. Please remember, a PEEP only keeps the lung open, and recruitment will give alveolar recruitment, and as soon as you give, without giving a PEEP, de-recruitment again occurs. That means you must give PEEP as well as alveolar recruitment. So when you add both together, then there's alveolar recruitment, means the open alveoli, prevents further atelectasis. I think you must give PEEP with recruitment maneuver, and that is a very, very important. Import of positive pressure, you can see that the PEEP is very important, and then it's okay with that. Lung protective ventilation, which I want to tell you. People all talk about, 6 ml per kilo, and you want to do all these things. That has been studied in ICU patients in ARDS. Why do you want to reduce your lung volume to 6 ml? I think that is not right. I used to say, but literature very clearly says, protective ventilation during anesthesia, is it meaningful? This pure ventilating normal lung. When you do like this, the conclusion of this particular, this one is, without knowing how successful the protective ventilation is during anesthesia, and if any positive remain in the post-operative period, reduction in post-operative pulmonary complications can hardly attributed to protective ventilation. So I think that you cannot use, no need to do protective, not that you cannot use it. The another beautiful paper from Switzerland, Marcus Wies as well as Spitz, all the people, ventilation total volume during upper abdominal, the total tidal volume with the low tidal volume, and the results are all very bad when you use 6 ml. You need little more. The conclusion of this, another one recent is the role of lung protective ventilation in LD children in anesthesia, and he says that in otherwise LD pediatric patients presenting for surgery, the evidence and absolute recommendation for lung protective ventilation are similarly lacking. So I think it's no problem at all. So avoiding tidal volume more than 10 ml per kg is avoided. I think as long as you remember, please do not give more than 10 ml per kg. I recommend at least about 8 to 10 ml per kg. Don't go beyond that, below that. There's no value because somebody says something. Because this is called the baby lung concept. The baby lung concept came when there's a diseased lung, there's a small lung, you go to total tidal volume is low, it will ventilate that diseased lung. That's why you want a low tidal volume. Whereas in anesthesia child, the lungs are good, there is no baby lung concept in there. So don't use a low tidal volume, it's okay. So not too little, no 6 ml per kilo, not too much, not 12 ml per kilo. I think suggested is 8 to 10 ml per kilo. I use about 10 ml per kilo, no problem at all. Having said that, I think I'll finish with this modes and then I think go. This modes of ventilation is, I think that's okay. There are so many modes of ventilation, something in the front and something back at the streets also available. But what is important for us to consider, only 3 modes, which is as stated very so. One is pressure control mode, then pressure control volume guarantee. Otherwise, it is called the PRVC, pressure regulator volume control mode. And finally, pressure support. I'll just finish these 3 and then we can go for lunch. Okay. Important for all people. Volume is easy because 100 ml, 100 ml. Pressure is easy. Pressure is 10 centimeter water. That But flow is a dynamic. Volume per unit second or unit time. So if you can understand flow, you will understand everything about ventilation. I'm telling you. Because volume is C and you have got a pressure. But if you can understand the flow, and that is what is the speed in which the volume is occurred and what's the pressure. That is because the volume per unit time is the flow. So if you can understand the flow, you understood everything about the ventilation. Coming to the pressure control mode, the pressure control mode is very good because it's a decelerating flow. Whereas in a volume control is a constant decelerating flow, which will compensate for the resistance, it compensates for the compliance, everything. And it's a very good pressure control ventilation is very good. And those days we used to ventilate the uncuffed tube and we are recommended to have a leak. In that means pressure control mode only will work. And started using LMA. LMA is likely to leak, then pressure control mode came. I think things have changed right now with that. And uncuffed tube and LMA. So I just want to show you a small, when in the pressure control mode, 16, we are trial volume of 292. The volume control mode, I am putting out 270 now. And what you are getting is going to be 190 ml. So the same pressure control, we are giving 270. I switch out the volume control to 270. I am getting only 190. That means it is compensating for the leak as well as the pressure control mode is very good when you are using a leak cuff. You put a cuff tube, you can use both, anything, whatever you want. It is okay with that. This is pressure control volume guarantee. This is a very good mode and one of the best mode which I have ever seen. What is the pressure control volume guarantee mode? It guarantees the volume, which is the optimal pressure. See, as soon as you put the pressure control volume guarantee mode, you want 100 ml volume you want to give it. Give about 2 times it gives it, and it says it was 10 pressure, then it comes to 8, then 12. For about a minute, it will ventilate and tell what is the pressure to be given for the optimal pressure for 100 ml, and that is volume guaranteed mode. The best part of it is this is also decelerating flow, so it works exactly like a pressure control mode, but it is volume guaranteed. I think it's a beautiful mode which I want to show you. This particular, okay. This is the child which has been put on volume mode. And then I'll show you you see, this is our PCV mode. You can see the PCV 10 centimeter. We are getting it to 200 ml. I did first pressure control mode volume. You put about volume is about 200 ml. When you go to 180, 190, 200 ml, you see the pressure goes up and down and takes some time and then settles down at 200 ml. So I think when you want to pay ARVC, put on a pressure control and tell what is the volume you are getting it. Then that volume you put as a pressure control volume guarantee mode and then switch over to PCV and volume guarantee mode. That will give you exactly the pressure. So pressure control mode, PCV mode, and then it will tell you exactly what it is. It's a beautiful mode. It is quite okay. And third mode I want to tell you is I think if anybody can be given, Neil McIntyre, who is actually 1983 pressure support ventilation as a weaning mode. But now it has become independent mode, fantastic mode. This will be given actually a Nobel Prize because whatever the mode we are giving is the pressure support mode, either in ICU or this is a beautiful mode. And this is actually pressure support mode can be during induction, maintenance, and recovery can be made with the same pressure support mode with all the things. It's okay with that. So I just want to, okay. This is very important. This is synchronic. Why PSV mode was not there for a very long time in pediatric? Because there was only pressure triggering. In a newborn, it cannot take so much of pressure. That pressure difference cannot be sensed by the ventilator, so it cannot give you. So that flow, pressure triggering has become a flow triggering now. So little change in the flow, it will sense, and then that's why PSV mode doesn't come in neonate for a very long time. Now flow triggering has come. This is what the triggering is, very important. The triggering, that is, see, if the patient triggers, goes to ventilator, takes long time to come back, then it is not useful in. So it should be a response time to be fast. That's why the present ventilators are very good. That's the bias flow, which is okay. This is a small baby when they're closing, when they're breathing, you don't have to paralyze. You put them on pressure support mode, then you can extubate. And this is what it is important. I just go to the concluding remarks and then I'll. Okay, I'll just go to the concluding remarks. See, this is induction. Then manually you ventilate, whether you want TPs or no TP. If the patient is without neuromuscular blocker, either go to SIME, PCV, or you can go to PSV or PCV, pressure volume. If you paralyze, you go pressure control mode or pressure control volume guarantee. I think that's okay. Then pressure at the end of the surgery, you put on a pressure support mode, then the child will breathe better than to just keep on spontaneous for a very long time. Put in a pressure support mode, then you extubate, then you okay with that. I think that's very important. Now the present scenario is that from protective, it has become a personalized ventilation. It is not very protective, it will be personalized for each one. The future of the intraoperative mechanical ventilation is converting protective to personalized, and that is very important. Finally, this last slide is very important. Always know the location of the nearest self-inflating bag. If all fails, you can keep a patient alive with the room. I think that's a very important, because when I started in anesthesia in 1991, I told the medical director, I want an ambu bag. He told me, you bought a ventilator. Why do you need an ambu bag? I just laughed because I can't explain to you what exactly ambu bag is. If he doesn't know ambu bag, I cannot explain. So I just laughed at it. When I'm quoting this quoting, I remember that particular incident that happened to the medical director who is the pediatrician. Thank you very much.
May I politely say that we have really overshot
No,
the allotted
sorry, very
time.
sorry, very
Not at all. In fact, I was enjoying it, and I just thought it was so easy to be a delegate.
No, sorry for that, but I thought I'll just.
No, not at all. Sir, you have dressed in a lungi for us. We could do this much for you. Okay, so we disperse for lunch. So please enjoy your lunch in half an hour.
There is a space on the right side. There is a space where you can sit down and have your lunch. It's at the Vivekanand Hall.
रमेश निकाला है HDMI डिस्कनेक्टेड रमेश वाईफाई चलेगा ना
सरांचं लेक्चर चालू कर ना इकडे लेक्चर ऑन करून ठेव ते दिसू दे मला पासवर्ड जे काय आहे ते but let the slide be seen such very easy from like you can just give it over to you so that transition मध्ये टाइम लागतो. All right, now that Ramesh sir has walked in, I am free to start the post-lunch session. Okay. As if we have really reached great strides in natural intelligence, as if I know we've yet to go a far way there. Here is artificial intelligence aiding us. So it's important, I guess, and very pivotal for us to know where are we being led by this and what probably is in store for healthcare, as it were, for this fascinating subject, and things are changing with such rapidity. There is one person through whom I have heard so much, even on the dining table of my own home. All right. So once and for all, I said, okay, let's stop dining table talks and let me once and for all give you some time and hear it out so I don't have to hear again and again. That was the entire reason. Jokes apart, this is one speaker whom I have always known to give total justice and total passion to the topic given to him. I present to you Dr. C.K. Ponde, who is the HOD of Hinduja Hospital, and he is working in the cardiology department for a long time. He breathes that subject, he eats that subject, he sleeps that subject, and he telephones that subject a lot. So over to you, Dr. Ponde. And we have the same surname.
Good afternoon, all of you. So thanks for the organizing committee to invite me here, my wife, Dilip and Ankit and all. And it has been always a pleasure to be speaking in the anesthesia meetings because the crowd is always very vibrant, eager to learn, and of course, close to my heart. Yes. So the post-lunch sessions, I feel, are pretty safe to talk, safe batting wicket, because you can get away with murder. And yet some people will come up to you and say that you spoke very well. So, okay, now let us start. Artificial intelligence. How many of you are students? Can you? Here. So we are all students, particularly in AI. So AI is something, I'll tell you, at the end of, you will realize that whether you want it, whether you don't want it, whether you like it, whether you don't like it, whether you accept it, don't accept it, you will have to live with this. This is the reality, and it's going to grab your neck from all sides in the next, not more, maximum 5 years. You will have to know what is happening. And this all started, approximately 5 years ago, before the pandemic, when I met one of the daughters of my very good daughter of brother-in-law of one of my very good friends. She passed MBBS from Andhra Medical College, and then she, after passing MBBS, she just shifted her career to AI. And she's one of the topmost AI engineers in US at the current time. She's just 31 years old. And I connected with her virtually several times, and I realized that this is where it is. So what is artificial intelligence? All right. Simple terms, artificial intelligence is the process of unifying mind and machine through human brain and computer interfaces. The term AI was first coined by John McCarthy in a conference, The Science and Engineering of Making Intelligent Machines, held in 1956. So it's not something new, but it was in primitive stage. So Marvin Minsky and John McCarthy are called fathers of artificial intelligence, and they give this definition. So you combine human mind on one side and machine on the other side. Why machine? Why do you require machine? Because human brain's computing capacity is limited. I will show you some examples of that in a while. So in other words, the artificial intelligence is theory and development of computer systems able to perform tasks that normally require human intelligence, such as visual perception, speech recognition, decision making, very important, and translation between languages. And also to do the task beyond human intelligence. And I will show you some examples of that as well. Right? So this is a old-time physician. They used to watch the patient, watch breathing, take the pulse, see the respiratory depth, even smell the breath to know the diagnosis, to get to the diagnosis. And in the shadows there will stand an assistant there who will watch the physician and the patient in case they miss something. The physician misses something. Today, you will have AI there. That's about it. You're just replacing your assistant with an AI. So let me put it, the good part, the bad part, and the ugly part. The good part, knowledge engineering is a core part of AI research. Machines can often act and react like humans only if they have abundant information relating to the world. Now, this is very important, I'm telling. If you want any algorithm and anesthesia to succeed, your data feeding to the computer must be immaculately perfect. Then the outcome will be great. If the data feeding is not good, the outcome is not good. So, three terminologies, I will not go into details of that. It is called machine learning and deep learning. In simple words, don't go by this busy slide. Machine learning, you give an information to the machine. You make the machine sit on the information for 2 to 3 months on an average, depending on the data that you feed. And the machine keeps on learning by itself. By itself. Now, this is very important. You understand what do you mean? The machine is living? No. The machine goes through the process of unifying the first set of data, unifying the second set of data. Then it compares the data and comes up with an algorithm. And I will show some examples of that. That is machine learning. Deep learning is the next step. Deep learning is when you make the machine learn and come up with an algorithm. After algorithm, you give the machine real-time patients, new patients, that patients whose data the machine did not have earlier. And the machine acts on it. Now it analyzes 1,000 patients, 1,000 patients, 2,000 patients or not. And then the machine becomes smarter than what it was a year ago. That is deep learning. And to tell you very frankly, when I was speaking to this girl, Sindhu, whom I referred to earlier, she said, until what level the deep learning will go is not in human hands. And that is the biggest catch-22 situation of AI at the current time. So the good part, all right, the good man. So why can AI do, what can AI do for healthcare? Improve accuracy of diagnosis. Bridge the gap between experienced and budding clinicians. Suppose in the casualty, I have a novice medical officer who just passed MBBS and they're sitting just new job. He has not really had an experience. All that he has to do is use 3 or 4 algorithms and that's it. He will get the diagnosis. Feed the basic data. Model prevents spread of infections across the hospital. It can predict the spread of infections. And this we are using at the current time. To tell you very frankly, in Hinduja, we are using the AI for spreading of infections in the ICUs. Automatic detection of relevant findings like pathology and radiology has become absolutely now a rage in US and abroad. For example, you have 100 cut specimens of histopathology of, let us say, prostate. And the pathologist goes through every section. You feed it to the AI. The AI now can give you only 3 or 4 sections which look suspicious, gives you a diagnosis. Then the pathologist has to only concentrate on those 3 or 4 sections, not those mundane 1,000 sections of histopathology he has to go through. Saves time, right? And identify subgroups for personalized decision making. I'll show some examples of that as well. Do we really need AI in cardiology? Yes, of course. Cardiology practice is becoming very complex. It is hard to properly make sense of all data. Hundreds of trials. In cardiology, I feel really blessed because you ask a single clinical question to me today. Anything you have a randomized control trial to tell you what the answer is. It's not what Ponde feels or X feels or Y feels. It's not my experience also. It's not my gray hair. It's not my baldy head. No. It's all about, it is there. RCT. Baap dakho na itar shraddha kar. Right? So, and then so many RCTs. How do you put the data in your brain? AI can help you there. And by combining, this is extremely important, different inputs of data and different processing methods, AI can discover a new relationship of that data to the existing investigation in a way which you never thought can happen before. And I will show you some examples of that as well. So let us start. Is the ejection fraction low? All right. Electrocardiogram is such a primitive thing, right? We have been sitting with that for decades, and it gives you chamber dimensions and chamber enlargement and old infarct and conduction blocks and that blah blah. A group of my colleagues from Mayo, they sat on this and they fed an algorithm, an AI algorithm, data of 2.7 lakh patients, followed up for 20 years, who had multiple ECGs in the 20 years follow-up and multiple echocardiograms and showed normal ejection fraction, right? So this data was on one side. And then they fed a data of around 8,000 and odd patients with low ejection fractions, not echocardiograms, ECGs, basic ECGs. AI sat on it, came up with an algorithm. And this algorithm now can diagnose by simple ECG, patient with poor ejection fraction with receiver operating characteristics, area under the curve, 0.93, 93% positive predictive accuracy. So a patient comes to the emergency room, we take an ECG. You will know which of that patient echo is a must and which of that patient echo may not be or can be done different or later or may not be done at all. So prospective validation of deep learning electrocardiogram algorithm for detection of left ventricular systolic dysfunction and artificial intelligence enabled ECG algorithm to identify patients with LV systolic dysfunction presenting in the emergency department with dyspnea. Here, the NT-proBNP, our basic biomarker for cardiac versus non-cardiac dyspnea, the AI ECG outperformed NT-proBNP. NT-proBNP today costs 3,000 in my hospital, and the downtime from the lab, the biopsy lab, is around 9 hours. All that you need here is an ECG. I will show you some examples. Suppose, for example, this 35-year-old asymptomatic man presents after his sister dies suddenly. This is the ECG. Okay. And all of you all must know that this ECG can be just normal, labeled as normal. Standard ECG computer labeled as normal. We fed this ECG to the AI. AI says 76% probability of having low EF. Referred to echo, ejection fraction 18%. Patient was asymptomatic. 18%. Next, 28-year-old male. His ECG was positive for, AI ECG was positive for low EF, coming for a health checkup. Look at this V1, V2, V3, weird looking ST and T waves. But the AI said, poor EF. Patient was sent for echo. Echo had normal EF. 5 years down the line, same patient developed poor EF. So AI can see what human eyes cannot see. And why the AI can see why human eyes cannot see, I will show you that also. So when they follow up, this is the green bar where AI predicted a low EF and they had normal EF at baseline. At 5 years, 15%, and at 12 years, a close to 1/3 developed poor EF. So you can follow them up very closely. Going ahead, ECG prediction of biological age and sex. Are you kidding me? Yeah, you will say that to me. Yes. So we know that a lot of these things, social isolation, typically older than what you are, right? So age and sex estimation using an artificial intelligence using 12 lead ECG, just 12 lead ECG, and then area under the curve again 0.97. Forget that example. 35-year-old woman presents with a cardiovascular health checkup. Her weight is 106. She's obese. AI ECG says her age is 40.8 years. She is just 35 years old. So we investigated her for a coronary angiogram, CT angiogram, coronary calcium score, lipid profile, everything. She just was pre-diabetic, little dyslipidemic, obese. And then put her on lifestyle modification. She lost 10 kgs of weight. This is the next ECG. All right. After a gap of approximately year and a half, AI ECG now says she's 36.4 years old. These two ECGs look absolutely the same to human eye, but to AI, they are different. The first ECG, her age was 41. Now she's 36, just because she lost 10 kgs of weight. This means weight loss is associated with biologically you become young, physiologically you become young, and that is not an unknown fact. But previously, we didn't have a modality to say that. There's another man who at the age of 38, the AI ECG showed the age of 55, ejection fraction 20%. He kept on medical therapy, and the gap between his chronological age and biological age kept on widening. And at one point, it reached 70 years when he was 53. And then suddenly, he became younger. What happened? He got a heart transplant. So this is what AI can do. So there's a holistic approach of even AI can detect patients who can develop atrial fibrillation. And there's another algorithm by network analysis of one of the biggest hospitals in US. And this algorithm is also very easily available, but currently very expensive to see the patients with AF or not AF. So I'll go to now power of cardiac ultrasound. All right. So now this is a man who came to our emergency department with a chest pain. Smoker, atypical chest pain, normal troponin. But those of you who know echo, this echo looks normal, right? The global longitudinal strain is also normal, perfectly normal echo. 4-chamber, 2-chamber, and apical 3-chamber, normal echo. But when we fed these images to the AI said, no, this patient has tight LAD stenosis. What? And my registrar said, Kunal, give me a break. This man is normal. Send him home. He said, no, sir. I've done twice. AI says the same thing. Okay, fair enough. We did an angiogram, and angiogram shows really. Look at this. Tight proximal LAD stenosis and tight high diagonal stenosis. So then, what did the AI see in these images which you and me and even me could not see? Okay, here is a James Bond clip. Carefully watch. You will ask me, Dr. Ponde, what the hell are you doing? Now, you've seen this clip of 15 seconds. Can anybody say how many umbrellas did you see in this clip? How many bikes? How many men? How many women? How many two-wheelers? How many four-wheelers? How many the hacking carts? How many fruit trolleys? Can you? You can't. Here is the AI. AI will see the clip this way. Look at that. Umbrella, 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 cell phone, man, woman, man, woman, man, woman. That's it. So that means the human brain's capacity to analyze a running image is limited. And there, AI can come to your help. He is not your enemy by any stretch of imagination. So this is what AI can do. So I'll show you a few algorithms which are using in our labs. This is a parasonal long axis view. And previously we used to do freeze image, go like this, like this. You have an ECG, you click a button. Look at this, what AI does. In 1 second, it has given you diastolic dimension, systolic dimension. 1 second. This is a 4-chamber. I used to do mitral flow, right? Mitral inflow. This is a Doppler trace. And then I used to take E wave, A wave, E wave, A wave. Now 1 click, all are average. Can you see that? 1 just click. Similarly, ejection fraction, automatic detection of endocardial border. Previously, used to do it manually. Go under the papillary muscle, then sometimes the trackball will go backward, forward. All that is obviated. 3D auto here. 1 image, parasonal long axis, This is all one click of a button. See what the AI does. Base, this I am not doing this, AI doing. Apex, systole, diastole, processing, ejection fraction. That's it. So your time is saved. You definitely have a lot of extra time at your hands then to do some good work. Now come to artificial intelligence and anesthesiology, right? Here, let me tell you, in historical development, anesthesia was the earliest subject to implement artificial intelligence for your kind information. The earliest. Cardiology started 8 years after anesthesia and now apparently is catching up and probably surpassed anesthesia by a couple of years. Anesthesiology first established the concept and model of pharmacokinetics and pharmacodynamics of clinical drugs model, pharmacological robots. In 1980, servo anesthesia system, you all know, this was embryonic form of automated anesthesia. With the gradual development of anesthesia monitoring, especially anesthesia depth EEG monitoring systems, the open loop and closed loop automatic anesthesia system was established. And in recent years, we have robots, technology robots, and diagnostic robots there. Since 2011, AI in anesthesiology is developing tremendously. Now, where are those developments? One, two types of anesthesia robots currently being used in 3 states in US, Canada, and Austria and Germany. Manual robots and pharmacological robots. Then the eye control RP machine closed loop system, intravenous anesthetic delivery system, which can make your own decisions regarding the IV administration of remifentanil and propofol. Now, Dr. Uday Gandhe, who's a cardiac anesthesiologist working in my hospital, had brought one of these systems and did some small study of 9 patients, but the control was control arm, right, to show which one was better or which one's not. But nevertheless, they work very well. And then all this development. And now the latest one is the use of Magellan robot to perform peripheral nerve blocks. So we will reach there slowly. The Magellan robot currently is not at its best, particularly for pediatric cases, not at its best. But for adult cases, it is quite good. It is quite good. The use of Da Vinci's surgical robot to perform regional anesthetic blockade is also there. And I will show you the father of this approach, machine learning approach for preoperative anesthetic risk prediction. Previously, you used to have some apps on your mobile, right? To put all the variables and it will give you the pre-anesthetic surgical risk, the death risk, morbidity risk, etc. Now, all those parameters you can feed, or you need not even feed the AI algorithm. All the AI algorithm requires only 3 things: age and sex of the patient, type of surgery, likely duration of surgery, type of anesthesia that you have chosen, and only one thing: baseline 12-lead ECG. That's it. It doesn't ask you creatinine. It doesn't ask you hemoglobin. So you say that could be a fallacy. Yes, that could be a fallacy. It can judge the patient's hemoglobin from the QRS voltages in V5, V6. It can judge a lot of things. So we have this probably coming in place. A novel artificial intelligence system for endotracheal intubation. This was published in 2016. Carlson and Torre. The initial efforts at computer algorithms using AI were able to identify glottic opening in over 80% accuracy. And slowly, this is going to develop. Why I'm telling you? Because companies like Microsoft, companies like Amazon, companies like Google have put humongous amount of money in AI, use of AI in healthcare. That is their first and the foremost destination. So they will definitely go ahead all the way. Machine learning models for post-extubation hypoxia during general anesthesia. I think there was a session here, this conference of the patient desaturates or aspirates immediately on the table post-extubation. So these models can predict post-intubation hypoxia. Prediction of the bispectral index during target-controlled infusion of propofol and remifentanil. Again, a deep learning approach. Now, this received an award in the anesthesia conference in 2018, just before pandemic, because this protocol, this algorithm was fed for 9 years and it developed. Automated anesthesia cards reduce drug recording errors in medication administration. And this is the father of robotic anesthesia, associate professor and department. First robotic tracheal intubation in humans using Kepler intubation systems is in place already. And first robotic ultrasound guided nerve block in humans using Magellan system, as I told you. Will AI replace anesthesiologists? Unlikely. Because anesthesiologists require two: cognitive and dexterity. Cognitive AI can replace. Dexterity AI cannot replace. Just cannot. So don't be afraid. You'll be all there. But we'll be with AI. So we know robotic surgery. This is robotic anesthesia. Anesthetist operates it from his home. So anesthetist at home doing robotic anesthesia. The bad thing is the data. AI cannot reason and AI cannot have any bias. So AI does have bias depending on the data that you feed. So the ugly part is the patient's data, which these companies will have, can be used for bad purposes. That is a bad thing. But the potential is there, is indisputable. The question is how to integrate it. And we have obstacles, soothe ethical concerns, and tendency to oversell the technology. And I will show you how world has oversold the technology. Just 1 second. Will AI replace medical professionals? No, I don't think so. I'll skip this. Neither man nor machine can replace its creator. So this is where I stand. Thank you very much.
Let me talk. You can continue doing that. Okay, I am just proving to the audience that I'm totally unbiased about keeping time.
Thank you.
This is for you. Other, I'll get it home and give you.
No, but still we need to be.
Oh yeah, you for the photograph you can. But thank you. It was a very nice lecture. And the last sentence shall make us continue calling you. He did say that we can't be replaced, because my heart was sinking when he says regional anesthesia and robots. And no, can't do. Okay. So now there is a change. You know, there was a thought in me to put simulations at the end because I wanted everybody to stay here because it's extremely interesting and it needs huge amount of participation. But now I just feel that this is the correct time to introduce simulation after AI. So Patil sir, can I request you to come and hold the stage? Patil sir has traveled all the way from Pune here. And he is going to be anchoring the entire thing. And over to you, Patil sir. Can I just have the voice, please?
Dr. Rajendra Patil is a consultant anesthesiologist and ex-HOD of anesthesia at Ruby Hall Clinic in Pune. His interests lie in medical simulation, inhalational anesthesia, low-flow anesthesia, and digitalization in healthcare.
Okay, to start. Okay, good afternoon. I have been promoted to go. I think there's still 2 or 3 sessions going on, right? But simulation, yeah, I think I was just telling them I was promoted, right? Thank you very much for that. And at the outset, we want to, appreciate the effort, all the CAST team is taking, right? You are so much, dedicated, and really hats off to you, right? They're mixing up AI, the regular topic with simulation and everything, right? So really, great effort by all the CS team, right? At the same time, you're all the hallmarks. When I say hallmark, because you're sitting in the hall, right? Since morning, right? Sometimes what happens in CME, there are 3 types of people. Some are stalwarts. They generally go to the stalls, right? But, the stalls, we do not have stalls today. So it's good one. Second thing, there are some people outstanding. Yeah, they always see, places to visit.
I don't think there is a good place to visit around Thar, except I think Lilavati. But I think Satish is already here, so we do not go to Lilavati for that, right? So you're really a hallmark of this CME, and the most important part is our expert. So may I call on Dr. Anida Malve, Dr. Nandini Dave, and Dr. Gunjan and Dr. Saroj. Please have a seat, right? We're going to have a interactive session, right? This is not going to be a presentation, no slides, nothing. Okay. At the same time, we were young. Yeah, please. When we were young, there was a movie called Roti Kapda Makan, right? I think Zinataman was the actress. I don't remember the hero because of my age. But anyway, and these are the basically three main things, right? Necessities: roti, kapda, makan. What are the necessities now? Mobile, charger, and Wi-Fi. Okay, because roti you can get on Zomato. Yeah, kapda you can get on Manyavar. Makan you can get on Magic Bricks, right? And everything you can get it on this mobile, isn't it, right? But at the same time, we are going to communicate with you or interact with you through this mobile. Okay. So can we just have a slide? So you will be sort of immersed into this simulation scenario. So what I request, I think you can see from here, right? And the only limitation of this is that there are only 50 slots available, right? So when we can see, yes, yes, sir. Right, so we're going to use Mentimeter. You can or Google, just type on mentimeter.com and just put this code, which is 37308832. Once you're done it, you will be connected to the present current. Are you connected? Most of you. Code is there. 37308832. Mentimeter. Yeah. It will ask you which the code. Yeah. Or you can scan the QR code also. Right. So I think most of you are already connected, right? In the morning, Dr. Brushari shown a beautiful, picture of Emirates Boeing, right? The takeoff and the landing and everything, right? And most of the time, the anesthesia is sort of compared with the aviation, right? What are the two differences between aviation and anesthesia? Anybody can answer. We always compare anesthesia with aviation. What are the main two differences? Autopilot, you can go on autopilot. Anything else? Pilot is not? Absolutely. Pilot is in aircraft, right? When we give anesthesia to a patient, yeah, given to him. So whatever risk he's having, patient is having it. Here, pilot is sitting, right? So he has to be, even if you forget about the 200 passenger, he is also going to have a problem if anything goes wrong. There is one difference. What is the second difference? What is the second difference between pilot and the anesthetist? It's a one-to-one, isn't it? We got one patient. He has got 200 passenger, maybe 100 passenger, right? And they have been doing this simulation, right? Nobody can just go on a pilot seat and take the plane off, okay? They have to undergo a lot of simulation training before they actually go, right? What happens in anesthesia? Somebody department, 1 month, he goes around here and there, and then one day he's asked, okay, final ke liye wash up ho jao, right? Suddenly he's under so much of pressure, okay? There is surgeon watching you, there is, consultant watching you there, and, you don't perform very well, isn't it? Okay, because you're not out of pressure, right? But if you happen to have simulation environment, okay, you can do this 100 times or n number of times. Okay, we got task trainer, we got high fidelity simulator, and you can actually practice spinal, intubation, and all sorts of things. In fact, the one which we are using it now, it's a high fidelity simulator. We can actually intubate and give anesthesia. You give oxygen, you give nitrous oxide, and the mannequin will throw up the CO2 also, depending on how much tidal volume you're giving, how much rate you are giving, right? So we have gone up to that far also, right? So basically, this is going to be the future now, simulation. And slowly, in fact, the NMC has made it mandatory to have a simulation lab in all the medical college, right? All the training before they actually go to touch the patient, right? So we're going to show you one scenario here. Right. So we're just going to have a little bit of insight what is the simulation and how it's going to change the future of the medical education, right? So we have got all this expert, right? So we're going to just show you one scenario. It's just for the one example, which is actually quite frequent, right? So this is the scenario you can actually watch on the video. It has been recorded earlier. Right? So this is basically a 3-year-old male child, 22 kg, obese, and posted for a daycare circumcision. Okay, he was unremarkable. Only thing he had a runny nose for a day, no cough, no fever, quite anxious. The parents are anxious. They are not going to let this child go in, right? They said, no, don't do IV here. Let first do anesthesia and then, right? So we are going to have the scenario, right? This is just the pre-briefing. Then the Wi-Fi is bit. You will be able to see on your mobile. Right. So there will be question coming to you now on this scenario. Okay. Obese child, no IV line, and just goes into pre-induction or during the induction, the laryngospasm. Okay. So what did you feel after watching this scenario? The single short answer you can give. So you will have a, they will have to type. Yeah. Yeah. They got this question on their mobile now, and then we can type, right? Scary, helpless, right? So the more you put, it will keep on coming. Yeah. Pathetic, chaotic. Ask myself to deep breath. Crisis. Okay, helpless. So more you put, the more answer will come here, right? So I just request you all of you to put your answer, and this is going to be very interesting and interactive, right? Yeah. Right. So if you can see here, mostly it is scary situation. I was scared, helpless. It is basically chaotic, isn't it? Yeah. And then there are quite a few answers. Lack of IV line, difficult situation, senior supervision is required, multiple. Right? Okay. So earlier you answered it quickly come, right? So we're going to move on to the next question now. Next. Right. The next question is, I think we'll need sir AI for the quick Wi-Fi. Yeah. Have you ever been in this situation? I think that they probably already got it on their mobile, right? Right. So 49 responses. Yes. Good. And it will keep on coming, right? So almost 60% of the people think that they were probably in this situation earlier, right? So this panicky situation, we had got scared, and it's basically it's not a good situation anyway, right? So we'll move on to the next question now. Okay. Okay, what went well in this situation, simulation scenario? Just one answer. So using this scenario, what went well? Just one answer. Call for help. Early help. So the more they answer the same thing, the call for help will go bigger and bigger, right? So that was the one good thing actually they did. So basically they call for the help, okay? And that was a good thing. It happened during this scenario. Now the next is very tricky, okay? There are quite a few answers. The senior and consultant come, senior call, United. So we'll go on to the next one now. What challenges did the team face during this induction? You can have multiple but short answers, okay? Not very descriptive. So what challenges did the team face during this induction? Cold, difficult IV, obese patient, yes, no IV line. Right. So basically the challenges mostly there are, one thing is obese patient, there was no IV line, and or rather difficult line. And there are multiple questions, running nose and all those things, right? Cannot ventilate. That was one of the things. And probably, typical IV access. Somebody said laryngospasm also. So, right, what will be your next plan? Multiple shortcut, right? You got this scenario, and then you have got this child, is not breathing now, and there is no IV line. What you will do? Multiple short answers. Parsons maneuver, CPAP, oxygenate, aspiration, LMA, deepen the anesthesia, intramuscular injection. So mostly if you see the CPAP, Larsen maneuver and LMA. Okay, I think it's coming up with so basically this will be the next plan, and maybe deepen the anesthesia. I am schooling also, I can see here. Okay, and then so we are going to we know the situation now that we have got this patient who's been taken. There was no IV, and during the SIVO induction, we cannot he went into laryngospasm, right? So we're just going to ask the panelists now, right? What will be your first choice, right? Anybody can answer, right? And I think we got mic ready also. You can get one of the whole right? What will be your choice in this situation?
Anesthesia.
Okay.
And maintain oxygenation is our first priority. It has to be there. And if the laryngospasm is partial, we can deepen with help of sevoflurane.
Right. A very smart answer. We'll talk to it later on, right? But basically, we have to deepen the anesthesia. In that case, we'll just increase the dial concentration of the CO. Anything else, madam, you can do?
Question was, what is your first choice in terms of...
What will you do next? You got this situation now. The child is desaturating now, and we know he's gone into laryngospasm. So what will you do next?
You've already called for help. We are giving 100% oxygen via CPAP.
Right.
We don't have an IV line, so we cannot give propofol.
Right.
We will continue to give the sevoflurane in the hope that something goes in.
Right.
But at the same time, now the only option is succinylcholine.
Right. Okay. So basically, CPAP with 100% oxygen.
Larsen's maneuver is going on.
Larsen's maneuver. No. Forget those were their answer. Now we are asking the panelists.
Beyond that.
Yeah, beyond that, or whatever is the base thing, right? So basically, as she said, we have to deepen the anesthesia. So increase the dial concentration. Second side, you will say oxygenate with the CPAP. Anything else you will do?
Proper tight fitting mask, give a good jaw thrust, give a CPAP, and Larsen's maneuver.
Absolutely right. Okay, jaw thrust will help, right? Some maneuver here.
Yeah.
Okay, it make clear, right? So jaw thrust will get Larsen maneuver you will do. Anything else, sir?
And during no time, there should be any interruption in attempting to oxygenate the patient. We should not just leave it and go and check for some other help, call for help. One person should be absolutely with the patient, with the mask, tightly fitting mask, and try to do possibly whatever oxygenation he can do.
Right. So first thing will be the early recognition. Do not waste time, right? We know this is spasm, tight fitting, and we cannot let the oxygen going in, right? So first thing will be the call for help. Second thing will be the stop stimulation. Whatever you're doing, you may be doing suction. Somebody may be just taking the IV line. Okay, that if the patient is light, plane of anesthesia, just putting a line also can, stimulate the spasm also. So stop whatever doing. Third thing, IV, airway manipulation. Madam already said, you can do jaw thrust, you can do chin lip, and then you can do CPAP with 100% oxygen. Deepen the anesthesia with sevoflurane. Okay, now you said something about partial.
Laryngospasm is complete. Then whatever you are giving through the mask is not going to reach the lungs.
Right.
So in
for the
that
point,
case,
basically, even if you increase the dial concentration, nothing is going in because, right? So what option we have got last in this situation?
then
She already
she
said.
yeah, we have to go in for succinylcholine and
Succinylcholine, right? Okay, so we'll give some muscle relaxation. And I think base choice will be succinylcholine. Anybody has got anything else apart from this answer? You can raise your hand. Yeah, yes, sir. Excellent, right? So we are basically coming to the succinylcholine, right? So we do not have an IV line. Only thing we have got in this situation, we are giving CPAP now. But as she said, if it's complete spasm, we're not going to get anything, right? So base option is to catch hold of the succinylcholine. Okay. And succinylcholine, we do not have an IV. So basically, we need to give intramuscular, right?
better to give along with atropine.
Okay. Why? May I ask you?
Yeah, because already because of hypoxia, the chances are very high that the child has gone into bradycardia, one thing. And plus with succinylcholine also there will be additional bradycardia.
Right. So basically, succinylcholine bradycardia, again, I think we can talk later on because it will take another 20 minutes, right? But if you give repeated doses of succinylcholine, it is going to cause bradycardia, right? So prophylactically, you say you can give atropine with that, right? So with the next question goes to what alternative routes you will be using in succinylcholine. We already said intramuscular. right? Yeah, they are already putting it. Very good, right? So we have got almost, 60% people saying we should give intramuscular. Okay, succinal schooling. There are some other routes available like intraosseous. Okay, sir already says, intralingual you can give, right? And intralingual, again, we will talk it later on, but these are the three options available. We have got one is intramuscular, one is intralingual, and the intraosseous. Okay, next one. If you give IM succinal colon, you already say that you might get some bradycardia if you give it repeatedly, right? But any concern, right? Multiple short answer you can try. If you give IM succinal colon, are there any concerns? Onset, very good. Bradycardia, you already said. Slow elimination. What are we worried about? Slow elimination? Probably. Delay in onset. Delay in onset is coming up. So basically, what are we worried about? It's going to take some time, right? How much time it will take, and how much dose to give. Okay, right. So next one we can go. Right. So I'm going to ask one of you how much dose will be giving, if at all, intramuscularly, and they have got a concern how much time it will take, because most of the people said it is going to take some time, right? So how much dose and how much time?
4 milligram per kg we can give, along with atropine 0.02 milligram per kg. And if we'll give intralingual, it will be acting about in 45 seconds or so. But if we are going to give intramuscular, then it means in deltoid or something, it will be acting. It will be taking time. It will be taking about at least 75 seconds to 1 minute. So by that time, I think with the hypoxia itself, it will open up otherwise.
So basically, we will talk intramuscular for the timing. So dose will be 4 milligram per kilogram, right? So we know the dose now, right? Somehow, whenever we talk about schooling, we are always concerned about something, right? And most of the people, means there is a debate also whether the succinal schooling will be off shelf now, right? No, but succinal schooling is the good drug, especially in this situation. Only thing we need to know the doses and everything. And unnecessarily, there is something called as, suxphobia. Yeah, suxophobia, right? So basically, don't worry, atropine, bradycardia, we are used to bradycardia and we can give atropine, whatever, yeah. But succinal choline is the right. We can give intramuscularly, we can give 4 milligram per kilogram, right? Peak effect, it will take 3 to 4 minutes, right? So we have got this situation we need to do, right? Only thing that we don't have to wait 3 to 4 minutes, because for 3 to 4 minutes, that will be the action for the intubation for the cord, right? But you can have 45 seconds to 1 minute, you can actually break the laryngeal colon, right? The duration option will be 20 minutes because you're giving it in the intramuscular. That will be the only concern, if at all. But the dose will be 4 milligram and it will take just 45 seconds to act, right? So that will be the savior in this situation, right? Any side effect? I don't think there is any side effect. Yeah,
just one
you can interrupt me anytime.
Just one comment. If the child is already hemodynamically unstable, like if the circulation is not good, this absorption from the intramuscular is going to be affected. So in that kind of a situation, it is better not to go for this.
Absolutely. Just, you just got this point. Patient in a shock, okay, or something, it might not get, good circulation. There may be delay in absorption. So we have to, just give some time. But as we said, breaking of laryngospasm will just take 45 seconds. Okay, madam, want to add? Yeah.
Suppose the patient has already gone into cardiac arrest, then you will have to go for the intraosseous route. That will probably be the only instance of giving succinylcholine intraosseous.
Absolutely, right? So, right, we'll come to intraosseous, and I think that will be the choice of route, especially when you are perine. Yeah. Platisma. That possibly sternocleido and yeah.
That dose.
Right.
So
the blood supply will still not be totally gone from there. The most peripheral ones will lose it the first. So there is a possibility, and you still not probably moving away from the jaw which you were holding well. Maybe by one hand we can quickly.
We'll come to that, madam, intralingual, right? But intramuscular, because we are all used to it, right? And we got deltoid, we got, something on the thigh we can give, and then quickly you can basically, within 45 seconds, you can break the laryngospasm, right? The next question is, if at all you are giving intraosseous, said, are there any concerns?
The time
Patient to the audience, yeah.
The time it might take, but then if you have no choice, then
yes, madam, you can just put it now. I think you are. Yes. No, it will come. It will come on this here, and then I'll ask you, madam. Yeah. So basically, if you just type it there, everybody can see then, and then depending, you can have the majority. What the majority people say, the technique. Yes, IO needle. You will have to have IO needle. Difficult. Okay, difficulty. We are not used to it. Basically, we don't do it every day, right? So that will be the problem, right? But so the problem here is we are not doing intraosseous that often, right? Maybe once in a while. Okay. So basically, the technique we do not know, we're not used to it, and it may be difficult sometime, right? Where to inject, or you need a special cannula for, right? But otherwise, that is a very good option. Okay. Right. So for this, we have, we are just going to ask you, if at all, right, you want to give intraosseous, what are your concerns? Right? We already said it may take some time. Okay. We may not have, IO needle available, right? But if you want to give intraosseous, how much will be the dose? How much, what will be the peak action?
The intraosseous dose is equivalent to the IV dose.
Absolutely, yeah. Right? So you don't have to worry about you think about the doses. Intraosseous is just basically an alternative to the IV line, right? So whatever your dose you're giving, maybe a 0.5 to 1 milligram per kilogram, you can give same dose, right? Previously, it used to be 1 to 2 milligram, I think. I think the scoring dose has come down quite low now, right? So we are now basically giving 0.1 to 1, right? The same dose you can give intraosseous, and we need to get
the only thing is, I would be mindful of the fact that by the time I maybe thought of IO and doing the IO, maybe patient is arrested. So it would be also with CPR going on, something to get the circulation going is what I would presume.
Yes, yeah, a very good point, right? Because you are almost lost 1 minute or maybe more, and you are trying to get IO line, you are almost near to the peri arrest situation, right? So you're going to need an IV anyway later on. So might as well get a intraosseous line. Yeah. Okay.
I completely agree with you. We are thinking that laryngospasm has not broken and we have reached there. Otherwise, usually with hypoxia, you never reach.
Laryngospasm is still there, and we are now, 82, 72, 62, right? And you might get a tube in at 42, right? Right, but so basically, in the meantime, you can get the intraosseous line.
May I add, sir?
Yes.
So this, I think the group is consists of all stalwarts of pediatric anesthesia. I don't know if junior residents or senior residents are there sitting at the back. I personally feel that administration of schooling in such situations depends on how experienced you are. If I am a JR, I don't think that in the next 5 minutes, 10 minutes, I'm going to get my faculty with me. Maybe I'll just go for my intramuscular, administer intramuscular schooling. If my seniority of 15 years or some stalwarts like them, maybe I can directly go for intraosseous. I know that I'll not be wrong. I'll be placing my needle at the right place and administer drug. So that's why I think this buffet of the administrative sites is there. Whatever you are comfortable with, don't waste time and administer at the site. Later we can discuss as to what was more efficient.
Right. So basically, point to take home is whatever you're used to it, right? IM is the most, right? We know succinylcholine is the drug of choice, and we know we are very much comfortable with the IM, right? So first we can do, right? But if you're in an intensive, right, you have been managing intensive care all the time, you've got a specific or dedicated pediatric anesthetist, you've been doing intraosseous, quite a few times, then we can actually give. In fact, in simulation, we can have practice on a task trainer. Okay, we have got mannequin, we got a task trainer, we can actually do intraosseous, right? In case of emergency, no, you should not say I'm not seen intraosseous in my life, right? Okay, so we can do it and you can get it in the emergency situation, right?
Dr. Raju, if I can just say one point here is that I totally agree with Vaishali, because by the time your patients become hypoxic, the laryngospasm is broken. But the point to think is that intraosseous is an available route in such an emergency situation, and maybe not scoling, but you would need adrenaline there through the IO route, by then. And you remember you have an obese child with no IV line.
Right. So we are just discussing, what are the other options also available. So IM is one, intraosseous is one, and we are going to talk now intralingual, right? Has anybody of you has given intralingual, right? Because I think not intramuscular also, right? But this is good to know in case, because as madam said, the intralingual will be in case of a child who has got a poor circulation, we can have an intralingual, right? Okay, and these are the basically concern, right? If you give intralingual, right, when the peak effect will come, onset time 5 milligram, right? So what will be the dose? Oh, yeah. So basically, intralingual is essentially an IM injection into the body of the tongue. Okay, so you can either give intra-orally or you can give submentally also, right? So this is going to see. So dose will be 2 milligram per kilogram. Time to break the laryngoscope is 75 seconds, right? So just a little bit more than the intramuscular, right? So maybe we can go for intramuscular, but if at all, right, they had encountered some unexplained arrhythmia also with intralingual. The reason we do not know, and recovery might removal of the tight fitting CPAP, right? When you want to give intra-orally, as madam said, we need to take out the mask, right? So you're again losing time. If at all you're giving some CPAP, going to push some oxygen, but you're going to take for 2 seconds, right? So then what choice we have got is the submental basically, okay? And again, the dose will be 3 milligram. Time to break laryngoscope is again same, and it is injected into the tongue underneath the jaw, the tongue base, right? You can go on the books, and then we can see actually basically there is a good demonstration there, and we can actually just put a in the center, so we can directly go into the tongue without actually remove the mask. Right. So we know it is intramuscular. So we know it can give intramuscular, it can give intraosseous, we got right. And there was this study, record study, anesthesia practice in children observation trial. And they said that, they have done this study in almost, 200 plus hospitals in Europe. And they found that the severe critical incidence is almost, 5.2%. Out of that, respiratory critical incidents were quite high actually. Okay, almost, 3%, right? So 5.3% is, quite high. And the laryngoscope incidence is quite high, right? So it may happen. And you already said that in the beginning, that this problem can occur. Laryngoscope, suddenly you are exposed to a situation where you cannot ventilate and there is no IV line. Okay. So what will be our main goal? Identify and removing the stimulus. Then we can apply all the airway maneuvers, and then administrating the anesthetic agent, right? Either you can use sevoflurane, given the anesthesia, or you can use the intramuscular vaccine. Right? Now, we cannot just go away telling about this anesthesia and non-technical. Okay? I'll just tell you the situation. You want to learn driving. You're going to ABC driving school. The person is sitting, you know how to drive your car now. Now, suddenly tomorrow you got a license now, driving license. Tomorrow I'll tell you, now you go to the Sadashivpet in Pune and drive. Okay. You go there, you will see the cat crossing. There will be 2 cows sitting on the road. Yeah, this happened on Tirak Road, typically. I'm not joking. Yeah, I just seen this, right? And then you know how to drive, but you cannot go ahead. Okay, and you're stuck basically, right? So if you are in this situation, right, simulation will give you some idea, right? So what we do in the simulation scenario, we are actually doing this simulation scenario on a mannequin, and then you get to know all this previous, sorry. Right? So basically, you need to have a good teamwork, right? Whenever, because pediatric anesthesia is most of the time it's team, right? So you got to know your senior registrar, there is somebody assisting you, right? There has to be a good team working, good task management, situational awareness. If somebody comes senior, right, that person needs to gather all the information, and at the same time you have to do a quick decision, right? So these are called anesthesia non-technical skill, right? So apart from technical skill, you need to know non-technical skill also, and this is best done through the simulation. Okay, next. Right, so there is a good infographic available, right? And this is from one of the hospital in Boston, right? So they have put a good infographic, right? And the moral of story is that basically, if you so basically what they say here is the early recognition, stop simulation, airway manipulation, CPAP, and then use the muscle relaxant, right? Okay. And the next thing, right? If you want to prevent laryngoscope, okay, what you should be doing, right? So there is one more here is during the induction, you should be well prepared, preventer, right? Anything else you can think of, right? Suppose you got a child with a running nose, and you probably think that he might give you trouble, right? What things you will do to prevent the laryngoscopy? Sorry, laryngoscopy.
Maybe anti-sialogogue pre-medication.
Anti-sialogogue,
Yeah.
glycopyrrolate.
Because already you're saying running nausea. So
Okay.
orally you can give.
Should be there to deepen the plane of anesthesia most efficient way, rather than struggling with the amount of SIBO or amount of propofol which we are giving. Maybe let's go out from this case. We have IV and propofol doses has not been given adequately, or fentanyl has not been given adequately. Maybe that planning has to be there prior, that this is the amount of drug which I have to give for the 1-year-old child, for the 3-year-old, for the 7-year-old. That I think can make a lot of difference.
Scenario, I feel one or two things I wanted to say. Considering that the child was already obese, had a running nose, and needle phobic, the senior should have been there right from the beginning. OT should have been well organized. If you see carefully that scenario, the one person is holding the mask. The machine is way behind. For changing the sevoflurane, he is asking the another assistant that you go and change. Meanwhile, nobody is holding the patient. Now, in a practical scenario, practical situation, they in and out in the theater. I always say that when you are doing a mask induction, always one person has to be one assistant or somebody, helper has to be holding the patient, because you never know, suddenly the patient would move. And I have seen even the patients falling from the, OT table also. So it's quite dangerous. And the machine has to be at a handy. Machine cannot be behind your back. It has to be on the side. The sevoflurane vaporizer has to be accessible to the person who's doing the mask holding, because the same person is leaving the IV line, going, changing the dial concentration, coming back to IV line. So those precious moments are getting wasted. So I think the most important crucial thing is a well organization, well planning of the OT ergonomics also.
Right. So if there is so basically, if there is a UITR, right, and it's not emergency, obviously you're not going to take the child anyway, right? But if you happen to be in this situation, right, as Madam said, we need to have a good teamwork, and there has to be good communication, good coordination, right? And as Sir said, that we need to have a good deep anesthesia before you do any airway manipulation, whether it is a airway or you are doing a suction and everything. Okay. And the last one, yeah. Right. So last two questions now. Generally, at the end of the lecture, we said this is the take-home message. Now we are going to ask you what is your take-home message. Right. So you can put your take-home message from this generation. Okay, maximum 2 answers. Great. Proper planning. Yes, proper planning is needed. Teamwork has to be done. Be well prepared. Okay. Proper planning. Yes. Prepare well. Good. No. Excellent, right? So, yeah, the 2-3 points are very important. Anticipation, especially this high risk patient. Second is good teamwork, good planning, call for help early, and somebody said mock drill also, right? And the last question here goes to no inhalation induction, no IV line. Yes, sir, I'll give you a chance. Okay. Last question, sir. How did you feel at the end of this session? Please give your feedback, maximum 3 points. Right, so this is basically, also in the future, it's going to be the way of medical education related, right? So whether it is spinal, intubation, or maybe laparoscopy or robotic. So simulation is going to come in a big way, and that's what we wanted to give you the message, right? Thank you very much, right? So at the end of the, yeah, just one sec. This is good for me also. Amazing, good, great, good discussion. Yeah, well prepared, happy, very good, right? So thank you very much, all the panelists. Dr. Yeah.
No, please don't leave. Please don't leave. Yeah, I know. I'm a reflex. Like if somebody sees me on the stage, it's time to say bye, is it? I guess you're going to remember me for a very long time. Now, by the way, by the time they do this, this was inspired, this video sketching, a deliberate wrong video sketching was inspired by an editorial written in 2007, which said which port in a storm, use of succinyl scoline without intravenous access for severe laryngospasm. So please do check out, and it's exactly what all the experts have said it here. And thanks, Anila, to really point out what I wanted somebody to point out. Thank you so much. So thinking alike. And Rajendra sir, I never knew you were so charming when you conduct. Anyways, you are, but while you conducted even more.
Thank you very much, madam. Yeah, I think we live up to that expectation.
Thank you.
And all the panelists, obviously. Thank you very much. Yeah.
For grouping call, and it's not all the way here. The simulation help. Anuya, Colonel Gunjan is from the armed forces, so we've seen to it that it's not just the civilian CME, it's even the armed forces here. Thank you. And Nandini, a very cherished and dear friend, and she's a past HOD for in KM and started the DM and now an HOD in SRCC and marinated in pediatric anesthesia. And may I introduce another dear friend, doesn't need an introduction at all. Anila Malde has always been with us. And Anila, thank you so much. Another talking encyclopedia, pediatric anesthesia. Thank you so much for being here. And Saroj, one phone call and you agreed to come here. I'm so glad. And Anuya, thank you for doing the honors. Thank you. HOD KM, pediatric anesthesia. Thank you so much. So
Amol has helped me.
Yes. It's time at the end of the day. All right. So now there's a reshuffle going on here. I guess after Dr. Dilip would be Dr. Kriti and Dr. Ramesh for the quiz. So Dilip, over to you. No introduction for you. Just jump on the topic and finish it in 15 minutes.
I think so. I need to be very faster than Dr. Ramesh. Good afternoon, everyone. Before starting my lecture, I would like to thank Dr. Bagdi. He is a very senior pediatric surgeon in Mumbai, and he has inspired Dr. Ramesh to become a pediatric anesthesiologist. And yesterday he agreed. I was in a PEDAL conference, and yesterday he agreed to come here. Hello, Thank you, sir, for coming here. So let me go to straightway to the topic because I have only 15 minutes and I need to cover a lot of complications. So let us see this is the practical lecture where what complications can go and how you need to be correct. And then there are the few cases which I'm going to show where what deadly things can happen and then how it need to be treated and then need to be done. So any procedure if you're going to do is going to cause an injury or some sort of thing. But what our main motto or purpose is that we need to avoid lesser injury and lesser complications of this. So what are the complications which comes in a central venous? So I am talking about IGV, subclavian or a femoral vein cannulations, and then few practical tips how you need to proceed with the procedure. So complications, mechanical, what during the procedure can happen, an accidental arterial puncture can happen, embolism. I had seen embolism because a guide wire has gone inside and then the retraction which has been then the cardiac component and the pneumothorax and hematoma and then so on, so many complications which are there. So let us see what is most important when the complications happen. The plan of the procedure, then it is important to have a preparation, like how you need to prepare. If any complication happens, before starting any procedure, one has to know that if the complication happens, how you're going to treat immediately. So this is what it is important. And then the execution has to be done in a systematic way. So let us initially I will show you the good part and then we will go to the complications and what can happen. So any procedure, central venous cannulation requires a sedation, whether it is a preterm babies, whether it is a neonate or any sort of children where you're going to. I'm purposefully talking about because we have been called for the central venous cannulation in the ICU, and then obviously in OR room we do a lot of central venous cannulation. So obviously the best part which can be used for the sedation purpose is the midazolam ketamine combination, what you should be able to use. So there are various ways of doing the cannulations. As I said, that IV induction is important, and then in ICU, you can just put a nasal prong, give some sort of oxygenation, and then in case of extremely preterm babies, where we do a lot of preterm babies central venous cannulation. So if in doubt, just intubate, so that after 1 hour or so, we can just extubate those children. Important part, listen to this one, is that a shoulder roll plays a very, very important role when you are putting a central venous cannulation. So just see a towel roll which is easily available. So this is what you can see is that for a 500 grammer baby you can use, and just one fold you can use for 1 kg and so on. So this fold which will give you. So positioning, why the shoulder roll? So I'm going to show a video how it affects when you are doing a central venous cannulation. If these things is not available, there are the IV bottles, which is like 100 ml, 250 ml, and 500 ml bottles. So 100 ml bottle can be used for till 1.5 kg or 2 kg child, and then so on. You can use 250 and the 500 ml. So let us see the proper positioning. If you see in this child, is that too much shoulder roll which has been applied. So what has happened? Extension which has been there, and then if you see on the ultrasound. So there is a lot of stress, so it becomes very difficult. So you get the IV cannulation, but it is very difficult to pass a guide wire sometimes, because see what happens when, unless and until that gel co which is there. So I'm going to come, what are the other modalities what you can use in this sort of situation. So if too much stretching which happens to the IGB, so there are chances of counterpuncture which is much more high. So positioning, as I mentioned earlier, is an important part. Secondly, the 15-degree inclination you are putting for an IGB cannulation. So this is what we should do. And let me show you the normal central venous cannulation. So this is and take the patient in the OR room. This is what the technique where we tie the mask under the CO fluorine, and then give the good position. So this is like a 2-month-old child, and you just tie the mask and give a good shoulder roll as mentioned earlier, and then you start the preparation. So whether you are experienced person or whether you are inexperienced person, this sort of thing has to be organized because it helps you for doing a good central venous cannulation. So Gelco, then you add the guide wire, then the knife has to be there, dilator, and then make sure that before starting the procedure, both the ports has to be flushed, because there are two or three times in my career incidents which has happened that one of the port was blocked. So it is important before doing the procedure that both the flow, like if it is using bilumen, ortho lumen, triple lumen, so all the port has to be flushed. So this is the port preparation. What we need to do. Important thing is either you can use the glove technique where you can sterile technique or a camera cover which is available. So this is what you do. Once the positioning is done, and then you can start the procedure. So in pediatric patient, almost 90% of time we feel that is that you just watch the procedure. I will speak certain few points is that never ever you will get exactly what position, what you want to see the sternocleidomastoid, and you will see the apex and everything. It doesn't happen. A lot of time it is now a chubby children are there, which is so. The best way of modality is that if you have an ultrasound, you can use. So you see the trachea, the carotid, and then the IGV. So this is out of plane approach. Why I am, again, one of the most important point is that why I am using a plastic cannula. Never ever try to use any rigid needle in the central venous cannulations, because if in a 1 kg child or 1.5 kg child, if you get with the ultrasound and everything, even the slightest movement, what will happen is that you will do the counter puncture. So this plastic gel, if you see it remains there, and then you can do a central venous cannulation. So this is what it is. Again, important point is that always make sure that you measure the guide wire from the site of intake till the second rib. So that is what it is, or just observe the arrhythmias which is there. Never ever try to force the guide wire. I'm going to show the complication, what happens if you try to do a lot of forceful guide wire insertion. So this is one. Secondly, if you see, there are the blood on the guide wire, which we see, it becomes a very difficult if you don't wipe the blood over the guide wire, because it becomes very difficult to pass the catheter over there. Again, important point over here is that the dilator. So dilator one has to be very gentle when you are inserting the dilator. Otherwise, a forceful insertion of the dilator will happen, the kink of the guide wire, and then everyone will start blaming the guide wire. So it is important for make sure that the guide you have to do a gentle dilatation. So that is how it is. So once the dilatation is done, and then you pass the guide. So the rest all of the procedure remains same. But one point before completing this one is that the suture has to be exactly front of the wing, because if you try to take the stitch from the side or from the back side of the wing, so what will happen is try to push the guide wire, the central line outside. So it is important that this has to be the stitch has to be from the front of the wing, and so this is one. And then if you see on the second side, if you take the stitch exactly, it fits the guide, so infection chances are reduced, and the other complications related to the central line, which has been is reduced with this one. And always make sure that you put the tega down, where you can always watch the central line throughout the duration till the guide the central line which is there. So this is the normal position where ideally it has to be RA-SVC junction has to be there. So let me show you the neonatal cannulation. A lot of people must have seen these slides before also. The only important point in a neonatal cannulation is that the procedure remains the same thing. This is almost 1.5 kg child, and if it is in patient, is never ever try to use a bigger syringe for aspiration, because patient, if you try to aspirate with a bigger syringe, already you will see the collapse, and even if you are into the vein, you will like make a false impression, and then you will try to do another procedure. Believe me, first single attempt is one of the best attempt. After that, it becomes a chaotic situation. So this is how it is. So what happens? I'm going to come. So in the left side, it becomes a very difficult situation of you will get the vein, but guide wire becomes very difficult to pass through this one because of acute angulation between the internal jugular vein, and then it is going to the brachiocephalic. So it becomes difficult. There is an acute angulation. So you get the vein, but it becomes very difficult. So what you can do is just the technique what we follow is that just little bit of bend of the guide wire. If you have a J tip, then it is fine because then you can that J tip should be facing towards the sternal end. So it will help you to pass the guide wire. So this is what the left IGV cannulation has to be done. Everybody doesn't have the facility of using the ultrasound. So what we can do is that we can use the landmark techniques. So only point over here is to be remembered is that what I do is that make sure that your index finger is always on a carotid and the direction of the needle has to be on the ipsilateral side. Again, important point over here is that at what depth, remember at what depth you're going to get the vein. So that much only insertion with the 15-degree angulation has to be, your needle has to be inserted. Once it is done, take one syringe, as earlier mentioned, that never ever try to take a bigger syringes, and then this is what you get. The procedure remains the same thing. So what happens? There are multiple cells. Sometimes you don't have ultrasound machines, and then you try to use the with the blind technique. And if you see on this one is the puncture, which is here in this slide, you can see the puncture which has happened, and then the hematoma form around the artery. You need to do once the hematoma, just go ahead little bit of the hematoma which has happened over the side, just go little the proximal, and then you start the insertion of your start the technique of putting the catheter. So this is the gel co. So if you see the compression which has been done, and then if you another point, if you have noted that I'm exactly into the middle of the lumen of the vein. In the hematoma, you cannot take a second chance of puncture because there are chances of again hematoma formation which is much more high. So this is what has to be made crystal clear in this one. So this is what it is. Just day before yesterday, I got a call from the NICU, and this was like this baby was 1 kg child, 1.2 kg child, and was in a shock. Almost heart rate was 240, 230, and wanted. So I just wanted to show what happens in a shock patient. Also, is a good appropriate the position. And if you see the carotid, which is a very flickering, you cannot see exactly the like a pulsation of the carotid. So then, still, in spite of that, the important point which if you see, I rested my little finger on the chest and just gently put the probe onto the vein, and this is what it needs to be done. The cannulation has to be done in a better way because again, patient is already in a shock. You need to infuse, or otherwise, if this fails, then what are the other options? This is already 1.2 kg child. You have failed with the umbilical cannulations. Nothing has been remained. So this is how. The cannulation has to be way. If you look at this one, is that exactly keep into the thought is that at what depth, even with the ultrasound, and then you make a success with the IJV cannulation. So this is what it is. So there are a lot of people. They take a lot of mistakes of cutting the guide wire. So I just show you the video of putting once you put the guide wire. People, they cut the guide wire. So if you see, this was the PICC catheter cannulation. And in that thought of like doing the procedure, you forget that there is a guide wire also inside in the PICCs. And just exactly, so this is what the guide wire which is already there. So if you see, it is make sure that you remove the guide wire and then cut the catheter and then put whatever the catheter which you need to be inserted and fixed has to be done. So never ever try to cut the guide wire. So what happens if you cut the guide wire? So this is what you see here. You can see the flex which has remained. So 2 or 3 times it has happened. We get a lot of referral patients from outside the hospital. Like cutting the guide wire, and then we are removing through the cardiac catheter. It is important to have a good teamwork. If you're going to put a central line, one thing remember that you should be very friendly to the pediatric cardiologist, because they are going to come help you in a situation when this sort of the complications which arises. So this is what it is. Again, important thing, what sizes catheter? This is a very busy slide. So what our protocol, what we follow is that less than 3 kg, 3 French 6 centimeter, 3 to 15 kg, 4.5 French 6 centimeter, and more than 15 kg, 5.5, 8 centimeter. This is what. So what complications do you see in this one, this X-ray? So the story I will tell you, this was an 8-month-old child. So they did everything with the ultrasound guided. Only he said, I asked to the intensivist that what happened. He said, yeah, I got everything, but then he inserted a very forceful guide wire. And what has happened? It has punctured the vessel and gone into the lung. So this is why it is important. Any resistance in the guide wire, just stop over there and redo the procedure. So that is what is the take-home message. Sometime in the left, if you see on the left side, left IGV, this was a Hickman's catheter insertion. If you see, it has gone into the coronary sinus. It is important whenever you are doing a procedure, has to make sure that post of, if it is under Siam guided, has to be in a proper position. So we'll come to the few cases. I'm going to show what happens if this sort of complications happen. So coming to the femoral vein access, one has to be a very important point has to be taken is that the leg has to be little external rotation and in a neutral position. So I will show you what anatomical changes which happens with the leg positioning. If you see the artery and this is the artery and this is the vein. So override. So if you keep in a good neutral position, then so there are a lot of data which we have. And then what we follow is the neutral position, little external rotation of the leg and keep wide apart. And this is what the neonatal vein cannulation, the blind technique, what we do is, so just keep hand on the femoral artery and the gelco has to be facing towards the umbilicus. That is what the normal. What protocol, what we follow is exactly going into the inguinal crease. This is what it is. Important point, why this slide which is there, the one has to make sure that small as the baby, smaller the gelco has to be used. And then if you want to do the procedure, you can put the guide wire and then you can use a bigger gelcos and then the catheter which can be inserted. So this is how has to be done. So the guide wire which we used was the Terimo wire, which exactly go along the blood flow, and then you make your cannulation successful for the femoral vein canal. So what is the understanding of the cannuloplastic gelco? Why I said is that once you puncture, then exactly it fits into the lumen of the vein, and then you have an ample of time for putting a guide wire or whatever the procedure. If you are not able to pass the guide wire, you can just insert the cannula a little bit ahead. And then, so there are studies, what is that anterior versus double puncture. If you see the anterior, if you are ultrasound guided, so definitely your success rate is much more higher than the double puncture because you take a lot of time. And we have a lot of children with the coac deformities where definitely the complications, hematoma chances are much more high. So let us see the few interesting complication cases where, so this was a 13-year-old child in a periphery decay and cardiac arrest, resuscitation, and then they put out. So what wrong do you see in this X-ray? What was the line put in this? Subclavian. Then, so it was in the subclavian artery. So, so we confirm on a echo. So it was brought to the hospital where, and then you see a severe LV dysfunction on the echo coagulopathy because already patient was in a shock. And then, so we put a femoral catheter once the child was reached to the hospital. So this is what. So if you see a severe LV dysfunction, can see on the echo and then the confirmation. So what is the anatomy of the femoral, subclavian artery? It is exactly chances of exactly if you see in this one is that it passes exactly below the mid clavicular region in the children, and then if the proper positioning is not given, there are chances of much more higher of puncturing the. So this is the video of the supplement. Puncturing the vein is artery is much more high, and then pneumothorax, and then the pneumo can happen in these children. So this is what. So this was a trauma child, 11-year-old child, which was there in the ICU, our ICU. So where it was very extremely difficult to put the IJV cannulation. So this is what we did. So only important point I would like to highlight over here is that guide wire. So guide wire JT has to be always facing on the downward side. If you try to push, put the JT on the upper side, it will go either into the IJV or on the opposite side. So it is important to have a tip to be below this one. If the artery puncture happens, so what we can do? So there is a technique what in our hospital we follow the protocol. So it is an angioseal device. If you see, the complete occlusion can happen. So usually these are the protocols. But I would like to show you directly the video of what we do. Luckily, in our hospital, we didn't had an opportunity to show you the video of angioseal device. So this is what the device. So what you do, pass the guide wire onto the catheter which has been inserted, and then you remove that one, and then immediately you pass this one, the angioseal device, and this is what once you confirm that it is into the artery, because already it is into the artery, and then insert this device. And if you see over here, so this you just switch the button, and this is where you see this is devices. This is a collagen where it fixed, so it occludes the artery. So further off going into complications, because sometimes see what happen, or other methods what we have tried is that smaller gauge of the central line we have put slowly, and then one day we removed from that one. So this is how the newer thing which we follow in our silent future is it's available in 6 and 8 French. Complete absorption of collagen happens in 60 to 90 days, and then the minimum size of vessel what we can do is 4 mm, and suitable for it is not suitable for the common deep arteries, and no major contraindication. It can be done at the bedside procedure. This is what it happens. So next case, this was like 820 gram. I had only done this one, 820 gram baby, and PDA device was done. And then in PICU, NICU, what happened is that we put an PICC catheter. So this was a normal X-ray of the baby. And when we put the PICC catheter, you can see here the catheter which has been happened. So you see a lot of dilatation. What are the if you see a huge effusion has been happened. If you see on the echo, there is a pericardial effusion which has happened only because of the central line, which was like PICC or a central line which has been inserted. So this is hemodynamics in an acute phase. Immediately patient can go into the shock. So patient can go into the shock, and so this is what we need to do. So what we did in this child is that, so there are so many literature. So if you see the literature, the commonest complications, pericardial effusion, which happen is because of only central venous cannulation. So important point, exactly measure the depth at what, at RA SPC junction, you have to keep your catheter. Sometimes if you try to, you can pull and then you can suture, but the chances, what happens if you keep the catheter out, coming out is much more high, or the infection chances are much more better, are there in the putting the cannulas outside. So this was the baby. Then we did a pericardial synthesis in this child and drain, and then baby was like post-op. Once the procedure was done, if you see, this one was, baby was fine. So exactly the thing was done, and then we could save this baby from going into the further the complications of complicated. So this is what, so series of so I was just thinking what complications what we had in our hospital for last 5 years. So this is what age neonate 8 children, and there were 3 referred from outside the hospital. So umbilical line cannulations. This was the embolized catheters, guide wire what embolized. So was 2 central line and the chemo port was from the outside. So this is what, again, we have to take the patients into the PIC, the cath lab, and we need to remove the catheter. So this is what a small simple central line not taken care of properly can lead to this sort of the complications. You can take the patients into the cath lab, and so there are so many cases which I can go on of putting a central the complications with the central line. So finally it is take home message: complications are bound to happen, but you have to learn from each and every complications. They are iatrogenic. Most of the time complications are, so think before doing the procedure, and in case of complications, be very friendly. Should have a team approach, and hardware planning and everything has to be done. And on the right side of the Swami Vivekananda, which has been like rise and awake, and do not stop till you get the success. So all these procedures are important. Try to you learn from the complication. Next time, avoid those complications and then go ahead with better, so that the complications are very minimal. So one has to be very firm and be very clear when you're doing the procedures. And she is here.
I had to arise and awake. Now, Ankit, is there any one take-home message you would like to give to the audience from the central line venous cannulations? That because I know you have done at various different places.
Use of ultrasound is mandatory, especially if you are doing it in very small babies, and follow all the focus guidelines. Now there are focus guidelines for each and every step. So you need to first scan the veins, look for any valves or anything, any anomalies. Then you have to see the guide wire going in. Then you have to see the dilator and the sheath going in.
Yes.
You have to just do an echo and confirm with your agitation test whether your the catheter is in place or not, and also look for complications. Look for complications like pneumothorax. So everything is possible with an ultrasound machine.
In that same sitting, you need
in
not
the same setting you have to can do.
see the car before the manifest. You want to pick up before the manifest. Wonderful. Actually, Dilip really spoke far faster than what he usually does. Otherwise, he's a very patient and speaker who speaks with pauses intertwined. However, I guess I just took that away from him. He was breathless. Like, okay.
I was like what I do when I induce the patient, like, because they know that you have to do it fast. So she was like behind. So like surgeon is sitting, and then luckily Dr. Bagbi is there. So I was like, you need to do it fast.
Ramesh sir. Over to another interesting topic. I know there's a reshuffle going on. You would have expected me to continue here with focus, but I guess focus can wait. He's come extremely intriguing. Another way of learning, I'm sure. And through Ramesh sir, everything makes a point.
Thank you. Right. Okay, can I show the front light? Oh, this will be there, okay. Oh, okay, sorry. Don't need it, I just want to, okay. There are some more slides here. Okay. See, I think, I don't know how to go about this one, and whether we form some team. Then if you form some team, then it will be taking a lot of time. I think the aim is to to learn, and whatever it's not very. I think that Kirti Puri and me supposed to be there. She'll keep on asking me what you're going to do. I told her I myself don't know what I'm going to do. So that's okay. So it's going to be a very educational type of a quiz, which I thought that's a team. I will do that, but what I have planned like this. And before I start, I just want to tell people that Rajkishore Bagdi, I have anesthetized for the last 40 years with him in Chennai, and he's sitting in front of me and just to meet me. It's really a great honor, Dr. Bagdi, who introduced me to pediatric anesthesia. And when I started Apollo, we were and now people in Chennai, they said if you are giving anesthesia to Bagdi, then you can come to anybody else. So that's how I got my pediatric anesthesia. I'm not that because he's sitting there, that is from my heart. So what I'm going to show about this pediatric anesthesia quiz is, I'm just, I don't want all people to, stand up and make a chorus like that. Just put your hand and I'll just ask them questions, but they'll be rewarded with a good, depending upon the number of questions they answer. And the gift is quite, very educative gift. You don't know about it. I'll tell you later. Okay. I just put that as a edu quiz. It is not like, competitive quiz where, you are answering something and you are giving something. Whether it's going to be edu quiz. I just made it as a edu quiz. But what I put, if there's a team, this is a child which this is a warm-up quiz with the people which just warm up. This is a neonate. Actually, I'm not sure that Bagdi is involved with this in child test. There's a child with abdominal distension. Child is very sick with the NEC, some abdominal distension and all these things. We thought some problem, and there was this one, and then we took an X-ray, and then the X-ray showed. Anybody can find out what the X-ray shows? Yeah. Yeah, this is a pneumopetemy. In children, we cannot see air under the diaphragm neonate. It will be this is actually what you see here, a small, like this, will have a gas, or it can be a bowel around that. That's called a football sign might come in that. So it could be, so this is a small pneumo. You cannot have an erect picture in neonate. Can we do? No, you cannot do. Yeah. So it is only supine and lateral as well. This is actually the air. So it means there's a pneumoperitoneum. So we have to open. There's no question about it. We have to open the. So when we open, we found the NG tube perforating the stomach. Okay. So this is want to tell you, this is for last about 45 years, I had 3 cases of NG perforation of the stomach. Because in a small baby, the neonate, the stomach will be very thin. Their sick baby, neonate, NEC or somebody will be there. So if you don't measure properly to an NG tube and put it, you will meet like that. So this is a close-up view of the 3 cases we have done. So NG perforation, be careful. There's hydrogenic, you must measure and then you put it. Don't put a hard one because you want to put a 8 year spread. You put a 6 nicely and then measure it. This is just for the people who are okay. So I thought there will be something with that. One of the candidates must answer. The group answer must be given within the stipulated 10 seconds. Only the first answer will, the stipulated time will be accepted. No change of answer will be allowed. Incomplete answer will not be accepted. The unanswered question will be carried over to the only next team, but no time will be allowed. First team will get 10 marks. That is the team, but I know who are going to answer. I'll put them mark by myself. But there are golden rules in this Mumbai quiz. Okay. The first quiz is that quizmaster decision is final. The second is, if any problem, refer to rule number 1. So I think that is the rule. So if nobody tells me you have done like this, whatever I say, that's right. That's it. Okay. So we'll talk about history. Nothing goes without history, because I think that's very important to the history. I want to ask, who is from KEM? KEM? Pune? I don't want HOD. I want a P. Nobody is overall postgraduate. Fellows. Okay. You are both of you from? East Kandy. Okay. Any 2 fellows anywhere? Huh? My fellows, they said to be biased, so I don't want to do. You are from? Fine, okay. Any other MD final year PGs, pediatric anesthesia fellows? Okay. Science, yours? Which Kandy? Last somebody from MD final year? Okay, I think from Ambani is there with no? Okay, let's be history very important. You just want to ask you this question. That's the one which Vincent has said. Further you look back in history, the better you understand the future. I think it's important to know what has happened before. The first question is to Bridgekandi. This all 99% will be related to pediatric anesthesia. That's the clue I can really tell you. Okay. So this is a person, I think it is, I'm not sure. I don't think we can forget certain people. And one of them is. Anyone put a hand? Not consulted. Anybody? No, I don't want to mumble. If anybody knows, please put out your hand. That's okay. This is actually Philip Iyer. Okay, Philip Iyer is a very important OSDP. She's the one who is 90. OSDP. Okay. Okay. This you may not know, but I can give you a clue. Okay, I can give you the clue because this is actually Professor Appukutti, who is the father of pediatric anesthesia in India. He's now no more. And on the right is Edward Sumner. Now, presently, he was the editor of the, taken about 15 years ago photograph. And he was the editor of the Pediatric Anesthesia. Now, he is passed maybe a couple of years ago. And who is this largest person? He is related to the previous person. Jackson Rees, yes, okay. This is Jackson Rees modification of ocular TP. He is also died because he had larynx over last year. I think all the three are no more, but they are the legends of medical science. Okay. 1957. What? 1957. Don't tell me it was my birth year. Huh? That was my birth year, but that's okay. 1957. Holiday cigar formula changed to holiday 57. Both of them are nephrologists from Howard, and it was put for the pediatrician formula, but anesthetists are taking to do that, so we don't deal with that. So I think this is only for a well-child formula, not for our losses and other things. So this is holiday cigar formula, 1957. I think this is not that I have to ask questions, that things that to remember, but these are all very important moments in the life where you must remember that. That's why it's okay. I think this is a very important to do. I'll give you some pictures often out in there. Yeah, often out. People can do that, but I want this one just see. Okay. Any postgraduate says that they will be given a very good book. I can tell you that. Oddman out. Yes, KM. Anybody? Put out your hand. Put out your hand. God. C. Yeah? This is Macintosh blade. Okay. This is Meggle's circuit. This is Meggle's forceps. This is Meggle's connector. So this is Macintosh laryngoscope. I think they're wearing a blade. So the Macintosh blade is the oddman out. Many people wouldn't have seen Meggle's circuit also nowadays. They wouldn't have seen the Meggle's connector also. Only they will be seeing only the Meggle's forceps. So if anybody asks what is the name, if you say Meggle's, 99% will be right. Because most of them, the Meggle is got Meggle connector, Meggle syringe, anything we have got is okay. This is all Meggle circuit. This is a Macintosh laryngoscope blade. I think that the blade is a different ornament now. So the next I'm going to ask you this question. Okay. Okay, this is from that fellow who is from Cyan. Come. This you must tell. This is nothing to the torr, centimeter per liter per second, kPa, psi, a millimeter mercury. Cyan. 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 AM. Okay, centimeter per second. I think that is that's because it's longer than all other things. No, no. No, tell me why you said that. Yeah, that's all other are very good. Others are pressures and this is a flow. Flow is always with the volume per unit per second. I think that's very important. This is a pressure. I think that's a good. This is a flow. Other measurements, all the pressure. I think that's okay. Centimeter per liter per second. Right. See, I'm not trying to criticize people. I'm not trying to make fault, but I thought I just stimulate the people to just know what is happening. This is the one. Okay. Cyan over the other back at the set. Hemoglobin, sodium, bicarbonate, protein, phosphate. The back, Cyan, okay. KM. No worry, you can see if you all made wrong things, then only we have come up like that. So easy to ask questions, but you may not be able to easy to answer. Tell me. No. Hemoglobin, because sodium, bicarbonate, protein, and phosphate are all buffers, where hemoglobin is not a protein. Hemoglobin is the answer for that. No, sorry. Sodium, yeah, sodium, correct. Okay. But Quizmaster is always right, huh? Okay. Oh, sorry, I couldn't answer, doesn't matter. This is oxygen. tent. I'm not sure whether anybody has seen that. This is a beautiful one which is actually used in a small baby when they are hyperpyrexia. People they are all hypoxia, hyperpyrexia. They're very restless. They put an oxygen tent like that. See, this is oxygen tent and given oxygen. And when you go oxygen tent over it, they get heated up. So you need a bed which cools the child so that the temperature will come down. So this this particular one is a cooler, which is kept underneath that so that the temperature is brought down. Because if you put the tent over it, uncooperative, asthmatic, wheezy child, you want oxygen tent is quite good. People call everything as oxygen tent. Only this is oxygen tent, but the other things are on oxygen, not tent. So give that. Okay, Sayan. What is this mask? Full name? Pardon? Okay, that is non-rebreathing mask. This is non-rebreathing mask because this gives you 100% oxygen. This is the only one on spontaneously you want to give 100% oxygen, you must give only non-rebreathing mask because non-rebreathing mask will have valves both sides and the valve from the back. Partial rebreathing valve will not have this expiratory valve. You will get only 70 to 80%. That's a partial non-rebreathing. When they're expiring, that means the bag will fill up. In a partial rebreathing, it will not fill up. So non-rebreathing gets oxygen not only from the source and also from the bag. So it gives you 100% oxygen. I think if you want spontaneously, you want to give 100% oxygen, the only equipment you can give 100% oxygen is non-rebreathing bag. I think that's how you have to. Okay, coming to oxygen therapy. This is called oxywood. I am not sure how many people have seen this oxywood. There are holes in the oxywood. I know the holes in the oxywood because they have to give some percentage. What they will do is they will close all the holes and they want to give more oxygen. That's not right. Those holes are made for some specific purposes. Okay, what is this and what is this? I think one you can find out. The other maybe. Yeah. Okay. Next. Not oximeter, the oxygen analyzer. Because when you put an oxywood, okay, because when you put oxywood newborn, the temperature of the child will go up. So you don't want to go hyperpyrexia, so you must monitor the this one temperature. The other hole, you put an oxygen analyzer, because when you give oxygen, there's a layering of oxygen happens in the oxywood. So you want exactly how much FiO2 you are giving for that child, you must have oxygen analyzer. That's why the hole is there both sides. You must put that. And the holes are there in the oxywood for specific purposes. That's why the oxygen analyzer will give X-ray and this is the temperature point. There are procedures which you are doing it. I just want to 10 minutes. These are procedures which you are doing it. But in pediatric, any answer? Put your hand up. Hand up. And I want where it can be done in two places in pediatrics. This is trans-elimination. It can be used for intravenous line, and also if you don't need an X-ray to be taken for pneumothorax. If you don't do in the theater, stop all the light in newborn, put in a trans-elimination, you will get a trans-elimination. You can put a drainage. So you don't have to wait in the intra of pneumothorax. Trans-elimination will definitely help with that. Okay. I want this. I think there was a question of intra-operative. What is the procedure? And what is the age limit for the procedure? I'm sure everybody tell what is the procedure. What is the age limit for the procedure? Back rows. What is this procedure? Yeah? Back row, come. Yeah? Intraosseous. What is the age limit for the procedure? About 10 years ago, Paul says you can go up to only 8 years. The present guidance is intraosseous can go even up to the adults as long as you can get into the TBI, into the bone. So there is no age limit for intraosseous. It can be used even in the adults. It's been recommended. So there is no age limit and intraosseous content. Whatever the drugs you are giving intravenously can be given intraosseous, including Cleft. So I think the intraosseous is a very important one. And there is a gun which is available, EZO. Just put it there. If you don't get a gun, you put an 18 gauge needle, just put it there, it's okay. In older people, you need a gun because it's difficult to puncture it. So I think, but there's no limit. The recommendation right now at age limit. Okay, intraosseous, you can go from neonate to adult. That's how it's okay with that. What is this? Manometer. Ah, yes. You are a fellow. You cannot. You are a consultant. No, I'm not. I just want the people to know this is very important. How many people have seen government emergency being done? Anybody? No consultant, but okay. Anybody? This is Bros flow tape. See, a small baby come with a road traffic accident. You don't know the weight. Mother has not come. Somebody is brought to the yard. You don't know the age. You don't know the weight. What are the drops? What is the endotracheal tube size? You just put this Bros flow tape into that, and there are color coding. That particular day, you know, for that height, this is the age, this is the weight, and these are the drugs you can give. All this. This is a Bros flow tape. Just Google and take the beautiful. When the child which does not know what exactly is being put a Bros flow tape, you will get all the doses, everything, height, weight, and all the things has been given in the Bros flow tape. Approximately, it will give you. It will not be this one. I think it's a very good. It should be available in all the emergencies in pediatrics. So it's all the emergency process. Yeah. Any doubt? Must be. Okay. I think that. No, this is a very cheaper one, but very easy if you want to use this one. Is okay. Okay. Close-up images of certain things. It's very close-up images. Okay. I don't want to give very wrong. Can you give exact name for this? What is this? Nasal. Everybody can tell nasal cannula. Can you tell a little more? This is actually used nasal CPAP cannula because you can put it. You can give a CPAP to the nasal. That was come with about 15 years ago. It came. It's a beautiful, soft, and you can give a CPAP through the nasal cannula. This is the nasal CPAP cannula where you can give very effective CPAP to the nasal because newborns are all, the mouth can be closed and you can give an effective CPAP with a nasal cannula. Okay. Anybody? Anybody? Yeah? Go ahead. This is actually Cole's tube. I think Cole's tube is the one which is narrow. When you put it into the, it is a first pediatric one, you put it there, it will exactly fit in the larynx and keep it. It is being used also for that. I'm not sure I have the correct picture, but this is a tube used for TEF. I've given a big name of this tube. Yeah? Huh? It's a replogel tube which is used for the TEF pre-op, so that you put it and suctioning it so that you don't suck the mucosa. Also, you have to suck the upper airway as well as the near the trachea. So you get a replogel tube. It's available in the market, but you can make, this is a new tube. The bigger tube is here. In that, you put a cut and put on a smaller PD tube. That becomes a replogel tube. You yourself can make before this, a pre-op suctioning can be done in the replogel tube. Okay. This is reasoning. Very nice. I don't know how many people can answer this. Mercury is used in the thermometer. Why? Mercury is used in thermometer. Why? Pardon? Anybody? Yeah, that's right. Okay, anybody? I think I don't know what I said. It is the lowest freezing point, -400, and the highest boiling point. None of them have got that. So if it's low, it's high, it can go to end number one. Number two, this is the only liquid which is visible, where you can see a visible one, we can do that. Third is its cohesiveness. It expands and comes back. So it doesn't stick to the glass which is being there. I think mercury is a very important answer because it has got a less cohesiveness, low freezing point, high boiling point, and it is visible. So that's why the mercury is used in the thermometer. I am not sure whether these people have observed this. There is initially Boyle's apparatus had nitrous oxide cylinder. Then Mark 3, Mark 4, he said, why you want the nitrous oxide cylinder? So they removed the nitrous oxide flow meter because you don't need it. But again, nitrous oxide, the modern has a pressure gauge. Why? Only PGs can tell that. See, nitrous oxide, if you put the pressure gauge, it will be the same till the empty. So they said it's of no use. But still, why you have to put a pressure gauge in nitrous oxide? Because at least we know when start coming, that means it's getting empty. So I think the modern nitrous oxide got a pressure gauge being there. Pulse oximeter shows spurious reading with carboxymeter and how much? This is for KEF. With carboxyhemoglobin, how much it will show? Wait. Tell me exactly. Sayan? Poor girl, Sayan. Anybody? Put your hand and get up. No problem. Wrong. It's okay. No, it's not yet. It will show 100%. Please remember, see carboxyhemoglobin because 100%, because the hemoglobin will be saturated by 4 molecules by the carboxyhemoglobin, it will show as an 100%. So I think where it methemoglobinemia will show 85%, whereas carboxyhemoglobin will show 100%. So if there is a smoker and she is 100%, don't think it is 100%. It can be carboxyhemoglobin. So it is because it doesn't tell you exactly what they're doing. The hemoglobin is okay with that. I think looking at the chart, I'll just now go into the clinical one. Okay, let us go to the clinical one. These are beautiful flowers, but let us not go. Let us go to clinical, then I'll finalize. Okay. This is very important. I like because this is a very important clinically. Okay. Oh God. Okay. We'll go to syndromes. Very nice. Okay, syndrome. I'll do 2 more this one because it's okay. Please remember the question. Okay. I want the answer for this and what is the any associated in the problem for anesthetist. This please remember why I given a clue normal hand. Please remember, please I given a clue. This is a child with normal hand. Or Ambani hospital there. Ambani, this group, 5-6 people are there. Kokila Ambani, yeah, tell me. This is not very high, Panda. Yeah? This is Cruzon. See, Cruzon is 11 exophthalmos, which is this. Along with that cranial stenosis, you can see this is being pushed out with the exophthalmos. And this one with the hands are syndactyly, then it becomes upward syndrome. Okay, so that's why I put that with a normal, this cranial stenosis with exoptosis with the normal hands, it is a Cruzon. If it has got a syndactyly, then it becomes an upward syndrome. I think that's why I put a normal hands with that. That's okay. So it is associated with intracranial hypertension. I think that's why you must be very careful with this intracranial hypertension. Okay, this is the child. What is this? What is this syndrome? And what is the pathology in this syndrome? Yeah? Huh? Who is this? Goldrash? 50%, I get that. Yeah, anybody? Yeah, Treacher Collins. I think this is a Treacher Collins syndrome, hypomandibular, and because of the Treacher Collins syndrome, it is a maxillary hypoplasia, whereas Peri-Robin, it is a mandibular hypoplasia. So when the Treacher Collins grows up, the mandibular becomes very prominent, difficult to intubate. Whereas Peri-Robin, the mandible becomes bigger and easier to intubate. So when the Treacher Collins grows up, easier to intubate. Whereas Peri-Robin, when Treacher grows up, it is difficult to intubate. Whereas Peri-Robin grows up, it's easier to intubate. That's why in a cleft palate, the Peri-Robin, please prolong as much as possible, 18 months or 20 months, so that mandible is little more easier and then it's okay. This. Yeah, who said prune belly? Yeah. So what is this problem for anesthesia? What is this problem? When you say a prune belly, what is the problem? Immediately you think of something else. That is their problem. You see, yeah, it's okay. I think this is prune belly is associated with the renal failure. You must do an ultrasound and use RFT done before you taking a prune belly. Because prune belly will be associated most of the time with the renal failure. So be careful with the prune belly coming for anesthesia. Identify the neonatal condition. This is the last 4 questions and then I'm going to stop. Identify the neonatal condition. Okay. And what is this? Identify the neonatal condition and tell me as an anesthetist what you are looking for, what you are worried about. Yeah? I don't know how to answer, but it's okay. Any questions? Anything? See, this is meconium ileus. Okay, the meconium is one is obstructed, abdominal distension. You can see a thick meconium coming out. You have to wash it with the acetylcysteine or something like that. You have to do everything. But please remember, when there is a meconium ileus, you must think of cystic fibrosis. This is a very important because meconium ileus, you do operation, everything is all right. The child will be on a ventilator, very difficult to wean off. So it's not just simple to take it off. It could be also, you must counsel the parent that it could be a cystic fibrosis. You must do that. That's why I'm just okay with that. This is a child. I know what this child is. Don't tell me the diagnosis. What is the syndrome associated with this particular anomaly, and what are the components of this particular syndrome? When you get example major, immediately think of some syndrome. Then what are the components of this syndrome? Tell me. Anybody? Just put a hand. This is associated with Beckwith-Whitman syndrome. Whenever there's an example major, please think of a Beckwith-Whitman syndrome because it may have microcephaly, hypoglycemia, and macroglasia. So you must have sugar problems, you have intubation problems, post-op, and think of that because this is only clinically anomalies is being all these things. Okay. So that is example, and this is gastroscopy. There's only two emergency neonate which have to be taken immediately. One is malrotation because that will become valveless and do it. Second is gastroschisis where you keep it for longer time, it will be infected. So if it is gastroschisis or malrotation, you must go to the operating room immediately. Nothing is urgent or emergency. It can wait. I think this is okay. So what is the significance of gastroschisis for anesthetist? Yeah? It needs very high volume fluids. 300 ml per kilo you might need is okay. It is not that during intra-op, post-op also because they're already outside for a very long time, you need a very high volume of fluid. Think of that, which is okay with that. So, I think that's fine. I think it is okay. I will left some more questions for the next class. Okay. I'll come with those if you don't. Thank you so much. I just is okay with it. Book is a book, I don't know. I got some books. What I am trying now, I thinking is, I'll tell one more, I'm giving one book to all the cost consultants now. Yeah. Let's wait for some time. Yeah, please.
How is the day going?
I'll give.
Oh, yes, of course. Yes. Yes, sure. Lovely.
This is Frank Shan drug dosage book, which I think is a very, I'm sure she will be thorough with that, but still I don't mind giving it. Okay. It comes every year, but 2017 is after that, 2019, after it has not come out, but still it is a good book. You can always, sorry. Dr. Dilip? Dr. Dilip? Dr. Ankit? Kiran? Dr. Kiran? Yeah. Anuya? Who are there? No. Yeah. Okay. Nigarika, okay. I'll kill one to Dr. Bhakti. Yeah. Okay. So good. I think I'll give two to KM because they were very. Come. Okay. Good. I want to Sayan. Every time I'm talking to Sayan, come. All the best. The best. Okay, sir. Okay.
Wonderful. Okay. So the last lecture of the day, do I hear a sigh of relief? Well, so we look at ultrasound in children, and we just answer one question. Is all you probably have heard from Amrita and Ankit a number of times since morning about POCUS. So what is this POCUS all about? And there is no way we are going to complete POCUS in 15 minutes. And this is just a brief glimpse into it, only to see what it holds in it. How can we open ourselves to POCUS? And is it really bogus after all? Let's see. Let's analyze each thing. Let's reflect on it. Okay, what we are going to do is we are going to plan it. We are going to look at airway. We are going to look at lung. We are going to look at gastric, and we are going to look a bit at cardiac POCUS. I shouldn't have made Dr. Ponde go home. We could have extracted things from him. Never mind. And just about any potential that ultrasound in your hand might help. So each of them, we would look at in a very systematic manner. We will look at the equipment, we will look at the normal findings, the abnormal findings, and the clinical implications. Otherwise, all this makes no just any sense. So point of care is something like this. Hence, we call it POCUS. So that's how the short form nickname comes. And there is something very important about POCUS. It's not just point of care. It gives you a poignant answer, a binary one in the form of yes and no. And hence POCUS becomes so important in the operation theater, if at all. Let's look at the airway, a very beautiful one. And also now, let's look at this part. The cone is something that always makes us wonder. That is what we call as nature's cuff, as it were, because that's the most narrowest part. And that's always the controversy that moves in our minds when it comes to cuff tubes. However, it needs to be remembered and used very carefully. So coming to diameters, that's how it will be helped. Come to airway, whether 100 kilogram baby, adolescent, or a 1 kilogram, the probe has to be linear. Coming to different scans, we can have a longitudinal scan and we can have a transverse scan. Let's start with the longitudinal scan because there's more to show in longitudinal scans. And once you grasp that, it's easier to go to the transverse scans as well. So first, let's begin. Imagine that this is the entire airway until the trachea in the sagittal plane. In other words, longitudinal. Have this in your mind and extrapolate it here. So this would be the scan, and this would be the cephalad end, and that's the quadad end, and that's how we start. So what would be shown to you first would be the thyroid cartilage, followed by a cricoid cartilage. Since these are cartilages, they're going to give you an anechoic or a hypoechoic shadow. In between the two is the most spoken about CTM, that is the cricothyroid membrane, which we are so eager to put a needle in when we have difficult airways. So this is what we're talking about. And see, it's not that easy to pick up in a very, very small baby. We need to do repeated scannings to understand the exact point where it needs to be. But then mark the word repeated. So if you have an ultrasound next to you, don't forget to pick it up and just put it around on the neck of the child when you're intubating, after intubating, or if the child is under general anesthesia, to play with this machine. Having said this, let me go to all these 4 things that have come up are actually the tracheal rings. The white line underneath is the air mucosal interface. So this is what is shown in the longitudinal section. Now coming to the transverse section. Transverse section would be, suppose it can be started right from the mentum, the submentum, then the hyoid, and then the thyroid, the cricoid, and the tracheal rings. However, let me just get you straight to the vocal cords because in 15 minutes, I need to give you the glimpse. So what it can be is, this is where do you think is the section taken? Anybody? Thyroid cartilage. So this is again skin and subcutaneous tissue. That's orientation marker doesn't matter. We are in the midline. These are the strap muscles, and this is the thyroid cartilage, and here would be the vocal cords. So V is always followed by V. So says a person whose name starts from V. So this is how we can remember. So this is a scan, and it can really help us to see what are the clinical implications finally, whether the cord movements are good. Coming down a little more, and then we would see that the transverse section at the subglottic area, and we can actually measure the diameter, predict the size. Once we predict the size, whether cuffed or uncuffed, the external diameter has to be that much. So that serves a lot of direction in choosing the cuff that we wish to choose. Now coming to what other signs? Suppose if we have a feeding tube and we're not too sure whether where we are going with it, and sir just said that we actually can get perforations with this. We can see this here, follow it to the gastric antrum, and you can actually see the NG tube really walking in. So that's the NG tube looking at you. Now coming to esophageal intubations. In the morning, we thought of neonatal intubations. Can I sell this idea to you in a minute this way? Okay, how do we best know that we are in the trachea? Number 1, ETCO2. Number 2, chest rise. Number 3, breath sounds. How much time does it take? If ETCO2 is right there, you're going to look at it. If you want to see the chest rise, you're going to look at the neonate. Of course, the feel of the bag, an educated hand is going to tell you this. How much time will it take? And how much time will this take if somebody else is just putting, because somebody else is going to stand and give some pressure here and there. What if they just put a probe and we see this? And how much time did this take? Because this is, I'm waiting for the tube to come over. So, but when the tube is right in the esophagus, you will see a double trachea sign. You don't need to wait for the ETCO2. We don't need to wait for an auscultation, neither the chest rise. And this is a very sure shot sign. So I guess this is how we can answer whether the tube is in the esophagus or no, or whether it is an endotracheal intubation or have we missed it? Yes or no, simple. More on the right side, more on the left side, nothing of that kind. In or no, yes or no. That's what POCUS is all about. Coming to ET tube, where it should be. So you will see this kind of a movement, and the air mucosal linings will start appearing as two, as if there are two, but actually the one underneath is the endotracheal tube. And what happens during the extubation? I'm just proving it to you that the two don't look two anymore. They start looking as one. So you just, the one line disappears underneath and it appears as finally a single air mucosal line. So that's how, well, extubation is not that important because you pull the tube out anyway, but this is just to tell you how an impression of a endotracheal tube inside is like. Is the tube in the esophagus? Is the tube in the trachea? Are the vocal cord movements symmetrical? So these are the yes or no questions. POCUS can definitely help you. Ponder on this. Now coming to lung. Lung is very beautiful. Lung POCUS is nothing but a wonderful play of artifacts in the lung. You're going to see what? Some bones. And then you're going to see what? Some lung. And the bones are going to give you shadows. And in between the two shadows are going to be windows. And through the windows, you're going to see the lung. And then the lung is going to tell, through again artifacts, the story of what it is all about, isn't it? So now let's read what it says. And it's wonderful how we can decipher lung. Where all we can actually study lung through the equipments that I'm showing you. These are the different zones that we can see. Most of the times, our children are going to be sleeping. Anyways, so these are the different zones and we can turn them and see what we want to see. Now here is our certain normal findings. We can see the chest wall. We can see one rib and the shadow of it. And another rib would have been here. And this is the pleura. In between the two shadows of the rib and this is the lung. That's the movement. Now this is a smaller baby, so we can see more. So 2 ribs, the shadow of the rib, the window here, and that's the pleura and the movements of the lungs. Clear? Very simple. And you can see the A lines, they are all parallel. These are reverberations, artifacts of the pleura, and they're normal because it's full of lung. So one artifact is telling us that the lung is normal, A lines, transverse. Now let's come to something else. Can you see the rainfall here? Can you see the rainfall a bit here and here? So let's see what's happening here. These are B lines. These are the lines that we wouldn't like to see. However, if they are few, then accept them. They're good. They don't harm. But if there are many, some machines can give you certain index of what is normal, what is abnormal. Okay. So these are B lines. Very easy to understand. These are B lines. So you can say drizzle of the rain. You can say intermediate rain, and then you can say a thunderstorm. So anything intermediate and above would not be really a good scene. And what would it tell you? A lot of fluid in the lung or the interstitium of the lung. And secondly, the recruitment maneuvers are helping or no. Of course, hepatization of the lung would also help you. In other words, the lung is going to look like liver. The name suggests. So this is something advanced, the hepatization and then the removal of it, or the progress of it towards normality, something advanced. But this is something that you can really look at. Coming to pleural effusion. And this has helped me even help my surgeons to look at pleural effusion and to see whether it's really been aspirated but what is the position of the ICD. So this is one pleural effusion. Again, very easy to take in because it's fluid. Fluid is anechoic. If anything anechoic about the pleura is pleural effusion. So this is pleural effusion. You can see the fibrous striae as well. So again, now this is pneumothorax. This is something like, okay, there is a sea, there is a shore. The lung parenchyma has many homogeneous things, or other heterogeneous things. And then these are like straight lines. The straight lines are pleura, and these things actually is the lung tissue. So when you get a pneumothorax, you see that the sea has invaded the sand. In other words, you have the barcode sign coming right here. So that's a pneumothorax. Again, go ahead, see the lung sliding, which you saw in the lung, which was dynamic a while ago. Lung point becomes very, very, very diagnostic, extremely specific. At one point, there is absent lung sign. And from that onwards, you see that the lung is still sliding. Why do you want to know all this? First, why is the kid desaturating? It can help that. And are the lung recruitment maneuvers really effective? A 4 hours case can also cause atelectasis. A 2 hours case can also cause atelectasis. So keep it in mind. But of course, in ICU, there are definitely different implications. Now coming to cardiac focus, again, a glimpse of it. There is no way we can go in the depths of this focus at all. What can you answer yourself? Is the contractility normal? That tells a lot. Is there any pericardial effusion? You have seen that in the IJV videos as well. Are we in an systole? Is there an air embolism or any kind of pulmonary embolism? So let's look at certain images and see what we can understand in the most simple manners that we could. This is the probe that we can use for kids as well as adults. A linear phased array square footprint transducer of 1 to 5 is what we usually use. Now this is an apical view. You can see the left ventricle and the left atrium. Good contractility. We can calculate on the machines, but for an anesthesiologist, eyeballing is good enough. The walls are coming towards each other, not a little bit of bulging out there. Fine, good contractility. That's all you need to know as an anesthesiologist till somebody else comes. Again, an apical view, and this is a 3-chamber apical view. Now let's go ahead with other apical views. 4-chamber apical view, and this is a 3D. Forget the 3D. This was just to give you a 3D impression of what it would be. So contractility. Do nothing more with this. Contractility is good. Ejection fraction should be good. Inferior vena cava. We are not replacing anybody. Basic focus. Inferior vena cava, quick assessment of volume status. If we see the inferior vena cava really moving well with the respiration, but at the same time, the walls not collapsing too much. A lot of calculations can be done here. It is a workshop. It is an entire workshop. I'm just going to give you what can be done. Now, a rigid one which is going towards the right atrium. It just tells you that the pressures there are very high, and hence it's a rigid one. Any cause that creates that kind of a pressure is a rigid IVC. So think about that. Now, pericardial diffusion. Look at this. You can see a strip of fluid here. You can see a strip of fluid here. So these are pericardial effusions. Can be quickly seen even after an IJV is cannulated, especially when a guide wire is put in and you have gotten a run of arrhythmias. Well, finish your procedure and do this. It doesn't take more than half a minute. Air embolism. Well, we'll see. God, watch here. That's the right side. It would be pretty unmistakable. This is a pulmonary embolism. Look at this part of the ventricle, and it's actually the right ventricle is looking as big as the left. Can you see that? This is how the pulmonary embolism would behave. What can we rule out? Yes or no? Is there hypovolemia? Pulse not well felt? Is there a cardiac activity? Simple. In pediatrics, you now. I think we're talking about aspiration contents. Maybe worth know what focus was understanding this. Look at equipment you need, usually a probe. Phase one is so, another is right. Now let's see how to use this pattern. Get the pattern. It's very clear from the anterior to the posterior, skin and subcutaneous tissue, the rectus muscles, the liver on one side, the bowel on another, the antrum, and look at the antrum. Get the anatomy of the antrum extremely clear. There is always a hypoechoic or anechoic border around the antrum, and a closed antrum is going to show you the mucosal folds almost touching. The lips are almost touching to each other. So this is a closed antrum, and here is pancreas, and you can see the superior mesenteric artery and the aorta. This is the dynamic scan for you to see. So that's the story of a empty gastric antrum in supine. We need to turn the child to get the real, if there is something hiding here and there, and it manifests when we turn the child. Coming to how do you grade it? Coming to that. So grade is empty, none, no contents, small amount of hypoechoic content maybe. And mind you, in both the positions, especially the lateral one. Clear fluids, it's going to look hypoechoic. Solid, heterogeneous, particulate, mixed with air, because we would have chewed and taken a lot of air along. And milk suspension, hyperechoic again. So what do we do with this information? Is fasting adequate, especially if the history is we need to go ahead and do the induction. So this is what it open to you, and this is just coming to being very off record. You can use wherever you think you can put on. So a day where we had a fixator in the lower extremity, the tibia, the femur, in fact, and the limb really went very pale. So we did a scan here, and you can see the pulsatility. You can see the pulsatility in the abnormal and normal part as well. On this side, actually, I should have put a Doppler and that image or that dynamic for you, but see that this particular thing. That too, because the child is trying to just, try to move the operated extremity because there is intense pain, because the epidural is stopped, because we are suspecting here a compartment syndrome. Actually, there is a stunned popliteal artery, and we took the child to CT, but CT obviously gave a lot of artifacts to us because there are metals. Then the DSL lab was then extracted. And meanwhile, of course, the epidural was reinitiated to get benefit of howling in pain is extremely bad. And it's really a myth to feel that our pain relief can actually mar it unless we make the extremity dead by extreme motor blockages. So this is what focus is all about. This is a tip of iceberg. All my job was to just show you what is possible with a probe in your hand. And, with that, I think I thank you all very much to be here. And I guess we can declare this. I can see this almost the same number of people that they were in the morning, where they are still here. And I couldn't have more glad. Thank you so much for being here. Thank you. Thank you. And this thanks is on behalf of the entire children's anesthesia team and for every faculty that have come here and every delegate. I have no, how should I say, there cannot be better words to put than this, that education can never go one way. There has to be taker, there has to be a giver, and the roles are extremely interchangeable. Extremely interchangeable. We gain a lot by talking to you, and I hope you gain a lot by listening to us. Thank you.
My number.